fracture session, I request Dr. Chandrasekhar and Dr. Ram Subba Reddy to be the panelists for this program. Now, the first talk is given by me, which is interpretation of X-rays and CT scans in acetabular fractures. We all know the elementary fractures described by Jude and Litornel of posterior wall, posterior column, anterior wall, anterior column, and the transverse fracture. These are the elementary fractures. And then you have associated fractures of different varieties. So, how do X-rays and CT scans help us in identifying these fractures? So, when we take a radiographic evaluation, the first is an anteroposterior view of the pelvis, and special views like Jude views like iliac oblique and obturator oblique are taken. Radiographs help us to classify the fracture, to know whether there is a displacement, and a fracture pattern describes the approach. So, AP radiographs will show us, in addition, pelvic ring injuries, whether there are bilateral acetabular fractures, femoral head fractures, fracture displacement, and to check congruency of the hip in acetabular fractures. So, learn to draw the lines on the AP view. So this is an important X-ray and an important slide. In addition, pelvic ring injuries, whether there are bilateral acetabular column. The ilioischial line indicates the posterior column. The radiographic U or teardrop usually indicates the anterior column. The roof of the acetabulum indicates both anterior and posterior column. The anterior rim indicates the anterior wall, and the posterior rim indicates the posterior wall. So, when you take an AP radiograph, you draw the ilioinguinal line, which will give you the anterior column, and draw the ilioischial line, it indicates the posterior column. Similarly, when you draw the radiographic teardrop or the U drop, this indicates the anterior column. Again, in the AP view, the acetabular roof indicates the weight-bearing area of the acetabulum, which indicates both the anterior and posterior column. Jude oblique views, which were pioneered by Jude and Litornel, are 45-degree oblique radiographs. They basically show the columns and walls. So an obturator oblique shows both the anterior column and a posterior wall. The iliac oblique shows the posterior column and the anterior wall. The roof arc measurement was described by Joel Mata. So it is a line drawn between the center of the head through the fracture site. And this roof arc indicates whether you should operate or not operate. So for example, if you take a patient like this, who has got a fracture like this, in the AP view or obturator view or the iliac view, when you draw the roof angle, it's coming to around 50 degree. That means it has not got displaced further. So all the three views are showing an angle more than 45 degrees. So this case was treated conservatively. Next is going to CT scan. A CT shows whether there is acetabular fractures, whether there are intra-articular elements, whether there is marginal impaction, and what is the joint congruity. The 2D CT shows whether there is a column fracture or a transverse fracture, or whether there is an anterior wall fracture or a posterior wall fracture. A 2D CT shows it in a different view. Similarly, a three-dimensional CT shows a 360-degree view of the pelvis and acetabulum. So let us go to a few cases and just see how drawing of the lines helps us to identify the fracture. Now, this is a case with a posteriorly dislocated hip. So let us see drawing the lines. See, that is the ilioinguinal line. The anterior column is intact. This is the ilioischial line. The posterior column is intact. This is the teardrop. So the anterior column is again intact. Now that is the anterior wall, which is intact. That is, the roof of the acetabulum is intact. Now this is the posterior wall which is broken, and that is a part of the posterior wall or the posterior lip. No problem. No problem. I request all the delegates to take the seats in the chair, please. So this is the posterior lip of the acetabulum. So this is basically a posterior wall fracture looking at the X-ray. Now when you go to a CT, it shows you the posterior wall fracture. And when you do a 3D CT, it shows it to you clearly. So that is basically the posterior lip fracture. Now this case number 2. Now in this case, you see that the ilioischial line is broken and there is a posterior column fracture. When you take a CT, you see the posterior column fracture both in the 2D as well as in the 3D. Now case 3. Now in this case, an injury like this, let's just draw the line. See, that's the ilioinguinal line. Anterior column looks intact. That is your posterior column, ilioischial line. That is the roof of the acetabulum. There is again your posterior wall. And that is the teardrop. But you see one piece coming from the anterior part. So take different views, the iliac oblique view and other views, which gives you a indication that there is a piece coming from the anterior part. So that is an anterior lip fracture, which is very, very uncommon. So which is best seen in the iliac oblique view. When you take a CT or a 3D, you see it much clearer, which shows you the anterior lip fracture from different angles. So that is your anterior lip fracture. Similarly, the next case, an injury like this. Let us draw the lines and see what's happening. So you have on the normal side, the ilioinguinal line intact, but on the affected side, it is broken. So the anterior column is broken. Then you have the teardrop and posterior column, which is intact. That is the roof of the acetabulum, which is also intact. Now this is the pubis and this is the posterior column, which is intact in the iliac oblique view. This is the anterior column, which is broken. So this is a classic anterior column fracture. Similarly, when you can have two types. You have a low anterior column or you may have a high anterior column fracture. So usually the lower anterior column where the pubis separates from the ilium. You can also have a high anterior column fracture going in like this when you take a CT and 3D CT. Okay. Now in the next case, you have a fracture like this. So let's draw the line. That is the ilium and that is your roof which is involved. This is your pubis and ischium. So you see the line is going transverse. So this looks more like a transverse fracture. This is a transverse fracture. So this is the ilium and posterior column. This is your pubis and anterior column. Similarly, you see that the roof is intact. So this is more a juxtatextal transverse fracture in this fashion. Right. So in the next case, an injury like this. So that is your ilium when you draw the lines. But the weight-bearing dome is attached to the ilium. So that differentiates it between a bicolumnar fracture and a fracture which is a T-type fracture. So this is your ischium, right? That is your pubis. So when you draw it on the bone, it is in this fashion. It's a T-shaped fracture, right? So you see it in this fashion. You have the ilium, pubis and ischium. And when you draw the line, it goes like this. The fracture line goes like that. And similarly, in the 3D view, you see a T-shaped fracture, right? And the last case is a bicolumnar fracture, where both anterior column and posterior column both are fractured. So it goes like this. The differentiation is basically the roof of the acetabulum is separate. That's why we call it a bicolumnar fracture. So an injury like this, when you draw the features, see the roof of the acetabulum is broken and it is gone as a separate piece with the ilium. So that becomes a bicolumnar fracture in that patient. So this is how a bicolumnar fracture can be. So looking at all this, you can decide and have a take-home message. Basically, draw the line on the X-ray, draw the line on the bone. Know which line corresponds to which column. And we have seen different lines corresponding to different columns. Check the roof arc angle. So this helps you to classify the fracture. It helps you to know whether there is how much displacement. And next is it helps you to decide which approach to take. So thank you very much for giving me this opportunity. Now I request Professor CHRISTOPH to start with his talk.
What about the questions? You are taking the questions at the end?
Later.
Okay.
Yeah, thank you.
So I request Dr. Uday Kumar to take his seat as the panelist, and Chandrasekhar sir will take over.
So after fracture acetabulum, now my role is telling about the fracture pelvis and sacral fractures. See, this pelvis fracture, I know the experience because I am practicing this orthopedics since 35 years. I know two parts of the practice when we were PG and early practice and when you are a senior consultant. I know how difficult to treat the pelvis fracture and how our teachers and seniors were treating this fracture. Because these fractures or complex fracture and high morbidity and mortality, and especially they are associated with the vascular and the neurological genitourinary complications, they used to treat very badly and patient used to land up in problems. And management just require exposure and experience. So ordinary, just general orthopedic surgeon never used to treat these pelvis fractures. Before 1980, I was talking about that. It was poorly understood biomechanics. That is why the conservative management, all the pelvis fracture, they used to manage conservatively. I got the experience when I was PG. We used to put them on the traction for months together, and patient finally will have deformities and limping. And outcome was definitely, it was used to be poor. Now at present, because of we understood the anatomy and classification and better techniques to treat, and we are now started surgically managing, and results are good. Before we go for this pelvic fracture management, we have to understand the little anatomy, because it's a basic things. I have to tell little anatomy about this. Anteriorly, pubic rami join together, they form pubic symphysis, and posteriorly, sacrum and ilium join, they form SI joint. This SI joint has got many ligaments: sacroiliac, sacrotuberous, sacrospinous, iliacolumbar. These are the ligaments which are responsible for stability of the pelvis. If these ligaments get injured, this causes rotational and vertical instability, especially sacrotuberous ligament, which is the one which is responsible for rotational instability. If this ligament injured, that causes the rotational instability. I told already, sacrotuberous is is ligaments responsible for rotational stability, and all other ligaments are responsible for vertical stability. After classification, we have to classify the sacral fracture. Very simple. They take the reference, sacral foramen as a reference. The fracture which is lateral to the sacral foramen or zone 1 fracture, where fracture goes through the sacral foramen or zone 2, and medially there falls under the zone 3. And one more classification, or the fracture pelvis is by tiles. Otherwise, it is AO classification. They are all stable fractures, and they are type A fractures. Type A1 is avulsion fracture, type A2 is fracture iliac wing, and type A3 is sacrocoxae fracture. These fractures are very stable fractures. They are all, we treat conservatively. That doesn't require very surgical management. Type B, actually vertically stable. These are all the fractures, both type B or C, we treat surgically. Vertically stable and rotationally unstable. So rotational unstable fracture, I told, sacrotuberous ligament injury, that causes the rotation instability fracture. So type 1, again they subdivided type 1, B, B2, B21, 2, 2, 3. B1 is open book injury, external rotational injury. Lateral compression, B2, it is interrotation injury. And B21 is ipsilateral, anterior, it is a one-side fracture. Both anterior and posterior is injuries on one side. Contralateral, one side is anterior, other side is posterior. And bilateral, both anterior and posterior are both sides. It is some example, open book fracture where the fractures are the book. They opened like a book. It's called open book fracture. Ipsilateral injury is type 2B21. Type C is a still complicated fractures, requires surgical management. They are both vertically and rotationally unstable fracture. Whereas B1, vertically stable, rotationally unstable. Here both vertically and rotationally unstable. Type C1 is unilateral. C1 is iliac fracture. C12 is sacroiliac fracture dislocation. Type C13 is sacral fractures. Remembering these two little difficult, but whenever you classify, you have to refer and classify the fracture, plan accordingly. C2 is bilateral. One side is B type, other side is type C. That is, vertically one side is stable, other side is unstable, and rotationally both sides unstable. Bilateral, both sides vertically, rotationally unstable, very bad injuries. This is typical type C fracture. Mechanism injury, any mechanism can cause, commonly road traffic accident, fall from height, and high velocity injuries. Problems. Say pelvis fracture, we face deglowing injury is the commonest problem, and vessels and viscera. Many patients that die because of the injury to vessels, and they bleed and they die. And some patients will have injury to viscera also. And because of the injury to vessels, they lose the blood loss and hypertension. And major blood loss is from small vessels from the fracture site. Everybody think fracture pelvis, the patient die because of the injury to major vessel. It is not so. Major vessels injury always in 10% of the cases. Investigation routinely APU X-ray, but that is not sufficient in pelvis fracture. We take two special X-rays, caudal and cranial. But caudal X-ray, cranial X-ray nowadays we are not doing because of the CT scan. After the AP, we ask them for CT X-rays. We get the information, whatever we get from these X-rays. Actually, these X-rays are useful during our surgeries on the table because we cannot do the CT on the table. So, caudal X-ray, tilt the X-ray 45 degree headwards and take the X-ray and you demonstrate rotational displacement. And cephalic view, we demonstrate vertical displacement. So it is all during the surgery we do these X-rays. I told CT scan before surgery is the must. Every small nursing homes will have CT. You should do the CT and classify the fracture and manage accordingly. Management. First, you have to manage bleeding and shock. So, when patient comes to casualty, you check for the pulse and the BP. If patient is in shock, you treat the shock. Either by fluid replacement or blood replacement. That is a common, everybody will do that in the casualty. Patient, even if you transfuse the blood and the fluids, patient will be unstable. Then check for CT and abdominal injuries. And if there is any such things, CT or abdominal injuries, you refer the patient to chest surgeon or abdominal surgeon to manage such cases. If it is normal, then think of external fixator in the casualty. After fixing the external fixator, if patient if you find him unstable, then you proceed with the angiogram to find out the major blood vessel damage and proceed according to the injury. So there are two types of external fixator, clamp and regularly what we are fixing with the fin external fixator. The clamp is ideal. Commonly we are not using that. It is a AO clamp. No, we don't have in our hospital, but the external fixator is the commonly we use the external fixator in our institute. This is the clamp available. And this is the external fixator. I think everybody got the experience putting in the casualty. Even external fixator can be used as a definitive way of management, but success rate is not good. We get only 60% of the result. So indications, we go for in abdominal injuries and soft tissue problems, and relative indications only in type B fracture, but reduction maintained only 60% of the fracture. So we don't get 100% reduction with the external fixator. Treatment of the fracture. We'll come to the treatment of the fracture, particular fracture. Type A, always I told conservative, there is no need of surgery for type A fracture. Type B, that is vertically unstable, vertically stable, rotational unstable, requires anterior stabilization by external fixator or plate fixation. So posterior is not required in type B fracture where vertically unstable, rotational unstable fracture. So this is if you fix it anteriorly by plating, that is enough for such cases. Then type C fracture. This is where to go a little bit elaborately. Requires both anterior and posterior fixation. So anterior, already I told, any pubic symphysis diastasis, we have to fix it with plate. Posterior fixation. So posterior fixation, I don't know how many of us in this group got the experience of posterior fixation. That is why nowadays, within 10-15 years, we started fixing posteriorly. Earlier, we never used to treat all cases, we used to treat conservatively. There are so many methods of fixing posteriorly. SI plating, iliac rod fixation, tension band plating, and iliac sacral screw fixation. Except tension band plating, I got all the experience of 3 procedures. We started fixing about just 15 years back. And now we are sticking to ilosacral fixation. We are routinely doing in our institute. Anterior SS plating, SI plating has got some advantages. We can directly see the fracture and there is no radiation or no easy procedure. Just open the fracture, reduce the fracture, fix it with the plate. That is the regular fixing like any fracture. But disadvantage, there may be some gluteal injury to gluteal artery and L4 nerve root and lumbar flexus. So this is one of the examples. This is what we fixed it. This is the diagrammatic representation. We fixed this fracture. Transiliac rod. That is the next method. They are fixing these fractures. Easy, no injury to vessel. Just put the patient posteriorly, expose either crest and put the rod across. And no radiation for this. Disadvantage is difficult to maintain the fracture. It has got many disadvantages, but easy, difficult to maintain the reduction, and over compression may cause neurological injury. This is the best example, diagrammatic representation. And this is tension band plating. This I don't have experience. We got it from the literature. So this is also one of the method of fixing posteriorly. Now, the posterior sacroiliac screw, this is the one, I think it is easy. If you people follow this method, easy to do this and very good for the patient. And I think nowadays many of us are practicing this. Advantage, anatomical reduction of the fracture and with minimally invasive procedure. So, before doing this procedure, I tell about the procedure for everybody's benefit. Before doing this procedure, we have to, on the lateral view, normal sacral has to be as an inclination called ala slope. That we have to find out. From it runs from proximal posterior to distal anterior. This is the one we have to find out to do this procedure. Otherwise, I will tell why this is important. Next slide. This is the one which is we have to identify in a lateral position. Otherwise, we land up in either damaging the nerve or neurovascular structure there. Very important. See there, anterior to this ala slope lies the L5 root and iliac vessels. So this is the one point you have to identify. If you don't identify this point, we'll land up in problem damaging these structures. Safe zone. What is safe zone? The anterior boundary is anticortex of the slope and posterior boundary is S1 root. This is the one in between these two is the point where you have to enter into the SI joint. So just see there, that is the anterior slope. The one with yellow line is the one you have to go enter into the bone. So take through a lateral X-ray, identify the ala slope. The point just below the ala slope is the entry point. Procedure. This is one example X-ray. This is we have done in our hospital. in the supine position, some people do in prone position, some people do in supine position, we do in supine position. And you have put it in the first you use the Steelman pin and point. I show that the point where you have to enter, just point there and tap it. I use the Steelman pen, don't use the drill, I tap it so that you will have a control, just tap it. And this is the lateral view, inlet view, outlet view. All the three views are enough for this. Should take all the three views before entering into the bone. Once Steelman pin is inside, you made the hole and take it out, pass the guide wire. Just you pass the guide wire and you can see all the guide wire pass, and then you put the screw along the guide wire. So guide wire is going in, inlet view, outlet view, lateral view. So after the procedure, take the X-ray because you have to see whether it is in the position or not. So in this, you can see all the screw is in position. These are some clinical photos. See, it is routinely done in our hospital, done by everybody, every surgeon. Because we started practice this 10 years, everybody picked up this procedure, doing. I don't know in other institute they are doing or not, but we are doing in our institute. For SI fractures, this is the procedure really routinely doing this in our hospital. There are some, how you manage post-operatively. Sit on the bed or wheelchair the next day. You don't allow them to weight bear. Non-weight bearing walking once patient is comfortable. Partial weight bearing walking gradually from 4 to 6 weeks and full weight bearing after 12 weeks. So some examples. So these are all some examples. This is to show. This is one lady doing good. The one more case. This is another case. So complications, there are some complications, definitely. See, any procedure, there are some complications. So injury to L5S1 root, so far luckily we don't have any such complication right now. And vessels also, injury to cardiac vena, malpositioning of the screw, that is very commonly we see, malpositioning of the screw. And backing out of the screw. Sometimes once patient walking, screw backing, start backing out. So we have to repeat this, or once a fracture is united, we can take it out. And it requires some long learning curve. To do this, to start this, we had a pelvis and screw. We almost 2-3 weeks practiced in the OT, really. So then we started doing this. Conclusion. Treatment always used to be conservative and results were poor earlier. I think all seniors agree this. Even Rajendra knows how you are treating this pelvis fracture. Even when you were doing PG student, everybody were putting on the extraction and putting on the bed. Used to wait for 2-3 months. So there was no surgery for this fractures. And now it is really good techniques, procedures, managed surgical results are good. If done properly, leads to complications like injury to vessels. If you avoid injury to nerve and vessels, take correct precaution. It's a really wonderful procedure. Thank you.
Thank you, Dr.
Thanks to Chandrasekhar sir for that detailed presentation.
Procedure.
Next, we have a virtual presentation by Professor Michael Wagner. Is there a role for conservative management of acetabular fractures in the year 2021? Professor Wagner, if you can please share your screen and proceed with the presentation.
Yes, I try, but you do not accept my screen. something?
Yeah, you can try again, Professor.
Okay, now we have it. Okay. At first, I have to thank the organizers for putting me on the panel. It's a great honor to be again in India. But it does not work. Now, is it state of the art to do a conservative treatment in the year 2021? In our service, the conservative treatment is very rare in acetabular fractures. Now, if you make a conservative treatment, you have to keep in mind that you have a difficult mobilization of the patient. You have a long period of non-weight bearing, and if you have a late displacement of the fragments, surgery is very difficult. And I think there is a difference between Germany and India. About 50% of our patients are geriatric patients. And if you look a little bit closer to the literature, there are not very many papers showing you good results of conservative treatment. And of course, in the beginning, you have to evaluate your acetabular fractures, as you can see it here. So nobody would think about doing a conservative treatment in such a fracture. You have to reconstruct your acetabulum. In the beginning, you do reduction and keep it on traction just to stabilize the patient, and then you have to do a good pre-operative planning. You have to look for the indication for surgery, check for instability. Is there a fragment interposition? And if you have more than 2 millimeter displacement, you have to do osteosynthesis. Even if this looks quite nicely in a plain pelvis X-ray view, you should not do a conservative treatment here. The aim of your treatment is anatomic reconstruction and, of course, the restoration of the articular surface. Now, if you look again to the old literature, there were only a few with patients who were very old, but this has changed in our country dramatically. So this is a typical view of a German trauma ward. A lot of very old patients, and of course they have to be mobilized, and they should not stay very long in bed rest. But keep in mind that some of these reconstructions are major surgery, and the surgery should not be more dangerous than the trauma. And sometimes we also have in these patients a lot of soft tissue problems. Here you see an unstable fracture, and the soft tissue is even the more difficult problem. Now, if you look again to the latest literature, there is not so much published about the conservative treatment. A paper from the Czech journal, they showed quite good results with a conservative treatment if there were fractures with only little displacement or no displacement. But these cases are very rare in a normal trauma service. There is another interesting paper coming from a major German trauma center. It was published last year, and they compared the conservative treatment of minimally displaced acetabular fractures to the conservative treatment, and they could show that the conservative treatment shows you almost the same result as the minimally invasive surgery, but you need only no displacement or minimal displacement. So again, very rare cases in most services. And also keep a little bit in mind that you can easily have a lot of thromboembolic complications. An old paper published in the JBJS many years ago, and they showed 33% of thrombus in conservatively treated acetabular fractures. So be careful. Now, in conclusion, the indication for conservative treatment of acetabular fractures is very, very rare, especially in the European countries. Only in undisplaced or minimally displaced fractures you can think about it. If patients are in bad shape or if they have very poor osteoporotic bone stock, you also can think about a conservative treatment. But I think now our osteosynthesis tools are so good and we have learned newer techniques, so our results have become better. Our complication rate in surgical procedures is quite low. So almost everybody can get the surgery. And if you treat them conservatively, think about the difficult mobilization. You always have the risk of pneumonia and thromboembolic complications. So I think in the year 2021, there is almost no indication for conservative treatment in acetabular fractures, except if there is almost no displacement and no instability. But these cases are very rare. So I thank you for your attention.
Thank you, Professor Wagner, for that insight. Next, we have a presentation by Professor Paul ROMMENS on ilioinguinal approaches for open reduction and internal fixation of acetabular fractures. Professor ROMMENS, you can start your presentation.
I will do that. Can you see my presentation?
Give it some time, probably it will come.
Can you see my presentation?
Yes, we can see your desktop. You can start your presentation, Professor.
So, good morning. Here it is still morning. Good afternoon to India. It's a pleasure to be with you again, although not face to face, but online. It's a pleasure for me to teach you today about the ilioinguinal approach for open reduction and internal fixation of acetabular fractures. As you heard from Michael Wagner, we are facing more and more old people. Yes.
Sorry to interrupt.
Yes, I hear you.
Click on the presentation so that we can see it.
see it where I...
Professor, you can close and try
The
again.
one down, which says ROMMENS, Boscon.
Okay, we try again.
Yeah, we can try again, yeah.
Can you see my presentation?
Yes, Professor, you can do a full screen, please.
Yes, Professor, we can.
Okay, you see it now?
Yes, Professor. Got it. You can go ahead.
And you see, can I, yeah, you
We
see
can.
if, okay. And you hear me as well. So again, it's a pleasure to be with you for this Bangalore Orthopedic Society to teach you about the ilioinguinal approach for open reduction and internal fixation of acetabular fractures. Mr. Letournel used this approach in about 50% of his cases. And as Michael Wagner said, we are confronted with more and more old patients in our hospitals in Germany. So patients with acetabular fractures mostly have anterior column and anterior wall fractures, sometimes combined with posterior hemitransverse. So the importance of the ilioinguinal approach in our hands has even grown since the time of Letournel. In my hands, I would say I use this approach in about 3/4 of the cases that come to the University Hospital in Mainz. So this approach, in my view, is the most anatomical approach to the acetabulum. It allows a direct access to the inner part of the iliac wing through the lateral window and the inner part of the small pelvis through the second window. I will show you. But it is not an easy approach because we have to isolate the iliac vessels. We see the femoral and the obturator nerves, and we have to take care not to damage them. And we can damage as well the lymphatics, which may be at the end dangerous complications for the patient. The indications for the ilioinguinal approach are fractures that are situated in the anterior part of the acetabulum, the anterior wall fractures, the anterior column fractures, combined with a posterior hemitransverse, some both column fractures as well, and some types of transverse fractures where the most displacement is situated anteriorly. I will now just describe the approach, and we will have the chance in the case presentation to see one of the patients. So we start in a midline incision, 2 finger breadths above the symphysis. A curved incision goes to the anterior superior iliac spine, and then we follow this iliac crest 2/3 posteriorly. As you see here, this is the supine position. This is the right acetabulum, and the incision is marked in red. First of all, we will release the periosteum together with the abdominal attachments and the musculus iliacus from the iliac crest. So that means that we first will expose the internal iliac fossa as far deep as the sacroiliac joint and the iliac brim. This is the first window of the ilioinguinal approach. Here in this drawing, you see the iliac crest, you see the iliac fossa on the inside, and mobilized the abdominal muscles together with the iliacus, mobilized towards medially, and in the depth of the wound, you may see the anterior sacroiliac ligaments. The second window is then prepared, and you see here the red line, which is situated about at the inguinal ligament. We will first incise the aponeurosis of the external oblique muscle in line with its fibers. We will unroof the inguinal canal, isolate the spermatic cord and the ilioinguinal nerve, and perform then below the external aponeurosis. We see a second layer, and this is the inguinal ligament where the internal oblique abdominal muscle attach. this is incised longitudinally. That means that the inguinal ligament is taken into two parts, one superior part and one inferior part. And you see the knife, and you see the superior and inferior part of the inguinal ligament, and on the medial side, the spermatic cord as well. What are the structures below the inguinal ligament that we are confronted with when we split this ligament? On the lateral side, very near to the anterior superior iliac spine, we have the lateral femoral cutaneal nerve. It is not a vital nerve, but if you damage this nerve, the patient may have pain on the upper lateral side of the thigh, or even a numbness. And he's confronted with that for the rest of his life. So we should take care not to damage this nerve. We are also confronted with the femoral nerve, which is embedded in the muscle belly of the iliopsoas muscle. Between the muscle and the vessels, we have the iliopectineal fascia that separates the lacuna vasorum on the medial side from the lacuna musculorum on the lateral side. And we have to dissect this iliopectineal fascia to be able to enter in the small pelvis. Medially from this fascia, we see the external iliac vessels and the lymphatics. And here you see a drawing where you can identify the inguinal ligament above, and below the inguinal ligament on the lateral side, the iliopsoas muscle together with the femoralis nerve. And on the medial side, you see the artery, the vein, and the lymphatics. We will sharp incise this iliopectineal fascia towards the pectineal eminence, which is the bone, and then detach this fascia from the pelvic brim in the direction of the sacroiliac joint. That's what you see here. You see that on the lateral side, the first window, there is a towel in the lateral window. Then my finger, or the finger in the drawing, is just at the level of the iliopectineal fascia, and the scissors start to cut this fascia in the direction of the iliopectineal eminence. And you see here in live the medial side with the Langenbeck retractor, the vessels, on the lateral side also with the Langenbeck retractor, the muscle, and between where you see my scissors is the iliopectineal fascia. And this fascia will be cut down and then dissected along the pelvic brim. You see that here, so that we have a direct entry now into the small pelvis. So we can enter from the large pelvis into the small pelvis and vice versa. And this is very important because we will there see the most important part of the acetabular fracture, which is situated at the quadrilateral surface. Medial to the vessels, we will have the third window, which is the most medial window. And this is the window where you will find the pubic bone, the symphysis pubis, and behind it the bladder. So it's the retiopubic space. We should take caution of the corona mortis, which is an anastomosis between the obturator vessels and the epigastric vessels, and this can bleed severely. Therefore, it's named the corona mortis. So we can identify this vessel and also ligate it if it is in our way. So we will work for the reduction and fixation through 3 windows. The first window is situated laterally, the internal iliac fossa, the anterior sacroiliac joint, and the pelvic brim. The second window is medial to the muscle and lateral to the vessels. And you will see the pelvic brim and deeper inside the quadrilateral surface towards the posterior column. And the third window is the retropubic space with the superior pubic ramus, the symphysis pubis as well. Here you see a drawing of these 3 windows, and we will work through these windows to reduce and fix our fracture. You see, this is an anatomical approach. We will not cut any of the structures. We will just mobilize them and reinsert them after the fixation of the fracture. This is the second window, as I said, and this is the third window medial to the vessels. The wound closure is done very carefully after rinsing and debridement. Redone drains in every window, that's what we do. Complete closure of the floor and the roof of the inguinal canal, and reattachment of the abdominal muscles to the iliac crest. This is very important, also without damaging the lateral cutaneous femoral nerve, which is there. I just give you at the end of my first talk some tips and tricks for this ilioinguinal approach. First of all, use the full exposure of the ilioinguinal approach. So that means you have to dissect deeply, and so that you can see really also the quadrilateral surface and identify where the course of the fracture is. Sometimes if you do not cut the iliopectineal fascia, you will not be able to enter and see the fracture which goes to the posterior column. So you have the impression to have reduced and fixed the fracture when you only look at the anterior column, but you miss the posterior column. And this is a very nice example for it. This is a complex fracture. It's a both column fracture. There was 7 hours of operation. And if you look at the right X-ray, then you see that the posterior column was not reduced at all. So it's not a satisfactory result because the surgeon did not explore the second window and identify the posterior column displacement. Tip 2 is start the reduction at the most proximal part of the fracture. If there is a step or a gap in the proximal part of the fracture, there also will be a step or a gap in the acetabulum itself. So you should start with a very careful reduction proximally and then work from proximal to distal. Every step at the crest will result in the same step at the articular cartilage, so we should not allow that. Third, reduce the anterior column first because you have a direct view on it. You can very nicely reduce these big fracture lines under direct view and fix them with a plate without placing screws in the posterior column at the first time. So first of all, you should reduce the anterior column. You see different steps there, and in red you can still see that the posterior column is not reduced at this time. Personally, I like to use this asymmetrical clamp for the reduction of the posterior column. This has 2 legs, a short leg and a long leg, this clamp, and the short leg is put lateral to the iliac bone, and the long leg is placed in the small pelvis to the quadrilateral surface, and then with compression of this screw, of this clamp, you can reduce the quadrilateral surface towards laterally and reduce the posterior column. That's the placement of this asymmetrical clamp on the inside. You should make a small incision on the outside, just below the anterior superior iliac spine, to allow the short leg of the clamp to enter very near to the bone. And that's the X-ray in the AP view, and in the ALA view, where the placement of these different legs of the screws of the clamp are. And this is the obturator view. A last tip is use the longest possible screws possible. So that means use the longest possible bone trajectories for your screws, and every screw must fit to obtain a maximum stability. You should try to have a good holding power of every screw. And if you look here at this bone model, in the in the oblique view, operator oblique view, then you see that the screws that go through the plate in the direction of the posterior column can have until 80, even 100 millimeter of length. This is a very long trajectory and giving you a good bone stability after reduction. Certainly, this is even more important if you operate in older people. So as a conclusion, the ilioinguinal approach is, in my view, the most anatomical approach to the acetabulum. You don't cut any structure, you mobilize the structures, you work through 3 different surgical windows, but you do not have a direct view on the acetabular cavity, so you have to rely on landmarks for your reduction and fixation. The fractures of the anterior wall and the anterior column are the best fractures for reduction through the ilioinguinal approach, be they solitary or in combination with a posterior hemitransverse fracture. If you are familiar with this approach, you can learn that, I think, with the experts, you can obtain a high degree of excellent and satisfactory results if adequate surgical technique is used. Thank you very much for your attention.
Thank you, Professor ROMMENS, for your experience on the ilioinguinal approach. Now we'll have a talk by Professor Michael Wagner again on how do I treat posterior wall and posterior column fractures. While Professor is setting up, refreshments and lunch is served. So delegates who would wish to have the lunch and refreshments can go have it. Professor Wagner?
Yes, I can hear
Are you
you.
ready with the presentation?
Yes, I'm ready with the presentation. Now, again, I have the easy part of the procedures. How do I treat the posterior wall and posterior column fractures? A little bit of my experience. Now, let's start with the classification. Here you see a posterior wall defect, and this is a posterior column defect. So be careful, don't mix them up. If you're more familiar with the AO classification, you can see it here, the posterior rim and the posterior column fracture. So as everybody knows, these fractures are not so difficult to treat, but of course you have to treat them properly. Now, you have to select your approach, as we have nicely heard from Professor ROMMENS. The ilioinguinal approach is, I think, also the best approach for the acetabulum, and also in our services, it's the most frequent approach for osteosynthesis of acetabular fractures. But you have to think, where is the principal pathology of the fracture? Is the posterior wall fractured? Is it dislocated? Do we need a direct view into the joint? And can the reduction and the fixation be done through a single approach? And do we need anterior and dorsal exposure of the fracture for reduction? So today we have a lot of tools to evaluate our fractures and also to think about where we can place our implants before surgery. So this preoperative planning makes life much easier as before. So we know before surgery where we have to place our screws. Now, the choice for the surgical approach with the posterior column and rim fractures is easy. Therefore, we use the dorsal approach, which is a very old approach to the hip. It was described by Kocher and Langenbeck. Here you can see it. Now, the plate is already in place. You see the femoral head. So keep in mind that you always check the nerve, which is very close to the posterior rim. Sometimes there is some damage of the nerve, maybe by the dislocated femoral head. Sometimes there is a little bit of hematoma around. So we all know that there can be also a palsy of the sciatic nerve, which was generated by the trauma. And again, here you see a typical case, a posterior rim fracture. Don't treat it conservatively. This ends up with an unstable joint and an early osteoarthritis. So you have to operate on. And here you see a typical result with a posterior plate. Now, the dorsal approach gives you, in these fractures, the best access and overview over the outer surface of the innominate bone. You have the opportunity for inspection of the joint if it is really necessary. Be careful not to damage the blood supply of the femoral head. And it's also in easy fractures possible to have a palpatory control of fracture lines of the anterior column if this is necessary. And also today we have possibilities with intraoperatively done computed tomography. So this also can help us a little bit. And if you have good facilities in your institution, also do the CAT scan not only before surgery, but also after surgery. Check your implants, evaluate the quality of your reduction and osteosynthesis, and if it is necessary, revise them early. Don't wait until screws have scratched your femoral head, because this will end in early osteoarthritis. So, in conclusion, posterior wall and column fractures are the easy to treat acetabular fractures compared to the fractures of the anterior column or the transverse fractures. In these posterior wall and column fractures, the Kocher-Langenbeck approach is the standard approach. And in all these fractures, do a real perfect preoperative planning. Think before surgery and don't think so much at surgery. Do your surgery, and if you have done a good preoperative planning, your surgery becomes much easier. If you use this Kocher-Langenbeck approach, always check for the sciatic nerve. It can be injured by the fracture. Probably you can damage it at the reduction that the nerve is in the fracture gap. So be careful. And always do a stable osteosynthesis to prevent a posterior dislocation of the joint. If you do a single screw fixation of the posterior rim fracture, this is normally not enough. This will lead in many cases again to instability. And always evaluate your postoperative results very carefully. Check them, and if there is not a very good osteosynthesis or reduction, revise them early. And be a little bit careful with minimal invasive surgery. Here you see a very recent example showing you an early indication for total joint replacement. So again, I thank you for your attention.
Thank you, Professor Wagner, for your detailed presentation. Now we have two case presentations. The first one is by Professor Paul Rommens. Professor, are you ready with your presentation? Professor Rommens?
So please unmute. Please unmute. So kindly open your presentation.
So, can you hear me now?
We can hear you.
We can hear
can't
you,
see your
sir.
slides, though.
Can you see that?
Yeah, we can see it. All good.
It's all good now? Yeah.
Yeah.
Excuse me for the short delay. So, good morning and good afternoon again. I've talked about the ilioinguinal approach a few minutes ago. So, I would like to show you a case which we can discuss together, because perhaps there are other solutions for this patient. But this is a case that represents what we see more and more in our hospitals. This is the acetabular fracture in patients that are somewhat older. So this is a 68-year-old man after an alcoholic fall. You see an AP view and an ALA view. I would say in the AP view, you see the medial displacement of the head. You see the interruption of the ilioinguinal and the ilioischial line. And you see also an interruption of the roof of the acetabulum that goes medially and upwards together with the femoral head. On the other side, you see the intact acetabulum as a kind of comparison. You see here the obturator view together with the AP view. And again, you see the displacement of the femoral head, this upside displacement of parts of the anterior column. You see a fracture line that goes into the obturator foramen and a fracture line down in the inferior pubic ramus. So now we see a CT scan. It's an axial CT and a coronal CT scan, where you can see that there is a horizontal part of the fracture. This is this line. And then there is a vertical part of the fracture, which is this line with the displacement medially of the quadrilateral surface together with the head that is not centralized under the roof anymore. And in the coronal CT, you see this fracture at 3 levels of the anterior column with the displacement towards medially and upwards. So this is a 68-year-old man. He's not very healthy anymore. You see the bone quality is, I would say, not optimal as well. There is perhaps a kind of osteoporosis because of disuse. So my questions to you are, we go quickly through it. What is your classification of this fracture? How would you treat this fracture? Certainly you have not only to look at the fracture, but also at the patient. If you treat the patient operatively, what is your positioning and the approach to the acetabulum? So we have just analyzed the fracture itself. And in my view, it is an anterior column and posterior hemitransverse fracture. You could always also say it's an anterior column fracture only, with a big part of the quadrilateral surface being broken out. but I think the posterior hemitransverse fracture, there are also good arguments for that. This is a typical fracture pattern that we see more and more in these older people that fall on the side. So the direction of the femoral neck and the head is going towards anterior and medially, and that's the reason this type of fractures occur after this type of fall. The treatment that we have chosen is an open reduction and internal fixation. Perhaps some of you would say, okay, this is an older patient. I prefer to do a total hip endoprosthesis, but you should realize that to obtain a stable cup in this broken acetabulum may be very challenging, and there may be a chance of early loosening of the cup if you do not perform an osteosynthesis of the acetabulum as well. In our view, this is a good indication for an ilioinguinal approach. So we will perform a supine position for this surgery. And as I said, we choose the ilioinguinal approach. Some of you may say, okay, we can use a stopper approach, which is a medial approach to the acetabulum. You just see the internal aspect of the acetabulum through the small pelvis, and then you are able to put on the medial side some implants as well. But I am more familiar, and I think there are some arguments for the ilioinguinal approach, especially if the fracture also goes more towards proximal and reaches the iliac wing. That's the postoperative pelvis, AP and ALA view. And you see that we managed to reduce this fracture relatively well. We have one smaller plate, a 5-hole plate, to reduce a fracture displacement in the iliac wing. And then we have a second plate that goes over the pelvic brim from the pubic symphysis towards the sacroiliac joint. And you see this is a plate that has two planes. There is a plate on the pelvic brim, and there is a second part of the plate that is perpendicular to it and goes from anterior to posterior along the quadrilateral surface. You can see that in the ALA view very well, and that prevents that the quadrilateral surface during a postoperative weight bearing dislocates again in the medial direction, and then that your reduction is loosened. So you see here an AP view and an obturator view, where you can see we also use very long screws. As I said in my talk, the longest trajectories possible. A screw that we use very frequently is this screw below the acetabular cavity, but lateral of the obturator foramen, this infraacetabular screw that can have a length of up to 100 millimeter and has a very good hold in the posterior column. Certainly, you have to make sure that it does not enter the joint or it does not enter the obturator foramen just there where the obturator nerve is going through. I would like to draw your attention to two recent publications of my service. Here you see a publication in International Orthopedics where we just proved that open reduction and internal fixation of patients of old age is possible if there are no serious comorbidities, and especially if there are no game changers. What do I mean with game changer? That are situations that you can analyze in the preoperative X-rays and the CT scan, just as severe subchondral impaction, comminution of the fracture, and a intra-articular fracture fragments. These are negative predictors for a good outcome, and in these patients you may think to perform a primary total hip prosthesis first. And another publication of just 6 months ago shows you the value of this medial buttress plate, of the medial buttressing of the quadrilateral surface, where we have performed about 48 patients with this technique. And we have seen that in comparison to other series where this plate was not used, that we had less patients needing a secondary total hip prosthesis afterwards. So 13.5% within 3 years of follow-up only, which is less than about 25% in the other literature. So I think there is a place for the ilioinguinal approach of acetabular fractures in patients of older age, if there are no negative predictors. And there is also a value for this special medial buttressing plate to prevent medial displacement of the quadrilateral surface plate after your fixation, so that it is not destroying your surgical result. Thank you very much for your attention.
Thank you, Professor Rommens, for your case presentation. We have the second case, the last of the one for the acetabular session, by Professor Wagner, case number 2. Professor, if you're ready, you can go ahead.
Professor, please unmute.
Okay. Now I will continue. Wait a moment.
Sure.
Sure.
Crazy computer. Okay. Now, my case presentation.
Professor, your screen share has not been done.
Yes. Wait. Now, here we have it. Yes. Now, my case, again, an acetabular fracture, a very old male patient.
Professor, sorry, your screen share has still not been done.
Okay, sorry about that.
Can you share a screen again, Professor Wagner?
Yes, wait, I will share the screen again. Sorry about that.
No worries.
Oh, stupid computer. Does it work?
It's working. It's working, yes.
Okay, now, an 87-year-old male patient, a fall at home. He's quite active. He has some growing pain in the right hip since half a year. He is suffering from diabetes, and he has a heart and kidney insufficiency. Now, we normally also try to do an osteosynthesis, because as you have seen in the last case from Professor Rommens, these cases very often are not a good indication for total hip replacement, because placement of the cup in an unstable acetabulum is very risky. It will lead to early loosening. You need major implants. But in this case, I think you should consider doing not an osteosynthesis. There is, I think, no indication for a conservative treatment. Open reduction and internal fixation in an osteoarthritic hip is probably not the best. If you do a simple joint replacement, I think you end up with an early complication, because you will not get a proper fit of your acetabular component. So in our hands, a combined procedure of total hip replacement and osteosynthesis is not so bad. Here you can see it, what we have done. We did a reinforcement cage and a posterior plating, which gives you, I think, in my experience, quite a good stability. It is, from the surgical point of view, not very difficult because of the reduction. If you have got some stability at the posterior rim, is not so important. You have a femoral head for bone grafting. You can fill up the gap, as you can see it here. That's a case with quite a big gap, but they normally heal properly. But I think in all these cases, you need a posterior plating. Maybe in this case, the plate is too short. I think you have to go a little bit more distally, but this cup survived. Now, this gives you immediate stability. There is some tricky point. This is the entry of the inferior flange of the cage into the ischium. It can be difficult because you have to do the posterior AO reconstruction plate first. And then it's difficult to insert the inferior flange in the vicinity of the screws in the ischium. The femoral head is an excellent bone graft, and normally these cases can have immediate full weight bearing. But I think you should keep this only for elderly patients. I think it's not a very good solution for young and active patients. If you look in the current literature, the results of this technique are not so bad. And I think we are facing more and more of these problems. And if you combine osteosynthesis with total hip replacement, it's not so difficult. And in some cases, you can avoid the ilioinguinal approach, which is for joint replacement surgery, who is not trained to use the ilioinguinal approach, maybe a little bit too difficult, especially the most medial window, number 3. So since we are facing more and more of these problems, probably the combined technique is a good alternative. So again, I thank you for your attention.
WAGNER, good morning.
Hello.
Hello.
Prof. WAGNER, are you there?
Pardon?
Hello.
Yeah.
Prof. WAGNER, you said that every patient of fracture acetabulum nowadays undergoes surgery.
Yes.
What are your complication rates?
Now, since we are in a service who does a lot of acetabular fractures, our complication rate is not very high because many of our senior surgeons are very well trained doing osteosynthesis in acetabular fractures. And probably many of us love it to do pelvic osteosynthesis. I'm not sure, but I think if you do it, probably the results are not so bad. And in our country, the patients are only for a very short period in the hospital. and they should be at home very early, and they have to be without any nursing and so on because it's so expensive. So we try to have the patients very quickly, very active, whenever it is possible. So we do much more surgery than we did 15 or 20 years before.
In percentage terms, could you specify?
In percentage?
Yeah.
We do 90% or 95% surgical procedures. Conservative treatment is very, very rare.
And amongst them, what is the complication rate in percentage terms?
Now, we have a very little infection rate. Of course, we have some problems in the very osteoporotic patients when we see an early loosening of single screws, for instance, if there is not a very good fit in soft bone. But the complication rate, I think, is less than 20%. Of course, we see quite a number of patients who get later total hip replacement. I would assume it's around 20% in the first 2 years.
Thank you, Professor.
Thank you. Thank you, Professor.
So thanks, Professor. Thank you for virtually seeing you. Hopefully, we will catch up with you sometime.
Thank you.
Thank you.
Thank
Professor.
you.
We'll go with the next session.
See you.
That is BOS oration. Srimati Sureka Rajendra Kokale Memorial BOS oration. The topic for the oration is my experience with intertrochanteric fractures by Dr. SHIVASHANKAR B, who is the current president of Indian Orthopedic Association. Professor Paul Rommens and Professor Michael Wagner, thank you for joining.
Yeah, with pleasure. I hope to see you all again live, but not online.
Yeah, thank you very much.
Thank you.
Bye-bye.
Bye-bye.
Dr. Madan, Dr. Avinash, Dr. Srinivas Reddy, and Dr. Rajendra Kivi, to please come to the stage. Dr. SHIVASHANKAR, are you ready? You can share your screen.
Yeah, I'm ready. Let the chairpersons take the seat.
Yeah.
Good afternoon, Rajgopalan sir.
Yeah, SHIVASHANKAR, welcome.
Thank you.
Dr. Rajendra here. Welcome.
Yes, thank you. Thank you, sir.
It's a great honor to have you, sir. Great honor to have you, SHIVASHANKar, to having accepted this oration.
Thank you, sir. Rajendra, should I start?
Please, sir. Go ahead, sir.
Okay, fine.
Floor is yours for half an hour.
Yeah, thank you. Respected chairpersons and my dear friend Dr. Rajendra, I'm happy to have been invited to deliver this prestigious oration of the Bangalore Orthopedic Society, and usually invited to be delivered by an eminent orthopedic surgeon. As I know, in the past, this oration has been delivered by many eminent orthopedic surgeons like Professor Shantaram Shetty, past IO President, Dr. Rajiv Naik, past IO President, Dr. John Mukhopadhyay, a senior consultant orthopedic surgeon from Patna. I'm happy to continue this legacy and to have been invited to deliver this prestigious Bangalore Orthopedic Society's Sureka Rajendra Kokle Memorial Oration. I happen to know Dr. K.V. Rajendra well from a long time, and his contribution to Bangalore Orthopedic Society, Karnataka Orthopedic Association, as well as Indian Orthopedic Association. He was the past president of Karnataka Orthopedic Association, and many prestigious positions he has held in IOA. Recently, during the Corona time, he did a lot of bargaining for procuring face masks and face shield, which were distributed through IOA. I am very thankful to him for the work he did. As I know, BORS Oration is a popular program, and I'm happy to know it goes in the memory of my friend's late wife, Srimati Sureka Rajendra Kokale. Incidentally, Srimati Sureka is from my place, that is Sholapur, and I happen to know the whole family very well. I would have loved to be physically present in Bangalore to give this oration, but because of the COVID restriction, I'm giving this oration virtually. The topic I have selected for this prestigious Bangalore Orthopedic Society's Dr. Sureka Rajendra Kokle Memorial Oration is My Journey of 3 Decades with Intertrochanteric Fractures. And just to give my background, I did my MBBS from KMC Hubli, nowadays KIMS, and through All India entrance, I came to Sholapur, and through Government Medical College Solapur, that is Dr. VM Medical College, I did my MS in orthopedics. During my MS, both the units were headed by full-time private practitioners. They were working as honorary professors. One was Professor Dr. VM Iyer, past president of Bangalore Orthopedic Society, also founder president of the NAILS, and another unit was headed by Dr. KP Daga. All of you will be knowing Dr. Daga for his D-nail fame. Why I am talking about this? Because both the professors were full-time practitioners. The whole unit was managed by residents. During the first house post, we used to get in the first initial 6 months only cutting work like radius ulnar nailing, tibia nailing, and femur nailing. In the second house post, we used to do duet nail for intertrochanteric fracture. In the second year, we used to get chance to operate independently. Osteoprosthesis, Richards, sliding hip screw, etc. In the third year, as a resident, I have done major surgeries, including pelvis and acetabulum and spine. Duet was government supply implant, but that was always in short supply. There are a lot of SP nail plates available, which was procured by the department many years earlier. And if we had to do Richards plate, then we had to prescribe it to the patient, and it used to cost about 250 rupees at that time. So as there was a lot of SP nail plate available in the department, many a time we started using this. SP nail plate is a 2-piece implant. So the plate was little thinner. So we used to use a McLaughlin plate where it was little thicker. Again, it works similarly like a SP nail plate. Only thing, it had few serrations here, as you can see, and locking between the nail and the plate was little better. So you could, after passing the SP nail into the head and neck, we could fix any of the barrel plate at an angle, whatever it was required, from 120 degree to 140 degree, we were able to fix it in just one plate. A bit about the X-ray, how it was taken. So before the CM era, which started in India somewhere in the late 80s, so we used to shoot the X-ray in the film, then develop, then fix, then dry. It used to take about 10 to 15 minutes to get an X-ray developed and ready to be seen. So while doing surgery, we used to put 1 or 2 KYs, and we used to take an X-ray, and it used to take about half an hour for the X-ray to come back to the OT. And if the best position the guide wire was placed, we used to select that and hammer the SP nail plate or the duet nail plate. One of the OT, we were not having the X-ray facility, that is usually on Monday or Tuesday for 2 different units. What we used to do was, we extended the lateral incision into a Watson-Jones incision, and we used to feel the neck, and just blindly we used to pass the spinal plate by feeling the neck anteriorly, medially, inferiorly, and superiorly. And 90% of the time, the spinal plate used to be in good position, but we have done that because of the number of cases we had to, in the caseload was too much in a government hospital. That was the reason why we had to do. Thanks to COVID, I was going through a lot of my collection. I have over 7,000 slides taken in 5 years between 93 to 97, 93 to 98, you can see. So you can see here, one of the subtrochanteric fracture where I have used a spinal plate. Friends, that was the time, even developing a slide was also not available in Sholapur. You can see, I had to go to Bombay and get it developed, these slides. Another case where I have used a spinal plate, again, it went into, again, a problem because of the separation of the nail from the plate, as you can see. That was one of the problem with the spinal plate. Another case used a spinal plate. This is bent because this was a thinner plate which was not very robust. So disengagement of the nail and the plate and bending of the plate was very common. So a one-piece implant like a Jewett nail became more popular at that time. So Jewett nail was a one-piece implant, and it was little more difficult to pass compared to a spinal plate, as you have to, your angle of the guide wire has to be very proper. So this we are using as a senior resident. The first year resident used to do a spinal plate, but as a senior second year resident used to do the Jewett nail plate. And this Jewett nail plate was very good for a stable fracture, but when it came to an unstable fracture, again, there was penetration, superior cutting through all those problems we have faced a lot in that. So the sliding hip screw became very popular, where the fixation within the head along with the screw slides within the barrel of the plate to allow continuous contact. So this sliding hip screw brought by Richards company became popular as the Richards hip screw or the Richards DHS everywhere. I have used this extensively between 1994 to 2004 or 2005 before I fully graduated over to intramedullary nail. Friends, you all know my involvement with interlocking nailing and conducting along with Dr. Iyer so many workshops across India in the late 90s, from Chandigarh in north to Coimbatore in south, Silchar in east to Sidhpur in west. During one of my visits to Vishakhapatnam, one Dr. Anne Satish, who was working as a resident or a lecturer there at the time, he said, "Sir, DHS is our bread butter. So you should do something like keyhole surgery for DHS also," because I had gone there to demonstrate my keyhole surgery of supracondylar nailing with a Solapur sleeve. So his question, I took it seriously and I developed an instrument through which we can do, instead of taking a long incision with a small incision, a DHS can be done. This is the sleeve which can accommodate a 15 millimeter instrument inside. Instead of triple reamer, I made it a double reamer. All long handle instruments were produced, and this is a case example of a percutaneous DHS with a small incision, as small as 2 centimeter incision. I have done this surgery in this patient. Another case, which I am showing little more in detail, a crack fracture. So this is intraoperative X-ray. I normally keep a DHS plate over the body, and between the second hole, I take a marking. Then I keep a guide wire in the lateral picture and take a picture in the direction of the shaft I mark. Wherever these two lines meet, the second and third hole and the lateral line, wherever they meet, that is the site I take the incision, and through the incision, I pass this Solapur sleeve. This angle of 135 degrees sits beautifully over the lateral aspect of the thigh. And I normally tie that thigh with a bandage so that that 135 degree angle will be maintained without any problem. Initially, I pass a K wire. Over the K wire, I pass a Richards 8 millimeter cannulated drill. Then I take out this K wire and then pass a long guide wire. So I have taken out the K wire and now I am passing a long guide wire. So this long guide wire is 18 inches in length. So here you can see I have passed a K wire. Over that I am passing a cannulated drill bit. Then I have withdrawn the K wire and I have passed a long guide wire. So this is the sequence at which I normally do this surgery. The long guide wire is required because all my instruments are longer. If I use a shorter one, pelvis penetration will be more. So using the double, I'm trying to ream, which also passes through the sleeve. And after reaming and passing cap, I normally pass the screw. Here, what I normally do is I pass the screw to the bone. You can see the back end of this inside the bone. Then I remove it slightly at the back end of the screw. You can see, but I'm trying to withdraw that so that back end of the screw will be outside. The reason is you have to negotiate the guide wire later. For that purpose, I had withdrawn the screw a bit. Percutaneously, with that small incision, I am pushing the plate against the bone, acts as a periostem, and this plate will go into the wound. Once the plate enters into the wound, I negotiate this special screwdriver. It is flat anteriorly, but its backside it is round. So I negotiate the back end of the screw. So I will show the next picture. Then once I negotiate the screwdriver to the screw, I pass a screwdriver here, and then I pull the plate out. You can see with the radius ulnar clamp, I pull the plate out, and then I do the final tightening of the. This is where the screw which was withdrawn slightly. Now I am doing the final tightening. So once that is done, see here you can see the back end of the screw is outside. I am negotiating the guide wire through the screwdriver, and there are male and female stuffs which matches very well. Once that is done, the plate is pulled and it is tightened. Then over the screwdriver, you can slide the plate beautifully without any problem. So then finally, in the lateral view, the plate has to be adjusted so that it sits on the bone properly before we do the distal plate locking. Here you can see that I'm trying to pass the fourth screw, that is by withdrawing, retracting down. Since our incision is between second hole of the plate, by retracting down, I can pass the third and fourth very easily, and by retracting proximally, I can pass the first screw. So this drill sleeve properly sits in the hole of the plate, so there is no soft tissue getting entangled, and I pass and fix the plate in this fashion. So that is the end of the surgery. Then, if the fracture requires, I normally do the compression. This is the demonstration case I did it during the Ganga operative trauma course, just to show the tightening of the screw and the compression happening at the fracture site. You see the gap here. You see the gap in the interior part. Then when I'm tightening the top screw, this gap will reduce. Now you can see that the gap is coming gradually down, and this gap will totally close once this tightening is completed. So this is the advantage of this. You could see that the gap could be totally reduced. So this is how I compress the fracture if it is required. Here you can see Dr. J. Deen Dayalan during the GOTS or the Ganga operative trauma course. The whole video is available on YouTube. You can either search for keyhole DHS or my name, Dr. SHIVASHANKAR. You can search and you can see this whole video. Normally, because I have elevated a lot of muscle, I keep a drain so that all the dead space will become very, very less because of the negative suction drain. And normally on 8th or 10th day, I take out the sutures with the same patient where I am taking out the suture in this patient. Then this is the immediate post-operative X-ray in the same patient. I normally use the technique only for crack fractures. This is a case of 6 weeks old. This is not the same case which I demonstrated. This is another case patient is able to walk comfortably at 6. You can see this is the intent post-operative extent. This is the 6 weeks. Now you can see whatever you are seeing now on the screen is the 6 weeks post-operative X-ray with the nice position of the DHS with a hardly any screw incision which can be seen. This is a cutlery slide from Dr. Sunil Shah from Sangli. He also uses a similar technique and he has shared these pictures with me. And this is the wound at the end of 3 months. Friends, I've been using DHS almost till 2005, but even this is almost a intertrochanteric fracture, not just a cracked lesser trochanteric. It's a very stable fracture, to tell frankly. But you can see that there is so much of collapse happening. So this uncontrolled collapse is the one which is very, very problematic. See the length of the screw which is going inside. Till the screw started touching the barrel, it has gone. So though it is DHS is a gold standard, this uncontrolled collapse is something which is very, very bad, and this is in a stable fracture. What about in unstable fracture? In unstable fracture, we all have seen such disaster, to tell the least. We all have seen. This is not a very good implant, especially for unstable fractures if you are using it. Unless you add something else, like a wiring or a abduction osteotomy or getting a valgus reduction. These are all required to get a good outcome. This article by Henrik talks about the iatrogenic lateral wall fracture happens in almost 40% of the cases, and due to uncontrolled medialization, you can see the screw barrel starts sliding inside. When it cannot slide no more, then it starts cutting up superiorly. So to have dynamization along the shaft, people came out with this plate. Fortunately, this works well for subchondral fracture, but if the lateral wall is intact, if the lateral wall is broken, this plate will also not work. So to prevent medialization, people started using trochanteric buttress plate. This also works to some extent, but unfortunately, some of the trochanteric buttress plates does give problem. This was a very well done case, but you can see in course of time, it has medialized and there is a failure bound to happen because of this uncontrolled medialization. I was thinking about how to control this medialization, and this article talks about by Parker. If there is no medialization, almost 10% failure. If there is 30% medialization, 30% failure. If there is 60% medialization, 60% failure. If there is a 90% medialization, 100% failure. What is this? This is a 25% medialization. This is 50% medialization. This is 100% medialization. When you see an X-ray like this, you should be able to predict this is going to fail. So you should take an immediate action. One of the way is to have a buttressing in the trochanteric buttress plate, or intramedullary nail is definitely better. That I will come little later. Or in an osteoporotic fracture, you can see as a precautionary measure, a trochanteric buttress plate can be used. This was a fracture of the lateral wall. You can see there is a fracture of the lateral wall which is caused iatrogenically, that could be tackled just with using a trochanteric buttress plate. But unfortunately, all the buttress plate available in the market don't fit well, especially for the elderly ladies in India. So I started using T plates and L plates as buttress plate, and over the DHS, I fixed them with 1 or 2 screws. This is a very short guy, less than 4 feet tall. You can see he's a Swamiji, and I was using a pediatric DHS, but unfortunately, I broke the lateral wall during surgery. I realized, and I used a T plate as a lateral buttressing trochanteric buttress plate. This is immediate post-operative X-ray. This is 4 months. He had a very good function. This is after the implants have been removed. Recently, before the lockdown, he had come for follow-up. At 5 years, you can see patient is able to squat, sit down instead of the severe valgus, which was unintentional because I was this so much of valgus I was not trying to get, but unfortunately, I ended up doing that. So I call these L plates and T plates as arm army TSP, because any of the Richard screw or plate you are using, you can use them as an additional one. So in a DHS, if you are using, you can reduce the bending strength by getting the beak into the medullary canal, that is Diamond Houston type of osteotomy, or you can put the plate through the fracture site and get valgus reduction. And as I said earlier, just by putting a DHS, it's not the gold standard. You have to have this TBP or the medoplate available with you. So DHS alone is not gold standard. DHS has to be fixed with one of them. Friends, after my MS, I did work in England, and also incidentally, I worked in Germany with Professor HOLZ, who was supposed to give this oration today. And during my tenure there, Dr. Professor HOLZ made sure that I attended many workshops, especially few interlocking nail workshops at Freiburg. And I attended one of the gamma nail workshop there, and I learned about the gamma nail. So the third way of reducing the bending moment is intramedullary nail. That is the reason why I talked about this reducing the bending moment. By medializing the implant, you can reduce the load. The load-bearing implant could be converted by putting an intramedullary load-sharing implant. I cannot talk further about intramedullary nail unless I talk about my friend, Dr. Subhash Haldar, who has designed this Halifax nail. He has come on my instance so many times to India, and he has come to my house, and even I have visited his house in Halifax in UK. He came out with this Haldar's nail, Halifax nail in 84. Gross came out with a similar nail in 87, and Dr. Haldar went to How Medica and they proved that this is his design, and finally How Medica agreed to give him royalty, and they renamed the nail as Haldar's Gamma nail in 1989. This we have been using so many years. You can read more about this on a webinar I conducted with Dr. Subhash Haldar. It is available on the YouTube on OrthoTV channel. Once indigenous gamma nails were available in India, this is again from my old slide. You can see I started using gamma nail in few of my cases, and I was quite happy for stable fractures, but again, I was not happy with unstable fractures as it was a too big an implant for our Indian bone. So that was the problem. So the AO group came out with synthesis, the PFN in 1997, which is a two-screw system, interlocking, the distal locking done away and the tapering nail. All those advantages of PFN was there. And incidentally, I was working as an Indo-German Orthopedic Foundation Fellow in Düsseldorf in Germany in 1999. I went there, I saw the PFN being done there, and I came back to India and I gave the design to an Indian company. And this was the first nail in India which was manufactured indigenously by Yogeshwar Implant. And this was a 25 centimeter implant. Then I met Dr. Gadegone in 2003 at Chandrapur, and he suggested that this 25 centimeter nail is too long an implant for Indian bone. So he suggested me to curtail this length to 18 centimeter. That's how the TFN came to market in 2003 because of the insistence of Dr. Gadegone. Friends, I have been using this TFN for IT fractures since 2004. My first preference for any intertrochanteric fracture nowadays is TFN only. Between 1999 to 2004, I was only using for unstable fractures or subtrochanteric fracture. But after seeing some of the cases by Dr. Gadegone, I started using PFN even for intertrochanteric fractures. This is an example of an intertrochanteric fracture where I used a PFN, and you can see that the patient is walking comfortably in the immediate post-period. If you do the surgery well, they walk very well. Compressing the fracture is very important, and the screw position also has to be very good. This is a patient who is 84 or 85 years old. When he came for follow-up at 3 months time, you can see that he was crying literally. So I took his permission to present this picture in front of you. He said that all his friends who had fracture in the hip, they never survived even after the surgery. But he was so thankful to me for having done a good surgery. Another 75-year-old lady. You hardly can see the posterior cortex in this patient, and I did a Halifax nail. Friends, implant is just a tool to fix the fracture. The patient is walking comfortably in the immediate post-operative period, and this is the 1 month follow-up, this is the 3 months follow-up, and this is the 8 months follow-up. So if you do the surgery properly and fix the nail properly, neck shaft angle should be good, then you have to get good results with this implant. Unfortunately, we face many problems, and these many problems lead to complication. The foremost, I will just talk about few cases because already 25 minutes now. Some of the commonest problem I face done by others are the mistake in varus reduction due to entry problem and positional problem. Second one is inability to pass both the screws, again due to the same problem, position or the entry. Third one is the lateralization of the shaft. This is due to inserting the nail through the fracture site without making space for the nail. These are some of the commonest problem I do come across done. So let me talk about few of them. I will not go in detail with any of them. First and foremost, you have to reduce the fracture. I normally pass a skin one pin to the fracture site and I get the anterior part done. That is very, very important. Once the fracture is reduced, I fit wires, then I will carry out the surgery. This is the displaced fracture. You can see laterally it is so much displaced. On table, I have inserted a Steinmann pin, then reduce the anterior cortex. Then I'm fixing the fracture with KYs. After having fixed the fracture with KYs, I'm adducting. On the left, you can see doing surgery is very difficult, but after adducting, the fracture is not going into varus. So many a time our friends adduct without fixing the fracture, that leads to varus. And I also keep the ischial perineal post against the normal side ischial tuberosity. The reason is I can adduct so much without any problem. So that's the advantage. Almost 60 to 70 degree I can adduct. So one should get a beak out. This is a negative cortical support, beak into the middle canal. Beak touching the shaft is neutral, but beak coming out is positive cortical support. We should always aim to get positive cortical support. So this is a negative one. This is a neutral one. This is a positive cortical support. This I have been practicing almost since 20 years. Just in AP, if there is a positive cortical support is not good. It has to be positive even in lateral view. So here it is a negative cortical support in lateral view. So the end result of this patient is slipping of the neck into the shaft. So both in AP and lateral, there should be positive cortical support. That is very, very important. This is a 2010 X-ray. You can see my friend was operating. There was a negative cortical support. He called me. What I did was I used a bone hook, pulled the greater trochanter out, got a neutral reduction, then fixed the nail. This is immediate postoperative picture, neutral cortical support. In due course of time, the fracture has healed beautifully without any problem. Another case, 2007, this patient has operated. You can see there is a valgus reduction or a positive cortical support. Without any problem, fracture has healed in this case. So getting a positive cortical support is also very, very important. The second foremost problem is the entry site. Because the bone is weak on the lateral side, it gets unintentionally lateralized in this fashion. So what you have to, so the nail, if the entry side is proper, your screw will be properly positioned. If the entry side gets lateralized, your screw position will not be proper. The third one is passing the nail through the fracture site. So that is, again, that will cause the varus. So always one should make a space for the nail. Don't shovel the nail into the fracture site. That is very, very bad. It acts as a spacer and the contact becomes less. This is a recently done case. You can see I have used a owl to make an entry. Then this is patient, you can see 94-year-old. It is written here 90, but she was 94-year-old. So what I have done, I reduced the fracture beautifully first, fixed with KYS, then adducted, made an entry. Then I'm using a cheese cutter to make a proper 10 millimeter hole in the proximal entry site. Then I am passing the guide wire, reaming with 15 millimeter reamer. Then only I am passing the nail. So always you should, even in a osteoporotic bone, you should pass the reamer first, make a space. Don't directly shovel the nail at the fracture site. This is the commonest problem I see. And your patient should be so good that the patient should be walking in the immediate postoperative period. You can see this is a 93-year-old patient walking on 3rd of March. Just the third postoperative day, he is walking beautifully. Normally, what I do is I take the entry over the neck, not over the tip of the trochanter. The reason is when we take the entry over the neck, we end up reaming more laterally because bone is more soft laterally, and then our nail position will be beautiful at the end of the surgery. Because the bone is so strong on the medial side, we may not be able to ream the medial side. So that is another thing. Just to give an example, if you take the tip of the trochanter entry, since intertrochanteric fracture, it is very difficult to demonstrate. I am taking an example of a subtrochanteric fracture. Entry has been done, reduction is beautiful. entry is through the tip of the trochanter. What happens, you see? Now, once the nail is passed, the proximal fragment goes into varus. This is the one which displaces the fragment. So this is the reason why I always tell, take the entry medial to the tip of the trochanter. Don't take the lateral, don't take the piriformis entry. Piriformis entry is much more posterior. It has to be in the center in lateral picture. This is the correct entry for an intertrochanteric fracture. Then passing the nail causing lateralization of the shaft. If you pass the nail through the fracture side, how it can cause? I'll just give a demonstration. This is an undisplaced fracture. When you adduct, you can see that the perennial post touches. The surgeon was not happy, so he adducted further. Because of the perennial post, the superiorly, when your reamer is inserted, the fracture opens up superiorly. That leads to varus. And when you put the nail, the fracture goes into varus. This is the commonest problem which happens in this patient. If the surgeon recognizes that there is a varus happening, he might try to abduct after having put the nail inside. Then inferiorly also the fracture opens up. There is opening up already superiorly, inferiorly also it opens up. That will lead to longer screw being required. That will lead to lateralization of the shaft. You can see normally when you draw a line from the outermost part of the pelvis, it grazes through the trochanter. Here, if it is trochanter is going outside, definitely it is very, very bad. It happens even in newer implants. You can see there is lateralization of the shaft. If you draw the line from the outer border of the hip, you can see that so much of lateralization has happened. You have to come. I release the foot end of the traction and I compress the fracture alternately, superiorly as well as inferiorly. So till my satisfaction, this is only possible. A screw with the head. Without the head, it's not possible. Friends, there are so many things to talk. A good implant from a good company is required. A good anterior reduction is required. Good medial reduction is required. Neutral or positive cortical support is required. Proper entry has to be done for the nail to go in the canal. A good screw position both in AP and lateral should be there. TAD has to be less than 25 millimeter both in AP and lateral. Fracture should be compressed well. In headless screws, the screw head should be slightly backside, outside, so that it will slide out easily. And nail should be slightly projecting out at the entry side. Since I have talked on this topic on various platforms, I'm not going to talk today. I once again thank the Bangalore Orthopedic Society for having invited me for this today's prestigious oration in the name of Sureka Rajendra Kokle. Thank you very much. Hello? I cannot hear. Oh, sorry. Hello?
Hello?
Yes, sir.
Yeah. So, friends, the normal dictum is to introduce the speaker before the lecture, but today intentionally I kept it for the last because SHIVASHANKAR was so gracious enough to accept this was initially to be delivered by Professor HOLZ from Germany, who was suddenly admitted in the ICU with some septic shock. And from ICU, he sent a message that conveying his regret to participate in the Boscon. But Dr. SHIVASHANKAR was so gracious and kind enough. When I requested him, he readily agreed. And he's been a close associate in KOA. In every program of KOA, we always see one of his lectures. And he's so well versed with these hip fractures. And he's all over, in fact, he's a great favorite for our Professor Tanna. And you see, he's been the member of Maharashtra Orthopedic president. Then he went on to be the IOA president with great, in this Corona time, with a lot of uncertainties. But today he's there as a president of IOA. And I'm so proud that he has presented this oration on behalf of my late wife, Sureka. Sir, I'm honestly honored with your presentation. We thank you very much. If it was a physical presence, we would have met with more mementos, but probably we'll catch up soon. Once again, I thank you very much, sir. I thank the BOS for giving this opportunity to select Dr. SHIVASHANKAR as the orator. Thank you very, very much, sir.
Thank you. Thank you very much.
Thank you, Shivashankar.
Thank you, Dr. Shivashankar. And now next we have the trauma session, for which I would request Dr. Rajiv Naik sir to come on the dais. And the chief panelists are Professor Raj Gopalan, Dr. Satyaroop, and Dr. Mallikarjun Swamy. Dr. Satyaroop, if you can come on the dais. Dr. Rajiv Naik, Professor Rajiv Naik. Yeah. So right now, Professor JOSTEN is not still online. So we have Professor KRETTEK to speak about his philosophies of the polar screw. Professor KRETTEK, are you ready?
Yes. Can you hear me?
You're not audible.
Can you hear me?
Yeah, I can hear you.
Good. Good morning, everybody. Thank you very much for having me in this prestigious meeting. I really appreciate to be part of it and to be able to share with you some of our philosophies. Can you see my screen?
Yes, we can.
Okay. So
we can't see your screen, your presentation.
You cannot?
Yeah.
Okay. Let me check. Screen sharing is, yes, here. And it should work. Can you see anything? No?
Now we can see your screen, sir.
You can see?
Yes. Please go for this full screen.
Full screen?
Got it. It's there.
And here we are. Thank you very much for giving me the opportunity to talk about the philosophy of polar screws. And this is nothing, has nothing to do with polar and north.
Please, Dr. Deepak, to join us in the panel.
Sorry?
Dr. Velmani also. Professor KRETTEK, you can continue.
Thank you. Has nothing to do with cold areas and animals there. And polar in Germany are these holes. And I use this name because small pieces of hardware are able to hold even very big ships or other things away. And this seemed for me the appropriate analogy for what we are doing in the operating room. And in the next 15 minutes, I would like to share with you facts and examples to understand the problems related to predominantly metaphyseal nailing, understand the special anatomy of the metaphyseal area, realize what factors are dislocating constructs and produce stabilities, the principles of starting point, how important it is. And we just heard a wonderful lecture of Dr. SHIVASHANKAR about this problem and learn about the philosophy of polar screws. And when things go wrong, it's usually not the problem of the implant, it's more as a problem of the application and the understanding of the environment. What are the problems in metaphyseal nailing? We have high amounts of instability and malalignment after nailing. This is true, very true for the proximal tibia, and Paul Tornetta and many others have published this, and there are dislocation up to 60, almost 60% above 5 degree. And this is true for the distal metaphyseal area as well. Here is such an example. A proximal third tibia fracture doesn't look too difficult, but when we saw the pictures after the nailing, many things went wrong. Questions are, is the nail position adequately centered? Is the starting point level high enough? Is this locking sufficient? And is the alignment sufficient? And is the additional implant also fixed sufficiently? And what's the remaining stability? Would it last over the following months to get good fracture healing? The answer is no, and this case went into deep problems. The approach is very critical. We heard this before, and actually, most important thing for the approach is not the size, it's the perfect location. You don't need for a 10 millimeter diameter nail a 10 centimeter approach, because kneeling after nailing is frequently a problem. The incision is just sufficient if it's equal to the diameter of the implant, but the prerequisite is that it's really right at the spot where it should be for mechanical reasons, and then these patients won't have any problems during kneeling. What's the starting point for the proximal tibia? We start very high at the level of the patella. And when you look in the lateral view, it's important that you start high in order to get steep into the metaphyseal cavity. Another important aspect is, where is the center of the medullary cavity? It's not what you can palpate, the so-called anterior tibial crest. The anterior tibial crest actually is on the lateral side. The center is more medial of it, and you should target for this. Proximal tibia fractures. What deformity can you expect? And there is a very simple deformity rule. The deformity rule says that it deforms to the side of the higher fracture line or the wedge. Here is such an example. There's the bending wedge. It's tending towards valgus deformity, which is most common because usually these patients are attacked by a car, and the bump usually comes from the lateral side and not from in between the two legs. Second example, we don't have a bending wedge here, but it deforms to the higher side of the fracture line. And also important to know that the proximal tibia is not a symmetric bone, is an eccentric bone, as we can see here in this example for a total knee, and they have adapted to the anatomy accordingly. The other thing, because the other reason why we have most valgus deformity is that all the muscles are on the lateral side. And if you have a bending wedge on the lateral side, there is lack of lateral support. So all these three factors contribute to the predominantly valgus deformity you have. And here is a picture of a cadaver bone of the proximal tibia. Here is the shaft where the green line is, and you see how eccentric it overloads to the medial side. And when you retrogradely ream these these tibial shafts, you have, according to a study, you never end up in the medial compartment. You never end up medial to the medial spike. You end up in a quarter of the cases in between the two spikes, but in most cases, in 75%, you end lateral to the tibial tubercle. So stay lateral for your entry point. Additional implants can help, but here I would like to share with you a clinical case who was really an eye-opener for us, a proximal segmental tibia shaft fracture. It didn't look too difficult, the segmental fractures, and what we saw Post-operatively was this picture with a large deformity, shortening, instability. So in the morning conference, we discussed the case. We have a misfit between outer nail diameter and the inner part of the medullary cavity. So we have toggling and instability. So we went back to theater and did a temporary nail removal. And the problem is, if you do renailing, you always fall back into the old wrong nail path. So you need to somehow block this old nail path, and this can be done with easy, simple implants like a single screw. We see here after nail removal the old channel of the nail, and then we just re-guided the nail and reinserted it. It passes on the medial side because it cannot fall back into the old wrong nail path on the lateral side. So it enters the distal main fragment and now nicely centers and aligns the construct. It not only aligns the construct, it also stiffens the construct. And look here, after 12 months, we have nice fracture healing, and all this supported with just a very simple, small implant and cheap implant for 10 euros. You can solve this problem. This was the situation before, which was prevented with a simple single screw, but it requires careful planning and understanding of the deforming forces. I have made a little plexiglass model in order to demonstrate the principle of what we are facing during metaphyseal nailing. We have a situation where we have fixed the distal main fragment with an intermedullary device and 3 screws. And one would think, oh, 3 screws, this must hold very well, but no. Due to the oblique fracture line, when you axially load the construct, there is slipping. And not only slipping because of this misfit between medullary cavity and the diameter of the nail, we also have translation along the nail. Despite the fact that we have here 3 locking screws, we have translation along the proximal and distal screw, and the middle screw acts as a fulcrum. So despite this construct, it's not stable due to slipping and due to obliquity. So what can we do? Let's have a look on the model. We have this oblique fracture line. We have a misfit with small implant and large medullary cavity. And when we axially load, we get a shift, we get a shear. And shear, we all know, is very bad for fracture healing because also growing cells are disrupted, and we diminish our contact area from ideally 100% to below 20%. So how can we solve this? How can we solve this mechanical problem? So we just functionally decrease the gap between the implant and the medullary cavity with these polar screws. And when we now act polar screw on the blunt side of the angulation, always on the blunt side of the angulation. When we now load it axially, what happens? We have no slipping anymore, and we have no shear anymore. We have just compression. And we all know how good compression for fracture healing is. And not only that, we have 100% ideally contact area. So here in the animated model, we have polar screws in red, and when we actually load it, the shift is blocked. We have good alignments and increased stability. So polar screws can reduce diameter discrepancy. They prevent translation along the screw. They increase the contact area, and they transform shear into compression. So this is a good thing to have. And we can not only correct and maintain alignment, we also increase primary stability, and biomechanical analysis have shown it goes up to 58%. So this allows us to go more to the joint level. It enhances nailability of certain fractures. But we have to pay a price. What are the buts? The buts is we have additional radiation because it's sometimes a little bit fiddling to insert the polar screws. We have potential nail damage, as we see it here on the slide, and it requires knowledge of the pathobiomechanics because they need to be placed on the right side. What can we use as polar? Anything which is stiff and hard. Before we can use a variety of screws, and we can use the differences in diameter. The bigger the difference, the bigger the diameter, the larger the correction potential, and vice versa. We can use also temporary K-bars, or we shorten the K-bar, and we can play with the diameter because with increasing diameter, they are increasingly stiff and more and less stiff. So we can play with the diameter, we can play with the stiffness because we do not want to break out fragments due to when the nail hits the polar device. The question is should we insert this before or after neural insertions? The correction potential is clearly larger when you do it before, but you need to be careful that you don't break out any fragments. Should we do it temporary and permanent? Sometimes they have as a job only to be done during the nail insertion, and once the nail is locked, in this plane, you don't need the polar screw anymore. And as mentioned before, different diameter can be used in order to have a different size of your correction, in fact. There are other systems in the market, like the angular stable locking system, ASLS, in order to address metaphyseal fractures. It's a little bit more complex system. And as we see here in this clinical case, we have also problems with the lockings. They should reduce the toggling, which we have naturally due to the tolerances. But when we have a look on this clinical case, look at this. This was a case done with ASLS, post-operatively, nicely aligned. Week 6, slight deformity. Weeks after 6 months, even increased deformity. And after 1 year, we have significant deformity, which required some revision of the case. So this system obviously has some flaws. Clinical example, proximal tibia fracture. Which deformity can you expect? Deformity rules deforms to the side of the higher fracture line. This is lateral. So we can expect bending valgus deformity, and we need to address this by appropriate placement of the starting point. Should be lateral to the tibial spine, and the polar screw should also be on the lateral side. But this has not been done. It has just been nailed, and it looks not bad post-operatively. But look at the pictures of 2 weeks. There is some deformity. Why? Because the proximal nail end is migrating to the medial side because that's soft bone, and it's a very low starting point. After 3 weeks, even more, and after 6 weeks, it's significantly deformed. There is a polar screw, but the polar screw is much too high, and the starting point is inserted much too low. How can we address this? What should we do? 3 weeks valgus deformity, which even increased in the following 3 weeks. And look at her. She has pain, and she has a significant valgus deformity. So we brought her back to theater. After careful planning, we decided to have a high starting point, and we blocked it posteriorly with the polar transverse polar construct. Here's the post-op analysis. where we prevented from posterior slipping out, and in the frontal plane, we moved the starting point to the lateral side, lateral to the lateral spine, and the polar screw close to the fracture gap. This corrects the alignment. Here's the postoperative analysis. Polar prevention proximal, because this was very, very soft bone. Nice alignment after a surgery, and completely uneventful follow-up, and no significant pain reduction and uneventful fracture healing in this case. And problem in proximal femur fractures, we very nicely heard from Dr. SHIVASHANKAR that how important the starting point is, but sometimes it happens because we have this deforming the forces, positioning, bad draping, bad approach, obesity, and asymmetric bone quality, laterally soft, medial hard. This drives the nail onto the lateral side. What can we do? We can use polar screws in order to prevent from shifting and drifting. Like here, we remove the construct, we insert the polar screw, make slight corrections, and reinsert the implant, and we have a very strong, very stiff, but also very good, better aligned construct. Here, a clinical example. Frank, 51-year-old proximal femur fracture, not much of a deformity, but he developed pain and he did not heal. He broke his distal screws. And 1 year after his surgery, he presented with 5 degrees of varus, almost 30 degrees of internal torsion, and painful non-union, not united despite all sorts of ultrasound treatment. So the case for us was very clear. He needs to have a perfect anti-varus alignment. Varus is our enemy, especially in the proximal femur. So removal of the implant, blocking the wrong nail path, as we just have seen it in the clinical, in the drawing, we block the wrong nail path with this simple 10 euro screw. And created a new starting point, more medial of it. And after resection of the non-union, torsional correction, and bone graft, we reinserted the nail. Here we see the post-op firm. We see also the old nail path. If you look carefully, that's the old nail path. And our new nail path is now 5 degrees reoriented. And here's the postoperative CT scan. Here's the border of the old nail path. Here's a new nail path, and we see the empty gap left by the new position. And 1 year after revision, the patient had a sound fracture healing and no pain. Pain is gone. He's back to his previous activities. That's true. These principles are true for the lateral deformity, for the deformities in the lateral view as well, because due to the flexion of the proximal main fragment due to the muscles, we see frequently cases where the starting point is too anterior. And this is also not good for fracture healing and is related to higher rate of non-union. So what can we do? We also need to be very concentrated in the lateral view to have the perfect starting point, the perfect nail path. And of course, this nail would fall back into the old nail path if there is one existing. So block it with a locking screw, with a polar screw, and reinsert the nail, and you have a nice alignment and all good prerequisites for fracture healing. Sometimes you have a problem, you have an old nail path, and then you have, for example, a new fracture, like in this gentleman. You see here, there's an old sclerotic nail path, and so you have a new fracture, like here, and when you try to reinsert the nail, you would land in the old nail path with this valgus deformity. So what can we do? Here as a clinical example, and the solution with the polar screw, we remove as a nail in the wrong nail part. We position a polar screw in a position where we have the new nail path lateral to it. The nail wouldn't slip in easily. So we need to take the hand reamer, slip it slightly lateral of it into the sclerotic bone, carefully ream it up and create a space for the intramedullary implant, and then renailing is an easy job. Many times we have the problems that we have these hypertrophic non-unions, which would be here, which nicely heal once you stiffen them up. So what the problem is to hit the distal medullary cavities. These are usually pretty stiff, and when you ream them, you would perforate easily the bone. So what we can do is we do sequential polar screws, and once the nail hits now as the first of the row, it deforms and reams up to the next polar screw and reams up to the next polar screw. The hand reamer is bending slightly, but it gives you the possibility and the opportunity to create a curved nail path, and you can have a medullary cavity again. And when you now insert a 10, 11, or 12 millimeter thick nail, you can straighten out the construct easily, and all prerequisites for fracture healing are given. So question is, do we need more intelligent implants? Do we need stronger implants, or do we need a more intelligent use of existing implants? I think adding more and more metal into a device is not the expression of intelligence. I think it's a critical and clever use of existing implants, but in the right biomechanical spot is the solution to many of our problems. So let me summarize philosophy of polar screws. Positioning and starting point are crucial. It's not a tiny little screw. You need to have a philosophy also for and understand the need for a right starting point and the right nail path, understand the pathomechanics of the tibia, and understand the deformity rules. It always deforms to the higher fracture line. Apply to approach and fixation. Analyze the problems early. Play on your desk with drawings. Additional tools are helpful, like polar screws, etc., etc. And usually it's not the implant which is the problem. Thank you very much for your attention.
Thank you, Professor KRETTEK. I'd like to acknowledge the presence of Dr. Deepak Shivana and Dr. Vanmali on the stage, along with Dr. Rajiv Naik. Next, we have Professor JOSTEN joining us for his talk on PFN, errors to watch for.
Yes.
Professor JOSTEN?
Yes, I'm here.
Yeah, we can hear you. Can you share your screen?
Yeah, I do. You see?
Yeah, we see your desktop screen.
Yes. So at first, I want to thank for the invitation, and I want to send my best greetings to my friend Uli HOLZ to give him the best recovery. And I also want to say many thanks to Dr. SHIVASHANKAR for his excellent presentation. And I can close my presentation because he talked a lot, not only about PFN errors, but also about solution. And also, my friend Christian KRETTEK showed you some solutions concerning errors which can happen with intramedullary nailing. So I'm not a friend of naming PFN. So this is a problem not only of the PFN I will speak about, it's a problem of all intramedullary fixation devices. Let's start with two current cases. This is a typical case. An 82-year-old lady, she had some larger spine surgery some weeks ago, 3 weeks ago. You see the osteoporotic bone. And then she had a fall and she had this proximal femur fracture. You see also here sclerosis of the vascular system. And this was the operation which has been done in another hospital. It looks quite nice, and according to Dr. SHIVASHANKAR, it's a neutral reduction of the medial cortex, but it looks quite nice, no medialization. But patient transfer, she had wound healing, and you see what has happened. This was an overlooked peri-implant fracture. You see this overlooked peri-implant fracture, and this I saw also in Dr. SHIVASHANKAR's presentation, that also, especially in the Asian people, you have to use curved proximal nails. If you use straight nails, you are hurrying in problems arising by the tip of the nail. And this is 12 days after the presentation, and you see she has also an arthroplasty of the knee. And you see, if you have one complication, the 1 year mortality is increasing very, very much. And we switched to a longer nail, but again, also with a longer nail, you see the problem by the kissing implants, the nail, and also the knee arthroplasty. This is the patient. She had a short nail extramedullary stabilization. It's an eccentric placing of the screw, not an optimal one, which is showed here, an off-center and a varus angulation, and again, a mismatching of the medial cortex. And as it has to come after 4 months, she has increasing pain and missing telescoping procedure and a secondary dislocation based on a rotational situation. And there was no chance because the screw has made a big hole. You see the big hole here, and there was no chance to place another screw, and she got an arthroplasty. And if we have a complication of an osteosynthesis of periodontic fracture, the mortality is increasing. The mortality is higher than the mortality of breast cancer that we have to be aware of. And the question is that the primary failed osteosynthesis leads to an exponential increase of morbidity and mortality in further operation. And a failed revision osteosynthesis of the proximal femur is almost equal to multi-organ failure that we have to be aware of. And this impending multi-organ failure allows often just one more chance. That means the salvage operation or an arthroplasty. You can't overstress the organism of the elder patients. The cutout, we have a 70-year-old lady. It's a quite simple fracture you see here on the left side. This was the implant of the intramedullary device, and as Dr. SHIVASHANKAR told it, the nail goes just through the fracture gap. It looks not too bad, but this is the situation after the operation. You see here the gap. The reduction is quite nice. And you see there is an increasing varus. The patient came back from the rehab clinic, no trauma, no infection, but the loss of reduction. And then you have to plan your reconstruction or your reosteosynthesis according the position of the screw, which is dramatically important that you hit strong bone with the device. And in this case, as I was afraid of the big hole we have here in the head, I switched to an extramedullary implant. I made a valgusation revision surgery by a double angle plate, 120 degrees. And this is 8 days after the operation. And the patient came, and you see there was a increasing perforation of this plate. And finally, we had to switch to an arthroplasty, which is also not an optimal device. And you see that there can carry some problems from the proximal femur. The first decisive question, should we operate in the situation of an imminent complication, or should we wait until the definitive complication is occurring? The second decisive question, do we make a revision from an extramedullary implant to an intramedullary one, or from intramedullary to extramedullary, or can we stay in the same system? Staying in the same system is a quite seldom option. I show you a case, 69-year-old male, which was treated by a DHS. It looks not too bad. But you see, due to a rotation and a complete telescoping effect, we had finally a breakage of the screws and a total collapse of the fracture. It's not an implant failure. It's a neglected fracture of the tip of the trochanter. It's an iatrogenic fracture of the greater trochanter. And besides the telescoping effect, we had an additional rotational instability. But I decided to go to stay in the same system, to make a revision surgery using the same screw, the same implant, and the compression device. You see the compression device, which is dramatically important. And I make additional circlage for the greater trochanter. And this is 4 days after the revision. 88-year-old lady with this peritoneal fracture. She came to our hospital after her first operation done in another hospital. This was 2 weeks after trauma. And you see there's no chance for healing. You recognize the screw misdisplacement. This was the primary problem, that they missed the interlocking hole. And there was also an impending fracture, although you see it here, the impending fracture distal of the nail. And 4 months later, we tried to get the lady a chance, but she developed in delayed healing. And so don't wait until the complication occurs completely. Be active and go into good revision surgery. So the screw placement was not too bad. I stood in the same system. I switched the system from intramedullary to extramedullary, and I got a telescoping effect. This was 1 year and 1.5 years after the trauma. You see good healing, and she was free of pain under full weight bearing. This is a 70-year-old male, was treated with the first PFN, the double screw PFN, and this patient got what I call the unhappy triad of the nail. That was 2 days after the operation. We have the widening of the fracture gap. Secondly, we have a lateralization of the shaft. And third, we have an unfavorable liver arm that I call the unhappy triad of a nail fixation. And it happens 3 weeks later, the patient had a cut free. And I go, as you know, I like revision surgery by using the valgization and the double angle plate. This is a procedure during the operation. I don't want to stress it completely. You know this procedure. And then I had this quite severe valgization. Sorry. I had this severe or this strong valgization. I made it stronger with a circlage, and I also fixed the lesser trochanter with a screw. This was 2 weeks after the revision. The patient was mobilized under full weight bearing according to his possibilities. And even in this age, 78 years, you have a good chance. 2 years later, the patient came. He was meanwhile 80 years, and you see there was a good healing, even of the lesser trochanter, no loss of reduction, and I rely on the strength of the plate, and this he was in a good mobilization situation. 45-year-old female with a subtrochanteric fracture, and you see an insufficient closed reduction with a long nail, a vertic position and an eccentric position of the hip screw. And what was the solution? When we have a malreduction of more than 10 degrees, this results in a significant higher rate of delayed healing or pseudarthrosis. So this is a picture with a perforation of the screw. And this was done by a colleague of mine, a revision surgery with a 95-degree plate. When I saw this solution, I was not happy. And of course, it occurs because this is a wrong implant for correction of the synthesis in a proximal femur fracture. And we have a redislocation, but be aware, this is not the implant failure of the plate. It's not a suitable implant for a correction operation of the proximal femur. And we had only the chance to make a revision surgery by an arthroplasty. This was 8 months later, and 8 months later, the lady got a neck fracture of the contralateral side, which was treated by a DHS. Typical complication case. The unhappy triad of the proximal femur, I told it to you. 84 years old lady. She was treated with an extramedullary implant. And you see this implant was overstressed. She had also an acetabular fracture of the contralateral side, which was treated by a stopper approach. And 2 weeks after trauma, second operation with a buttress plate. But she got the infection. 2 months after trauma, we had to make, we had to remove the proximal femur. This was a cement spacer, and then she got a total femur replacement. I repeat, the total arthroplasty after failed primary intramedullary nailing or extramedullary is characterized by a high mortality. And again, I repeat, the mortality of complications after hip fractures are equal to late results of tumors. My conclusion, pertrochanteric fractures are also associated with high complication rate. The reasons can be manifold, and mostly it's not an implant failure. Mostly it's a failure of reduction, choosing the wrong implant. The treatment is very complex, and be aware, intramedullary nailing is not a 100% solution for all problems of the proximal femur, and in many cases, an extramedullary implant may be better choice. Thank you very much.
Thank you, Professor Josten. Now, before we go to the next case-based discussion, Professor Rajiv Naik, do you have any questions, any discussion you want to have about these two presentations? Okay, Professor. So we have next is case-based discussion on what went wrong, fractures of the shaft and distal femur. First case is by Professor KRETTEK. Professor, are you ready? Professor KRETTEK? Professor KRETTEK, are you ready with your presentation?
If he is not, is Professor Josten still on the line?
Yes, I'm on the line.
Professor Josten, Rajiv here.
Yes.
What in your opinion is not so good a fracture for blade plate?
So the plate is for me not an indication for primary operations. Secondly, the plate, the younger the patient is, the better are your options with the plate. In elder patients, you have to choose the patients very correctly. I showed you the case with a 78-year-old patient. It was a male. In a female with a higher incidence of osteoporosis, the failure rate of platelets are higher. So the younger the patient is, the better are the options with correction osteosynthesis of the plate.
Right. Professor KRETTEK?
Yes.
Yeah, you can start your presentation, Professor.
Okay. Can you see my desk?
Not yet.
Organizing team
No? Okay. Okay, sorry.
Office bearers
Yeah. Better?
Team organizing committee. Okay. Organizing committee.
Can you hear me?
Yes, Professor KRETTEK, you can carry on. Yeah.
This is, you asked for femoral cases, and I would like to share with you the case of Doreen. Doreen is a 36-year-old lady who had a motorcycle accident with this segmental shaft fracture of her left femur, and it was stabilized, reduced and stabilized with this retrograde nail. And during the nail insertions, there was a split of the proximal main fragment, resulting in a little additional wedge. So I'd like to ask faculty
sorry to interrupt, Professor. Can you reshare your screen? Can you stop sharing and rescreen again?
Yeah.
Difficulty in viewing your screen. Stop screen sharing and reshare again.
Okay. And again? Should I do it, share it again?
Please do it again, yeah.
Okay. Okay. And
Go for full screen, Professor.
Okay. Sorry. Didn't you see anything?
Got it, Professor.
Yeah, it's working, bro.
It's working?
It's working.
Good. Okay. So we have, what did you see so far? So
we heard your discussion regarding the patient having a road traffic accident.
But you did not see the images?
Yeah.
Okay. So this is a 36-year-old female, segmental shaft fracture left femur, and it was treated with a retrograde intramedullary nail. And during the nailing procedures, there was a wedge of the proximal main fragment. And I would like to ask the faculty if they are happy with this, with the type of fixation, and what problems they would expect.
Sir, no, we are not happy with this fixation.
So, explain us why.
First of all, preoperatively, we don't see a fracture higher up. Second,
yeah, but that happens from time to time. That fragment split complication occur.
Yes, the nail
so
is a little bit.
Should the surgeon have? Should he? What should he have made different?
Yeah, he should have chosen a longer nail, probably. Nowadays you get nails which extend even far more proximal. because this locking is very, very, very close to the fracture site.
Okay.
The other
So you would remove the nail, choose a longer one, and reinsert it.
The professor, here, after seeing the post-operative X-ray, it looks like an unstable fixation because the proximal screw of the distal femoral nail is basically unstable, and this is not going to unite. And since it's a segmental fracture, the choice of implant would be a antegrade nailing and probably fixation with an antegrade nail.
Okay.
That would be a better option for this. Since it was a segmental fracture, probably the preoperative planning with the existing longest nail would have been the error, which probably I would have thought of.
Dr. Rajgopalan, your comments?
Yeah, I agree with that. Basically, the split fracture wedge has gone pretty close to the tip of the nail, the locking device area. So this is, as we heard from Professor Josten just now, it is better to act early than late. So the question is whether to choose for a longer retrograde nail or antegrade nail. I think I will go for antegrade nail, mainly because you have to lock it proximally well. And you may have to put the screws into the neck rather than having the first generation. So I will prefer to go for an antegrade nail and revise it early.
So as I understand you would you revise it?
Yes.
What I mean is that advantage is that we can use the same, we can remove the nail and pass the guide wire from above, bring it out, go for antegrade nailing from above. You can use the entry point. So you can choose for a longer retrograde nail, but I don't know whether you will be able to get a good, strong purchase on the upper side because the fracture is pretty close to the not exactly subtrochanteric, but is coming to the limit of subtrochanteric. I will prefer to remove the retrograde nail and go for an antegrade nail.
Okay. So what problems would you expect if they would, if you would leave the implant? What's your prediction?
I feel that the locking is not sufficient. There will be so much instability there that you might find fracture not uniting or the breakage of the implant.
But don't you think two locking screws, cross locking screws would be enough?
It would have been enough if not for the wedge. That wedge, even though you can't see the proximal tip in the X-ray here, it seems to be going pretty close to your locking screw.
Okay. Dr. Josten.
Yes, it's easy to speak about revision after an operation which is done okay. This is not a catastrophe. Of course, I would have also chosen primary and antegrade nail because the most problematic fracture is the shaft fracture, not the distal one. But after this, I would talk with a lady. Is she obese? Has she any comorbidity? I see some chance.
Healthy, skinny person.
So normally, if we would have only this fracture, we would make a dynamic stabilization, a dynamic fixation. This is a rigid one, and we have a certain gap here. This may cause a problem. I suggest there could occur a breakage of the nail on this level. I would talk with the lady. I would say, okay, one choice is we can stay and wait. There is some chance to heal. Secondly, I could say we make a certain small revision surgery. That means we make a small plate here just to give here more stability. And the other option would be to choose to exchange the nail to make an antegrade nail. So probably I would suggest to make a revision with a small plate here to give more stability. But 3 options are possible.
Okay, very interesting. Any other comment? So the main concern would be fracture
Can I say something?
and instability. Go ahead.
Yeah, I just say that I thought about another plate. The only problem with that if you are going to put a plate here, where are you going to put the plate? Because the plate has to stabilize the fracture at the fragment and give a protection above the nail. So are you going to put a long plate laterally from this thing, or you're going to put a small medial plate?
Okay, good. Any other comment?
Can I?
Yeah, but
So one small suggestion. Suppose we retain with the same implant, hoping that the distal fracture would settle and then tackle only the proximal fracture later. There's a good chance of union of the distal fracture with the same implant when the complication becomes less and tackle only the proximal fracture later.
Okay.
Rajendra, she's a pretty young lady.
So
Are you going to keep her in bed?
anything, would anyone, everyone is commenting on the proximal fixation.
Sir, are you satisfied with the distal locking?
Yes.
Only two distal locks are, is it okay? Or nowadays we are recommending multi-directional locking?
Yes, but that is a case from 2011.
Okay.
There was only these two options.
Correct.
And
No, but
actually,
at the moment,
I was not concerned about fracture healing. I was concerned about alignment. And when you look carefully to your, and I'm very surprised that nobody is commenting it. When you look and follow the line of projected positions, then you see your distal main fragment is in varus deformity. And the other concern is the distal nail end is inserted too much. So the more it's inserted, there is no good hold in dense cancellous bone. With increasing distance proximally, it's getting softer and softer. And as we have seen in the video before, there is translation along the nail, along the screws. So my concern was not fracture healing. My concern was alignment. So this is the situation after 1 year. She had healed in the level of the distal fracture and in the level of the proximal fractures. She was pain-free. There was no torque pain, but she developed isolated pain on her medial meniscus. An MRI showed a torn posterior horn of her medial meniscus. And when you see alignment, we have now an alignment problem. She is full weight bearing. She was full weight bearing after 3 months without pain, but she developed pain after 1 year. So we have now this situation. We have a varus. We have a healed fracture. What can we do? Should we do only a scope and debride her meniscus and go on? Or should we change her alignment? What is the panel thinking?
I speak.
Sir, as an arthroscopist, varus deformity will tear the posterior horn. And only repairing the posterior horn will not help. You have to do alignment.
Okay.
If you don't do alignment, the posterior horn repair will again tear.
So is that alignment acceptable or not acceptable? And how much amount of contribution is that angulation causing on the medial joint line pain?
No, that alignment, it is too medial to the Sigakos line point. It is gone too medial. So you'll have to bring that point laterally.
So what would you do? What would you recommend?
You'll have to correct the varus happening at the femur.
What would you do? How would you do it?
Remove the nail, correct the. I think you'll have to do a corrective osteotomy distally also.
And then?
Correct the alignment.
Yeah.
Femur is going to varus.
How would you fix it?
Fix it again.
You can use a plate.
Plate. Distally use a plate.
Okay.
Because the nail will with the nail it will be difficult to control the angular deformity.
Yeah.
But the point at the knee joint has to come laterally. It is too much in the medial compartment.
So there is agreement. We not only need to
I don't know. I feel
address,
that we can wait for the correction.
You wait. Okay, that's a new aspect. So there are panelists who say this needs correction right now, or another opinion is we do the meniscus surgery, but postpone the alignment correction. How long would you wait, or would?
Sir, do you honestly believe that?
I want to wait because.
Sir, do you honestly believe that meniscus is causing the pain?
Yeah, that's a good question.
Exactly. Good question.
She had never any meniscus problems before. She is mid-30, and 1 year after our traffic accident, she develops pain which has not been there before. So she has a varus. We know that varus overloads the medial compartment and is linked to a higher incidence of medial meniscus pathology. So I think it's a reasonable chain of arguments that this is related. And also, when we treat it properly, this might stop. Professor Josten, what's your opinion?
Yeah, I have a question to you, Christian. I suppose this distal fracture has healed. I can't recognize it very exactly, but the distal fracture is healed.
Yes.
Yeah.
She was after 3 months. She was full weight bearing and pain free and no stress. I know you could discuss on the medial side of the distal level, but we assumed it as healed. We did not do a CT scan or something because clinically it was very clear.
So as I suppose there was not a breakage of the screw, but we have a non-union here. So we have two problems, and I agree, Christian. I didn't recognize the varus after the first operation, because we hadn't a long leg picture. But I would tackle now as well the non-union as well the varus.
No, there is no non-union. She was full weight bearing without pain.
Sorry, stress. I'm not sure because this picture.
Now I understand. You think it's a non-union, a pain-free non-union.
Hypertrophic. Yes.
No.
She's a thin lady. The nailing is still stable. So I would tackle this and maybe to make an anterocret nail. And as you mentioned it before, by maybe polar screws to make a correction here. So this I would plan. I would need more picture, but this would my primary choice.
So wouldn't you, if this is a non-union, after 1 year, wouldn't you have expected screw breakage or anything like this?
Yes, I would have expected. I agree.
Or instability, sclerotic windscreen wiper effects. None of this is happening. So this is a stable, healed fracture situation on both levels. No pain so far until after then, 1 year she developed.
Christian, if this is the case, I would remove the nail and I would make a subtractive validation by a blade here.
Okay, good point. So there are opinions predominantly correcting the alignment at the same time as the arthroscopy. So I think we can move on. Any further comment? No? Then we move on, and that's how we approach the case. We did some planning for the correction and went back to theater. Did an arthroscopy and then the osteotomy. And the osteotomy we did exactly at the level of the old fracture line. We opened with the chisel percutaneously the old fracture line, placed the polar screw where we, according to our preoperative plan, where we used long-standing films, and then we reinserted the nail over the guide wire. And look at this, how a polar screw can correct the alignment. See, it corrects the bone translation. And now we have a very nice alignment, and we have stiffened the construct. Again, the nail entering the distal as passing by with the guidance of the guide wire, the polar screw. We have still translation of the two fragments and angulation. And now the nail is entering the proximal main fragment, correcting the nail translation, correcting the alignment, opening up the medial gap a bit. And that's the postoperative situation before and after. And as a long-standing films and the united fracture situation. So any further comments to this? I think this is something we should have done before to add support in form of a polar screws or in form of whatever. And it shows the message I learned from this case is that there still can be some migration of the nail in a metaphyseal area. When you look at the two X-rays at immediately post-operatively and about in the long-standing films, it's about 1 year. You see there has been approximation of the nail to the medial cortex with some rotation. There was some varus from the beginning, but it increased over time. So this should be considered. There are strong medial muscle groups, and there's a tendency for varus malalignment. And these tiny little implants, strategically placed, can help to prevent malalignment and increase stability.
Prof. KRETTEK, that was a very nice illustration. We did not realize that you had fixed it in varus to begin with.
Yeah.
And secondly, the slides here are not very clear for us to think of
okay. Oh, I'm sorry. Oh, yeah.
So
it's a transmission problem.
Yes, yes. Thanks a lot. It was a brilliant presentation.
Thank you.
Thank you, Professor KRETTEK, for that wonderful presentation and the interesting case. So next we move on to the case by Professor JOSTEN. Professor JOSTEN, are you ready?
Yes, I'm ready.
Yeah, can you share your screen?
Yes. Sorry. So, do you see my slides?
Yes, we can.
Yes, I have not a case with I have a shaft fracture, not combined with a distal fracture, but combined with a proximal femur problem. You see, this was a motorbike accident, patient, 48-year-old male, motorbike, first to an external clinic, first CT scan in the trauma unit, and you see here, this is a CT scan of the pelvis, and you see there's a combination of a Pipkin fracture, of the neck fracture, including some problems of the posterior wall, and you see also here's a shaft fracture. This is the CT scan. You see the dislocation fracture of the hip and the shaft fracture. So my question is, the patient is quite stable, he can be operated, and now my question is how to treat this. Is there anybody who wants to give a comment? If
Rajgopalan, want to comment?
Yeah, I will. The hip is dislocated, so that gets the primary importance in the whole thing. I will probably first reconstruct the acetabulum, reduce the head into the acetabulum, then fix the femur if the patient is stable at the same sitting or next sitting. But the idea is to tackle acetabulum first, reduce the dislocation, then go for the shaft. Shaft will be an antegrade nailing.
Antegrade nail. Other options?
The second option is it's too high for retrograde for me. Second option is a minimally invasive plate.
Okay.
And retrograde if you still don't want for any reason antegrade.
Christian, your suggestion?
I would, is there a Pipkin fracture?
Yes. You see, okay. There's a Pipkin fracture.
Yeah. So, would try to address the Pipkin fracture, address the acetabulum, and do probably intramedullary nailing of the femoral shaft, and be aware in the communication with the patient that he has a poor prognosis.
Yes, this is of course, but the question is, do we make, sorry for my mistake, do we make a simultaneous operation or do we make it sequentially? That means, can we tackle this problem in one stage or not? So the first comment was, of course, you make a one-stage procedure. And then the question is, when you make a nailing of the femur plus a fixation of the Pipkin, or do you do a plating of the femur plus a fixation of the Pipkin and maybe also a certain wall fracture? What is the majority of you would choose?
Professor Josten, is the knee all right? Is the knee and the distal femur all right? Or
yeah, that's all right.
Yeah, we didn't see the X-ray on that. That's why I asked.
Some comment from the orthopedic surgeon. Christoph, if you start with a nail and then do it everything in a one-stage procedure, all the management of the Pipkin fracture is much easier because you have only one big fragment when you want to keep the hip joint reduced. So I would start with a femoral fracture with a nail, and then correct the acetabulum and the Pipkin fracture in one procedure.
The question is, how do you want to fix the Pipkin? By a posterior approach or by the Smith-Patterson approach?
If the patient is young, I would go for the Pipkin, not to sacrifice the blood supply with the Smith-Patterson, and then you have to fix the posterior wall with a posterior approach. So this is a lot of surgery.
Yes, Michael, this is too much surgery. I would suggest to make anterior as well as posterior approach. This will for 100% destroy the last option of blood supply of the head. So you see, the problem with this fracture is just a strategy. We have a consent that we have to tackle the pipkin, but as Christian KRETTEK pointed out, the chance to survive or surviving of the hip is quite low. But on the other side, the patient is too young for primary arthroplasty. That is clear.
So the head is dislocated posteriorly, so you can approach it easily from the posterior side, yes, and have already your in-flight into the femoral shaft for the fixation. So everything is in one place, and it's a welcoming simultaneous procedure.
Yeah, this was also our philosophy. Thank you, Christian. We started with the Kocher-Langenbeck approach, and as Michael, Professor Wagner pointed out, the question is: do you stabilize at first the femur, or do you tackle at first the pipkin fracture? Our choice was at first the pipkin fracture, because this was a critical one. It's easy to reduce the femur, but it was not 100% sure how we can reduce the big pipkin fragment, and can we reduce and can we fix the hip in the acetabulum. So we started with a Kocher-Langenbeck approach. We at first made a screw fixation of the pipkin fracture, and there was a rim fracture of the posterior wall, which was fixed by a small plate, and then we made the nail. You see, this is a postoperative CT scan. You see, what is good, what is not so good.
The problem is that this is some sort of a very high energy fracture, and you have this ping pong effect, ping pong ball. You have the compressed cancellous bone, and here's a cortex, and it's a big biological problem here.
I agree. The problem was the reduction is quite good, but nevertheless there was still a small gap. There was also a lesion of the cartilage, and of course, if you look very correctly, there is not an optimal reduction. There's a small piece inside left, and there's also, you see, a bigger distance of the interarticular gap. That means I have been quite happy with this operation. I would not say it could be done better. Maybe that one of you would have made a better solution, but it was okay. But you see, as Professor KRETTEK told it out, we have a damage of the cartilage here. We have a damage of the cartilage here. We have a small gap. But again, to Michael Wagner, Michael, would you make another procedure, or would you say, okay, you would stay and leave?
I would stay because if you revise it, it will not improve your vascular supply, and this probably will end with osteoarthritis. So you have reconstructed the cup or the acetabulum, so later total hip replacement will be very easy. So I would not touch it again. Otherwise, I would be a little bit concerned about infection.
Yeah, this is absolutely correct comment. From my Indian friends, any other suggestions?
No.
No, because the chance of AVN is going to be higher by any interference, and either way, you may still get a post-traumatic OA. So it's probably not worth doing it now. So I will rather wait.
Okay, thank you. Yes, you see, this is 4 weeks after the operation. Any comments? Yes, you can be honest. This is also not an optimal nailing procedure. You see, there is a certain gap here, and also you see the gap here. So, and this is after 4 weeks. After 5 months, we have a progressive arthrosis of the hip joint. You see the narrowing of the articular surface. And this is after 1 year. And after 1 year, you see there's an increased collapse, as my colleagues mentioned it before. There was a necrosis of hip, and also you see it here. And after one and a half year, you see we have had 2 problems. We have the problem in the hip, and we have a problem here with a non-union. And now this is the thing what we have to talk about. Tackle at first the non-union, or tackle at first the arthrosis and the problem of the hip. So you see, as a patient was quite comfort with the hip joint, and I said there is no chance to make hip arthroplasty with the existing pseudarthrosis of the shaft. I decided to make at first an additional osteosynthesis of the pseudarthrosis and to treat it. Would be there any other suggestions?
So, Justin, don't you think the nail was pushed too much inside in the first place?
Yes.
Why was it done so, number one? And number two, are you happy with the single lock that you have done?
Yeah, Ajif, this is a very precise question. In the combination of this fracture, I realized that I chose a nail which was a little bit too short, and you see here also in the nail ended quite high above the knee. So my mistake was to choose a quite short nail, though I made a much more deeper entrance here. And I said, okay, there is a gap. I make a gliding hole, 1 screw, and this gliding effect occurred, but this was the reason in this combination. It was a long time of operation. At first, the Pipkin fracture, then the wall fracture introduces a nail. So finally, I made this wrong compromise with the nail. Do you accept my apologize, Ajif?
You are too big a man that.
I would like to comment as a starting point. The problem here is relatively lateral starting point, breaking out medial cortex.
Not, but it's too lateral.
Yeah, and this is, if you look the pictures before, this is broken here. So when you end up breaking, you have a high stress to the medial fragment, which is easy to, which compromises the medial wall.
Yeah, absolutely correct. But nevertheless, it was done so. Not always I make 100% good operations. Sometimes they are also mediocre. This is the fate that we have as surgeons. But this was after 2 years and 5 months. So 7 or 8 months after this, you see my idea of increasing the stability in this pseudarthrosis worked. We had been happy with the healing of this pseudarthrosis, and then I removed the nail because I had to make an arthroplasty, and this was done 1 week after removal of the intermedullary nail. Why I didn't do it in one stage? To remove the nail and make in one stage the arthroplasty would be logical. Any idea? Or would I have make the patient a higher bill with 2 operations?
No, but if you do it in a 2-stage procedure,
maybe
you do not have so much danger from infection. Many of these implants are a little bit infected, as we have seen with sonification. So whenever it is possible, do it in a 2-stage. It's safer. More on the knee than on the hip. But I think it's better to do it in a 2-stage.
Yeah. Thank you for this explanation.
When I would have done another thing.
Yes.
I would have treated the non-union, if it is not infected, with a retrograde nail, and would have inserted a short stem total hip replacement.
Okay.
Maybe 1-stage procedure. But I know I'm a little bit crazy.
Yeah. Professor KRETTEK?
I have a question to this picture. What happened here? Is the prox shaft exploded, or did you know this?
Yes.
Can you see my?
You mean here?
Yeah.
Yeah, yeah.
What happened?
This was interval happened, but it didn't had a further complication. It's absolutely, I was had been aware of this, of course, but this healed uneventfully. But I come back to the comment. This was my reason that I looked for the infection, that we looked for the nail, whether there is a slow infection inside. That was absolutely the reason that we made a 2-stage procedure after we have been sure that there was no hidden infection in the canal as well on the implant. And after we got these results, we made the arthroplasty. And again, for the idea to make a 1-stage, to make a retrograde nail and a short stem arthroplasty like in this picture, this would not solve the problem with the infection. So for me, the main reason was to be sure that there is no infection in the canal and not on the implant. Yeah, thank you. This was my case.
Thank you. Thank you, Professor, for your presentation. Next, we have the third case by Dr. Rajendra. Yes, sir. Can we share the slides, please?
Yeah, thank you. Before I proceed, Rajiv Naik, you're all here. I deeply appreciate that critical analysis of the alignment of the fracture femur, which Professor KRETTEK presented earlier, with that minimal varus, which was not even noticeable on those first X-rays. In the Indian scenario, would you really think of doing those changes? I'm honestly asking this question to the audience, to my Indian colleagues who are here. I deeply appreciate the critical analysis, but in our Indian scenario, would you like to really revise like that?
No.
Is it?
No.
Yeah. So I think we are lagging behind in the critical analysis of all our fractures compared to them. So that's where I think we need to jump higher up now. So this was the good message given by our German friends there. So
but I suggest you ask them this question. How many of them will revise that?
But he has revised it and shown it to you.
No, correct. How many of the Germans who do it? You ask them.
Yeah. Are they audible to us now? Am I opening a Pandora's box by asking? Okay.
Yeah, you ask them anyway.
Professor KRETTEK, sir, are you there?
Yes.
Can we get them online? Yeah, sir, I'm sorry. You must have heard of us, what I just spoke. And we deeply appreciated your critical analysis about the alignment. But in Indian scenario, I would never ever dreamt of redoing that as you have done it. My colleagues here in the panel are asking you a question. How about your other German friends? Will they analyze it so critically? Will they redo it again?
It's a good question. Maybe the other German friends can answer this.
Yes, this not routinely. I would make a long leg picture after the operation. So I didn't realize this malangulation also in the picture. So I would decide this on the clinical situation. If the patient has a certain varus when she is mobilized, I would go in a long leg picture. But of course, normally we make intraoperative controlling with a cable. This we do routinely. And of course, if we would detect this malangulation intraoperatively, then we would go in a primary correction during the operation.
Okay, that's the message. So, Rajiv, I think we need to catch up with them in all these improvements. Okay.
Prof. SCHATZKER, we welcome you to this meeting. So also Professor Sergio, both of you are welcome.
Okay. Can I have the first slide? Okay, earlier to this.
Go ahead.
Yeah, I'm sorry. Okay, you see this distal femoral fractures. It's sometimes can be a nightmare to even a practicing experienced orthopedic surgeon, however experienced they may be. When everything goes well, nobody thinks about the complexity and applied biomechanics, okay, of this difficult fracture. When non-union gets established, then one realizes how difficult to treat this non-union. It is not unusual that it may require several surgeries on several occasions. The purpose of this talk is not to impress availability of new implants, but a simple concept which surprisingly not being used in the past in spite of its strong biomechanical principles. Can you change the things? Yeah. I encountered this situation here while in trauma.
I suggest you ask them what they will do.
One minute. Before that, you see, I would deeply thank our trauma courses, which they really taught us so much. And we took home the Professor Wagner's statement there. Now, this is a gentleman, age 44 years, presented to us with a history of road traffic accident. It was a closed fracture, no neurovascular deficits, type C2, probably with extensive metaphyseal comminution, though not much of intra-articular comminution, obviously indicative of a high velocity. So, sir, what would you do in this case? Could I put that question to the panel?
Professor JOSTEN, would you take this case up?
I don't see. I don't see only a very small picture. I don't have full screen, so I can't realize the X-ray.
Can we get them online, please? Professor JOSTEN?
Professor JOSTEN, what would you do?
At the first glance, I would go in this picture for a plate fixation of this. How old is the lady?
44 years, gentleman.
No, with a plate fixation for this fracture.
A distal femoral plate? Locked distal? Okay. Any other set, Professor Wagner?
No, it's a little bit depending on the soft tissue. It's a high energy trauma. If the soft tissue is bad, I would do external fixator.
No, the tissue is fine, sir. Absolutely. It's a closed fracture. Skin is perfectly all right.
Okay,
No
and no
external-
damage of the.
No,
okay.
no damage of the skin.
Okay. Then I would do a CAT scan, and then I would do internal fixation with with the plate, as Christoph Josten has mentioned.
Okay. Now, this is what we did.
Professor SCHATZKER, you are there for this?
Yes, good morning, gentlemen.
Good afternoon, sir. Thank you. Okay, this is what we did. We fixed it with a concept of MIPO. Through a small lateral parapatellar incision, the joint was exposed to anatomically reduce the articular components with 4 mm cancellous screws and fixed it with a low femoral condyle lock plate, once again sliding under the big muscular bulb. Overall mechanical alignment was satisfactory. Medial cortical alignment was satisfactory with no significant fracture gap. Plate was sitting flush on the bone and mechanical access was very much acceptable. We hope this would go for primary union. Okay.
So is it okay?
1 minute. But unfortunately, you see, we were happy with the fracture stability and started the knee mobilization immediately. But this patient had a lot of paramedical free advisors. So the knee mobilization was a little problem. Sir, is this okay, sir? So Professor Wagner?
No, I cannot clearly see it on the screen. There obviously is some valgus deformity, but it's difficult for me to evaluate because you see the reduction of the fracture is not really perfect.
The joint part of it, or are you talking the metaphyseal part, sir?
The metaphyseal part.
Are you happy with the joint part? The joint in...
I cannot see the joint really properly. But maybe this is due to internet transmission.
Okay, I'm sorry about that.
Put it to others. Put it to others.
Yeah, sir, Professor SCHATZKER is there, and we are very fond of reading Professor SCHATZKER's book. You know, it's a Bible for us. Sir, your comments, Professor SCHATZKER.
Very difficult from the picture that I see, but the reduction, I can't really comment on the intra-articular restoration because it's inadequately demonstrated, and the reduction is not proper because there's still a valgus deformity.
Okay, how could we have bettered on that, sir?
Well, to have done it technically properly from the start. It's not being facetious, but the first thing that you have to pay attention to is get an intra-articular proper reduction.
But are you happy with that, sir? That intra-articular reduction?
Well, I can't comment on it. Unfortunately, it's not properly demonstrated.
I'm sorry. Okay, that's all we could get on that. I'm sorry about that.
But let's assume that is all right.
Yeah, the joint...
The metaphyseal, well, the axis has not been restored, the legus and valgus.
Okay.
And we don't know about the rotation.
Yeah, I mean...
In all probability, there is also a rotational malreduction. And as far as the actual biomechanical construct, you are splinting this, and you hope that it will heal with callus formation. I think that you have created a short segment. I'm not commenting on the length of the plate. I'm happy with the length of the plate, but the distal screws, or I should say, proceeding from the fracture to the diaphysis, these two screws are creating a very stiff construct.
Okay, a rigid construct. The proximal screw, I mean, the distal screw of the proximal fragment?
Yes.
Okay. This is 3 weeks old. Still no, just a post-op check X-ray. Any comments on this now, sir?
Well,
we could see a little bit of translation on the metaphyseal part.
Well, I would say there's a little bit more than a little.
Yeah, the earlier one.
It's malreviewed.
Yeah.
And one of the basic principles, even though we are relying on a bridge plate and splinting, you still have to restore axis, you have to restore rotation, and attempt to minimize the gap between fragments.
Yeah, can you just highlight us how do we reduce those gaps on the medial side, sir?
Well, if you have restored the axis, and the key is that the lock plate, your central screw has to be absolutely parallel to the joint surface. And if you look at it, you see that it is not. So this is the first step where things have gone wrong, because you have attached the plate in valgus to the distal fragment. And this, once you do this, then of course the malreduction will follow.
Night girl, only Raya.
Okay, and now this is a photo. Can you just increase this thing of that slide, please? Yeah, this is 14 weeks post-op X-ray. Patient was in between followed up regularly. No signs of union. Patient still comfortable. No pain. No evidence of any infection. All the blood parameters are normal, except quadriceps power was really good. But of course, flexion we were able to achieve only about 70 degrees. Patient was still non-weight bearing. And well, I had 2 lifelines left. My first lifeline call was I went to Rajiv Naik and my friend Manjunath, what to do. Then, of course, he advised us, let's take a valgus stress X-ray and a CT scan. Now what should we do, sir? Now, what do you suggest? Professor Wagner, sir?
No, I would also do a CAT scan, and then you also can evaluate the joint reconstruction. And still there is a lot of valgus deformity and not very much callus around. And you have to plan a major reconstruction of this previous osteosynthesis.
So should we, we were aiming to get a fracture union somehow. I will come to our Indian scenarios when those happen, but we were aiming to get a fracture union at, more important. Is that right? Rajiv, are you okay? Okay, now we asked for a stress X-ray of a valgus stress X-ray and CT. Okay, that was the valgus stress X-ray. We could appreciate a little bit of mobility at the fracture site. And this is the relevant CT scans. I've just posted the relevant ones. Now what, sir? Professor Josten?
Yes, at first I'm very happy to see Joseph CHRISTOPH after a long time, and he's even younger than we all here. Many greetings to you, Joseph, and your wife from Germany. Thank you. And again, as Professor CHRISTOPH pointed out, the problem was this incorrect reduction. But now this is unstable. And this is not an optimal osteosynthesis because, as Professor SCHATZKER told it out, it was a mix of rigid fixation proximally and elastic one distally. So my philosophy is, in this case, is if you are going to pseudarthrosis, you have to leave your philosophy of elastic fixation. I would go in an absolute rigid, stable fixation, staying in the same implant. And perhaps, as it is an open one, to make a second plate a little bit more anterior in this case. So I would stay in this situation, make a rigid new plate fixation, and maybe an additional medial cancellous bone plus an anterior plate to give more stability.
Should we have put a medial plate in the primary itself, sir?
No. It's not my philosophy in a primary one.
Professor SCHATZKER, sir, your opinion on a medial plate in the initial phase when there was a medial instability?
No need for the medial plate if you reduce the fracture properly.
Okay, but the general, Rajiv had left with one lifeline, and there was a teaching from one of our German friends that after fixation, you give a valgus strain, and if you notice any sort of instability on the medial side, go ahead and put a primary medial plate. Is that right, Rajiv, on the panel?
Sir, what we used to do was, once we fix it laterally, percutaneously, then put a valgus strain and check it under the C-arm. And if there is a mobility, then go ahead and fix it medially. Mm-hmm. This is what we used to follow.
I know, sorry, that my Indian friends are quite in favor of medial plates more than we are doing in Europe or United States. I agree with this. This is a kind of philosophy. And I know that there are a lot of good orthopedic trauma surgeons which are doing it more routinely, but it's not the case in my school here. Yeah.
Professor KRETTEK, what would you do?
I would like to get a more clear CT scan, 2D CT scan projection of the distal articular surface, longitudinal sagittal views, very nice coronal screws views in order to judge alignment. I have no clear picture of the topography between medial and lateral condyle. When I look on the right lower corner here, this seems to be one condyle, and the other one, as a lateral one, looks very. Can you go? Do you have scans which go more distal? This doesn't look harmonic as a posterior surface of the femoral condyles. Usually they are wider, and as they're also it looks like a translation here. So this would be the prerequisite before I think on non-union management. I would careful and analyze. I would like to have a careful analysis of the distal articular surface.
Sir, our opinion on the joint stability and union was, we thought was all right, that fracture at the joint site was united. Only in the metaphyseal was the problem for us.
Okay.
So I'm sorry, I don't have those relevant CT to show you the joint part of it.
Evening, friends.
But the joint part of the fracture was united.
So you have two big pieces, and you need to treat as a non-union. Correct alignment, debris is the non-union gap, and fix it according to alignment principles.
Yeah, okay. So what to do now, sir? This is what we did. So what to do now? So we proceeded and we went ahead. And this is what we did. We removed some of the screws from the proximal shaft, got rid of that rigid fixation, hoping to allow micro movement at the fracture site, stabilized medially with a small DCP plate, hoping to offload the varus stresses at the non-union site, and thus the medial plate neutralizes the bending forces and promises bone healing. We did a little shingling and of course, we added a bone graft from the ilium. In short, we did everything possible. This is because in Indian scenario, if the patient agrees to come back to the same surgeon for a second surgery, we are blessed. So fortunately, we thought, okay, we should do everything possible on earth for the fracture to unite. And this is what we did. Now, any comments, sir? Professor SCHATZKER? We have added bone graft, iliac bone graft, medial plating. We removed a... Yeah, please go ahead, sir.
You are accepting something that is bad, and I can't understand why you are not correcting the problems that we have outlined.
Yeah, sir, that's initially...
You're going to do... Well, if you tell me that this is all that you can do, this medial plate should be longer. You should get much better purchase on the distal fragment, because what you are doing now, you're trying to establish absolute stability in order to get a non-union to heal.
Yeah.
There's no micromotion. When you're dealing with a non-union, you're now going from splinting to absolute stability.
Yes, sir. That's why initially when I started the subject, I was appreciative of the deep critical analysis you were all doing, which we were overlooking quite easily. So I think we need to take that message back to all our colleagues here so that we look into those mechanical axes very much. But anyway, we did this. And for this dual plating, do you agree with our supplementation of bone graft here, sir?
Yes, the bone graft, of course. But
because, yeah.
The bone graft alone is not going to salvage this, because you've left it unstable and there will be motion.
Okay.
And
anyway, now we followed it up. We didn't do anything further more because getting a third chance is virtually impossible in our Indian scenario. And this is the next slide. This is 7 months post-op. Some promising signs of union. Fracture has begun to unite. And we were quite happy with this. There was no signs of any implant failure anywhere. And graft progression was fine.
What has happened to the patella?
Beg your pardon, sir?
It's a patella baja.
Yeah, patella is very low.
Rajiv, can you answer that?
He's saying patella baja.
Yes.
I'm not.
Michael, this is a typical problem when you make a more anterior lateral approach with a plate. And you see the plate is, and you make an incision mostly along the ligamentum patellae. And during this, the ligamentum patellae will get scarce and will shorten. Therefore, you have quite often a patella baja if your lateral plating approach is too much interior. So this is, I see it quite often, but this is related to the attaching the ligamentum patellae during the reduction maneuver and anything else.
But the next problem will occur with this problem, because if you convert it to total knee replacement, then the next problem is starting. Patella baja in total knee replacement never gives a good result.
Absolutely right. And you get even a rupture of the ligamentum patellae. This is a quite often a complication after arthroplasty in trauma.
Okay, we need to take a lot of take-home messages. But
Rajendra?
Yes, sir.
Can you show the beginning X-rays to see where the patella was?
You want me to go back to the first X-ray?
Yeah, just to see whether the patella baja came after surgery or was it there before?
No, there was no patella baja in the initial phase, sir.
Okay, fine.
Yeah, this is a 1.5 years follow-up. Of course, we were looking at the fracture union. Fracture is well healed now, and patient is full weight bearing. Only thing is knee motion is restricted to about 70 degrees of flexion. That's because of the little physiotherapy which he was not doing much as we had advised. But this was the final picture. And we take a lot of take-home messages from all your suggestions, sir. I'm sure for our next surgeries we promise to do with on a better scale. We did follow up with one other X-ray like this with plating, and we went ahead with the dual plating. Comments on this, sir? Professor Wagner?
The reduction is better than the last one, but there is we call adlatus displacement.
Okay. Anyway,
the distal fragment is a little bit too medial. And there is maybe also some flexion deformity. There's a lot of effusion in the joint because the distance between the femoral condyle and the patella is very high. Hematoma has nothing to do in the near of osteosynthesis. But these are very difficult cases, I agree. It's very easy for us to give good suggestions.
No, sir, that's why at the first of my starting, I said your critical analysis is what we really need to take home. And I'm sure this will give us a lot of teaching. And we really appreciate that. Anyway, this fracture healed well and went on to heal. With these things, I think there's a little take-home message. Non-unions of distal femur can be a very difficult situation. Understanding the biomechanical principles to neutralize the stresses which are detrimental to fracture healing is absolutely vital. Implants may come and go, but sound basic principles hardly change in our lifetime. First surgery is the best surgery. It is the best time. Take your time to do a proper job. Remember, failed surgeries are worse than no surgeries. These are all our lessons to our youngsters here. And we thank you all for giving us a nice teaching, sir. Thank you.
Thank you, Professor Rajendra, for your presentation. And before we go on to the next session, there are a lot of questions by the audience online. So I would request Dr. KRETTEK and Dr. JOSTEN to answer them on the chat of the portal. So next,
yeah, can you have only one question out? Because time is going short. You can just stick to one question.
We will have it on the chat box of the online portal.
Yeah. Keep it on. My next small video, Rajiv, sit for a while. My next small video is worthwhile watching because we have had the best of the senior professors on the panel, both from all over the globe here. Now, I request this 2.5 minutes video, a non-orthopedic video, to just go on. Can you just put on the video? It's just a casual where we stand in this universe.
Sorry, Rajiv. I have to leave now.
So, thank you.
What's our background?
No, nothing. Just a minute.
They're showing that.
Okay, thank you. I'm sure this will humble all of us. It's just a video to show. Thank you. Thank you all.
Thank you, Dr. Rajendra, for that wonderful video. Next, we have Professor Hamantaya oration, which will be rendered by Dr. David Rajan, who is online. I would like to invite the panelists, Dr. Madan Ballal, Dr. Avinash Parthsarthi, and Dr. Srinivas Reddy on the dais, on the stage. Yeah, before we ask Dr. David Rajan to speak, I would like to request Dr. Madan Ballal to give a brief introduction about Dr. David Rajan, sir.
Good evening, sir.
Dr. David Rajan, can you hear us?
Yeah, very well. Thank you. Sir. So you're online, right?
Yes, I am. No, I'm not in the golf course. I'm in the theatre.
It is my honor and privilege to introduce Dr. David Rajan, sir. While he needs no introduction yet, it is a proud moment for me to do so. Dr. David Rajan qualified from Christian Medical College, Vellore, and went on to complete his orthopedic training from Madras Medical College. He was trained under great orthopedic surgeons like Dr. M. Natarajan and Dr. T.K. Shanmugasundaram. He developed interest in sports medicine and arthroscopy during his brief stint in the UK. Arthroscopy was just evolving at that time, and Dr. David sir is a pioneer in this field. He is one of the first to introduce arthroscopy to us, which became a trendsetter and revolutionized the faster recovery of sportsmen from their injury. He was also the president of Indian Arthroscopy Society and president of Tamil Nadu Orthopedic Society. He has conducted several arthroscopy workshops and live surgery meetings. One such distinction was first ever shoulder arthroscopy and live surgery workshop. In the year 1995, the faculty included Dr. Yap Willems and Pascal Ballot. Now he runs the Ortho One Orthopedic Specialty Center, which is known for its high standard and exemplary service. He is extremely happy and proud that several other orthopedicians from Bangalore, including me, were trained under him. I had the privilege of learning from Dr. Doyne himself, and he is not only the best teacher, but also a most humble human being I have come across. My first year of training under him was one of the best years, and he has not only taught me, but was more of a friend as we would play sports in our leisure and time and have a meal at his house. We are lucky to hear him today, and we sincerely thank him for taking out time from his busy schedule and accepting our invitation to deliver this prestigious oration in memory of our beloved professor, late Dr. Hanumantaya. Over to you, sir.
Thanks, Madan. Thank you, Venkatesh, and distinguished surgeons in the dais. It is a great opportunity for me to participate in the BOS annual meeting and deliver Dr. Hanumantaya's oration.
David Rajan, can you share your screen?
Dr. Hanumantaya's picture now or later?
Can you please share your screen, Dr. David Rajan?
Yes, I... Share the screen?
There's a green button in your bottom. Yeah, it's working. Division, click on open. Or double click on that file. Yeah, it's working. You can start.
Yeah, when do I introduce Dr. Hanumantaya?
You need to do it now, sir.
Yeah, sir, you will project Dr. Hanumantaya's picture.
Yeah.
Well, you can. Dr. V.H. Hanumantaya was born on 4th July 1935 at Vajrahalli village in Sira Taluk. He completed MBBS with distinction in the year 1960 from Mysore Medical College and master's degree in orthopedics from King George Medical College, Lucknow.
Sorry, Dr. David, can't see Professor Hanumantaya photo. I think the slides are
you
not.
are supposed to project. Can you project?
Okay, go ahead, Dr. Rajan.
Yeah. He worked as an assistant professor in orthopedics at Mysore Medical College until 1969, and then as associate professor in orthopedics at KMC Hubli and Bangalore Medical Colleges until 1972. He further worked as professor and HOD of orthopedics at medical colleges in Bellary, Mysore, and Bangalore. He was awarded Colombo Plan Fellowship to stay at Glasgow University, the UK, in aesthetics and rehabilitation. He worked as director of Sanjay Gandhi Accident Rehabilitation Center before he took voluntary retirement and started an accident care and orthopedic hospital, first of its kind in Bangalore. As a teacher, he taught both undergraduates and postgraduate students in orthopedics for over 30 years. He was an examiner for undergraduate and postgraduate students at the above universities. Oh, thank you. I used to know Dr. Hanumantaya personally, so it's a great honor to present this oration to the Bangalore Orthopedic Society. He was the founder, president of Bangalore Orthopedic Society, as well as founder, member, and later president of Karnataka Orthopedic Association, and guided its proceedings in the formative phase. He also conducted KOA annual conference chairman and organizing president at Mysore. He was the executive committee member of Indian Orthopedic Association for 6 years. He also conducted the annual meeting of IOA in 1994 as organizing secretary of IOA and was elected vice president of IOA in the year 1995. So with this, I would like to start my oration. So thanks again to Madan, Venkatesh, and others organizing people for Bangalore Orthopedic Society meeting. It was a great honor given to me because I knew Dr. Anumantaya personally. Before I start my talk, I would like to thank Manish and Hakam for organizing this talk for me. And the slides, I have borrowed some from my colleague, Dr. Santosh Sahanand. I'm aware that general orthopedic surgeons are here and attending this meeting, so I shall try and keep it as suitable for them. I'm going to share my experience, not quote too many papers and statistics. Today being Saturday evening, I should be playing golf. Since I'm deprived of my opportunity to play golf, I'm showing this background to you. Although Coimbatore Golf Course does not have a seashore at behind. Anyway, thanks, Madan, for this opportunity. How do you go to this slide?
David Rajan, can you share your screen again? Click on the share screen again. Okay, it's okay.
So meniscus repair, my journey. Since 1983, I've been doing and dabbling with arthroscopy, with a telescope which I bought and doing scopy whenever I could. Then I started doing open ACL reconstruction in the year 1985. And in 1990, I started doing arthroscopic ACL reconstruction. You see the picture on the left and the right, and you can see this meniscectomy and ACL reconstruction done. The joint space is reducing. This is what happens eventually whenever you do arthroscopic or open meniscus excision. You all are familiar with this picture of blood supply to the meniscus. This picture is from Stephen Arnowski's work in the early 80s. And meniscus was thought as a vestigial organ and avascular. It is not so. It is got vascular supply and therefore amenable for meniscus. But tens of years we've been excising it, and that led to a lot of osteoarthritis of the knee. I started off with open meniscus repair. In the year 1885 onwards, when I did open ACL reconstruction, when the meniscus was amenable for repair, I always made an opening and passed a few sutures and managed to repair the meniscus. But it was tedious, and once I started doing arthroscopic reconstruction, I started doing arthroscopic meniscus repair also. You can see some of the olden time pictures, and below is a mulberry knot of absorbable suture. On top, you can see that the meniscus is repaired, and the knot is tied externally outside the capsule, extra capsula. And then came the inside-out meniscus repair system, and that came to stay. Even now, although it was introduced in late early 90s, that this technique of inside-out meniscus repair went on to stay. It is the most effective way of doing meniscus repair for most of us even now. So you can see in this picture, the speculum or spoon, which you keep it at the back by under release incision on the middle side or lateral side, so that your sutures can be passed and injury to the saphenous vein nerve or the lateral popliteal nerve can be avoided. You have zone-specific cannulas in the middle, anterior, and posterior, and so you can pass the sutures on all the three zones. I'll come back to this later on. And later, in the early 90s, it came the implants and like arrows and darts, which are supposed to be bioabsorbable, but not really. And it was very effective to repair the meniscus with a horizontal tear with the help of first generation and later on Bob shaft of the implant. But only issue was the head of these implants never got absorbed. So that led to injury to the articular cartilage. So this was also given up. So the modern day inside out cannula system is really sleek and most of them are disposable. Some of the ones you see here are again disposable, and these kind of inside out cannula system can be reused limited number of times. Once the all inside meniscus suture system came, we thought inside out cannula, the inside out repair will be abandoned. It is not so. Posterior 1/3 all inside is useful, middle 1/3 and anterior 1/3 inside out as well as outside in is useful. The workhorse of meniscus repair is inside out cannula system repair only, even now in spite of all inside the meniscus repair system. So I'll show you some examples, and this is an example of meniscus tear in the red-white area of the lateral meniscus posterior 1/3. And we used to regularly excise the meniscus until the stable part. And this is better than total excision of the meniscus, but it is suboptimal because even with this, you develop osteoarthritis in about 10 years, 15 years down the line. And now what we do is, even if we excise the meniscus partly, we will repair it as much as we can. It's a medial meniscus, complex tear of middle as well as posterior 1/3. It is being probed and the unstable meniscus is excised. There is a horizontal cleavage tear, which is not very stable, and this is repaired. If you don't repair it, it may form a cyst, may form further tear. You can see the switches being passed. We'll go to the next case. Bucket handle tear of the meniscus, especially on the medial side or even lateral side, was always considered as a tear which cannot be repaired. But now we don't spare them. We try to reduce them as much as we can. And this is a perfect example whereby it is tough to reduce the meniscus. In spite of all that, with perseverance, you can reduce the meniscus, although it is flipped. And once you reduce the meniscus, it is, as you see here, it is quite stable. But for a few fragments which are excised or debrided, the remaining meniscus is repaired. So this is an example to show you that no meniscus, unless otherwise proved, is irreparable. Most of the meniscus are repairable. You must go all out to repair. Here we have done inside out meniscus repair for the middle and posterior 1/3. And the posteriorly, we've used one all inside meniscus repair device. It is not enough if you pass the suture superiorly, you must also pass the suture inferiorly, so that the meniscus is really stable. You'll have to put the patient a non-weight bearing for a while. It may take a little longer while, but this is absolutely necessary or mandatory to repair the meniscus whenever you can. Oblique flap tear. And the one on the left is something which I did in the 2005 or 6 or 4, one of those years. It's an atypical meniscus tear of the lateral meniscus. You can see this meniscus tear in the junction between middle and anterior 1/3. If you do partial meniscectomy, it's going to be subtotal meniscectomy. That is going to eventually ruin the compartment. So I repaired the meniscus way back by inside out cannular system. Those days I used to use monofilament PDS. In this manner and repair it. So nowadays, this is a borrowed slide from my colleague. So nowadays, we do repair for these kind of similar kind of a tear, but the one single entry point at the back and multiple entry point in the front, and he calls it feather cap, crown cap, crown feather repair of the lateral meniscus. Hey, what happened in the background, bud? The reason why I'm showing you this, that whatever be the meniscus tear, you can try and preserve it. So it has to be preserved, otherwise it will be a shame, because patient will be developing osteoarthritis pretty soon. Especially when we deal with youngsters, we have to go all out to repair the meniscus. You may think the lateral meniscus is how will it heal, but I have seen personally that when there is a lateral meniscus tear, posterior horn especially, the tear, the patient goes away, comes back after 1 or 2 months. At that time, you do the scopy and you find that lateral meniscus tear has already healed. Nature heals it. It's a very vascular area, especially in the youngsters. So you make an attempt to repair the lateral meniscus every time. So next one is a root repair. I remember the root repair was not recognized by us in the 2000s, early 2000s. At that time, we used to simply excise the meniscus, and that resulted in continuation of pain, persistence of pain, and early osteoarthritis. Now we know that we have to repair the meniscus. We use whatever instrument is available to you, a suture passer or a scorpion or any one of those, and make a drill hole and fix it onto the tibia. So this way, the extrusion of the meniscus is minimized, and load bearing is possible through the meniscus, and thereby the patient is relieved of pain. The need for replacement of the joint is postponed drastically. So whenever possible, repair the root. If necessary, sometimes you have to do osteotomy also. So next one is an example of radial tear, posterior 1/3 in a 50 years old lady. And normally one would excise the meniscus. But nowadays we try to preserve the meniscus as much as possible, and that way postpone the need for a replacement. You will see in this clipping, several switches are passed the posterior flap. The extrusion is also corrected by sutures. This is what is known as centralization of the meniscus. Make a drill hole into the tibia and pass the sutures and tie them. It's a complex tear. It's a complex way of repairing in the meniscus. Age is not detrimental for meniscus repair. It all depends on the quality of the meniscus, especially in a situation like this, where there is a lot of articular cartilage damage. This meniscus tear will help this patient to continue to have her original knee joint. A ramp tear is very often associated with the anterior cruciate ligament insufficiency. Very often you find that pivot shift is more than 2+. Then you may find a ramp tear. Once you repair the ramp, the pivot shift comes down to 2, and then all you need is ACL reconstruction. There's a middle meniscus ramp tear. If necessary, you must also make a posteromedial portal or rasp the meniscus tear first, make it raw so that it will heal, then use the suture passer. There are some special suture passers available for the meniscus ramp repair. What's the time? And pass the suture? No. What is the time? Time lapsed. And repair the meniscus. If you don't repair the meniscus root, there is a chance of ACL reconstruction failing. So whenever necessary, whenever possible, repair the root. Always make it a habit to have a look at the root or the middle meniscus as well as lateral meniscus. So in conclusion, you will recollect that ACL injury, it was quoted as ACL injury is the beginning of the end of the knee. It is not actually ACL injury. There is little change in this. I would say the ACL injury, which leads to meniscus tear, is the beginning of the end of the knee. So you do the ACL reconstruction not only to stabilize the knee, but also preserve the meniscus. So when you do the ACL reconstruction, if you do not preserve the knee meniscus, the whole purpose of doing ACL reconstruction is lost. So go all out to repair the meniscus whenever you do ACL reconstruction. Only then it is beneficial to the patient, and only then it really works. The take-home message is meniscus repair is primarily to preserve the meniscus. I have heard a lot of debates going on. Should ACL reconstruction be done? And then somebody will say, no, I will not do it. I'll do conservative treatment. In other words, you can't leave the knee alone until the patient develops an irreparable meniscus tear and then do the ACL reconstruction. It's not done. So ACL reconstruction should be done early. ACL reconstruction is done to preserve the meniscus and thereby preserve the knee. To carefully read the MRI, only then you can plan. If it is a complex kind of a tear which you may not be able to repair, send it to the right person and plan the surgery. Have the proper equipments for insert out cannula or to repair the meniscus. You have to pass several sutures. Sometimes we pass up to 14 sutures inside out. Only then we are able to repair it along with all inside. You have to have all inside, you'll have to have outside in, you have all the equipments and all the instruments available and infrastructure available. Only then you must take up ACL reconstruction, because ACL reconstruction always goes with meniscus repair. Choose the right patient. You know, some of the patients may not be able to understand, then you better not do it. And you have to counsel the patient appropriately, because there is always 5 to 10% chance of re-tear. This the patient should appreciate and understand. Only then, even if there is a failure later on, he will appreciate the hard work that you have done. If it is a net savvy patient, you can make him understand very easily. So thank you very much for the opportunity. Thank you, Madan. Thank you, Venkatesh. And all my best wishes to the Bangalore Orthopedic Society. Thank you.
Thank you, sir, for an excellent talk.
Thank you, Professor David Rajan, for your talk. So, are there any questions from the panelists? Yeah. So, we will go ahead with the next session, which is the shoulder session. For this, I'd like to call upon panelist Dr. Satish Ravegar, Dr. Rudra Prasad, Dr. Mohan, and Dr. Chirag. Dr. Satish? All right, they'll join us shortly. So we have the first talk by Dr. SERGIO ROWINSKI. Dr. ROWINSKI, are you ready with your presentation?
Yeah, are you listening to me?
Right, so over to you, Doctor. You can start sharing your slides.
But I just want to know, are you listening to me nice?
Yes, we can hear you.
Okay, so can I start?
Yes, you can.
Okay, so just give me a second. Just give me a second. Just a second. Okay, so are you seeing my presentation?
Yes, we can see the presentation.
Okay, so I'm going to start. So hello, everybody. I'm Dr. SERGIO ROWINSKI, shoulder and elbow surgeon here from the city of São Paulo, Brazil. It's an honor to be here. I have a lot of friends over there, especially my good friend, Dr. Hemant, which is in the audience. Hello, my friend. And
Dr. Hemant Reddy, can you come on stage as a panelist?
Yeah, yes, he knows a lot about the topic. So the thing is, I'm going to show a lot of tricks and ideas based on real cases of real life to do this technique that I consider a revolution in the management of humeral shaft fractures. And so we will discuss cases, principles, technical aspects, pitfalls, and especially a lot of tips and tricks. Okay. So let's start here with this case. So this is a 21-year-old lady with a distal transverse fracture on the shaft. So a lot of people ask me, can we do anterior bridge plating in transverse cases? And the answer is yes. You can do in any pattern of humeral shaft fracture as long as you can put 2 screws up and 2 screws down. So many people would do here posterior plating, which I am absolutely against. Some nailers would nail in, but in my hands, I always do anterior bridge plating. So there are many messages in this case. First of all, I always use the longest plate available, which is as a standard, a 12-hole, 4.5 narrow plate with 2 screws up and 2 screws down. And I have been doing this for 15 years and always non-locked screws. This is the focus of the fracture site with an absolutely anatomical reduction. And this is the size of the incisions. I do very, very small incisions, and I'm going to show you how to proper position the incisions in a way that they become very, very small. So as an average, 3.5 centimeters up, 3.0 centimeters down, and in the distal part, generally, the incision shrinks. I'm going to show you many cases in a way that from a statical and cosmetical point of view, the incisions are very, very small. So this is 8 weeks post-op AP view. And there are many messages that you people have to understand. In this technique, clinical healing precedes radiographical healing a lot. I'm going to show you many examples. Callus starts from a radiographical point of view around 11 weeks, 10, 11 weeks. And when the patient is very young, like this girl, 21, you start to see some callus at 8 weeks. But we have to understand that in very young patients, it comes faster. When you do it in elders, I'm going to show you it, my last case, it comes slower, but in average adults, the radiographical evidence of healing appears around 11, 12 weeks. And I'm going to show you many examples. So this is 8 weeks post-op, in which we see here a starting callus, but again, this is not usual, because this girl is very, very young. The youngest the patient, the higher biological response, and hence, the faster you will see callus. And this is 4 months post-op, a lovely callus, and we have to understand that bone remodeling happens for months and years. It's written in Rockwood, it's written in Campbell, Jupiter's book, Rockwood. So if we saw this girl 4 months after, the radiographical appearance of the callus would be much different. But I have a lot of difficulty to keep these patients more than 5 months with me because they are so good from a clinical point of view that they have a huge tendency to disappear. But nevertheless, this is 4 months post-op view in which we see a lovely callus. And let's see the incision. So this is the proximal incision. And as I have said, there is some shrinkage in the distal incision in a way that it becomes very, very tiny, the distal incision. I have to reinforce, as many of my Indian friends have been asking me for these last 13 years, that we have many keloides problems in Brazil, which is absolutely out of my control. But nevertheless, there are very, very tiny incisions. But what about a good final clinical result, which is what we want in the end of the day? So let's listen to my conversation. I'm speaking in Portuguese and passing to English immediately, okay? Vamos lá. 6 months post-op, anterior bridge plate, você foi operado 29 de dezembro. Surgery 29 December 2016. Então, foi aqui assim, isso, ok. Foi aqui assim. Ok. Tá bom, dobra tudo.
Neu eingestellt, Conny.
Ok? Dobra. Tá bom, sobe a mão lá para cima. Tá, volta. Você quer fazer o quê? Só fala alto. Você quer fazer boxe? Boxe. Né? She wants to go boxing. Tá. Então, você quer ir pro boxe. E o braço dói? Não. Absolutely no pain. No pain. Absolutely no pain. Você nem lembra que tem uma placa aí? Não, não lembro. Não lembra. Ando de bicicleta, de moto, simplesmente. She rides a bike and she doesn't remember she has a plate. Tá bom? So that's it. She rides a bike. She wants to go boxing. She doesn't remember she has a plate. This is, when you master the technique, this is a wonderful way to manage these cases. So I do very tiny incisions. So many friends of mine in India ask me, how do you do so tiny incisions? So let's understand how to do very small incisions. You have to draw the skin properly and how to draw the incision. So I'm going to show it very slowly. So we always do this intraoperatively in the beginning of the surgery under C-arm guidance. So we have to imagine that what I am looking on the right side is not an X-ray, but a C-arm view. I'm putting an X-ray for pedagogical purposes, for things to become easier. But all of this process is done in the beginning of the surgery, always under constant and delicate traction to reduce the fracture and under C-arm assistance. So this is how I do. I always put the two penultimate screws, the two last screws on the tip, on the upper tip, on the inferior tip, and I do drawings on the skin. I'm going to show you on the next slide. And I do it up, I do it down, and this will be the space of my proximal and my distal incisions on the red arrows. And I always do this under traction with C-arm assistance. So this is what I see. I am under traction with C-arm assistance. The fracture is reduced. So under traction, I'm seeing on the C-arm, this is going to be hence my proximal incision, and this is going to be inferiorly, hence my distal incision. So where to locate the incisions from an anatomical point of view? So the proximal incision is always on the deltopec line. Okay, you can put a little bit up, a little bit down. It depends on the case. Each case is a different case. So my proximal incision, yes, it is on the deltopec line, depending on each case, but a little bit up, a little bit down is always on the deltopec line. And I do a little bit different than my Indian friends. My distal incision is always done. Pay attention, everybody. It took me many years to get to this, allow me to say, maturity point of view from an anatomical point of view. I do my distal incision in between the anatomical, I repeat, anatomical interval of the bicipital muscle units, the biceps brachii and the brachialis with the lateral triceps. So if we see in this beautiful image, this is where I put my incision. I have here the bicipital muscle units, the biceps brachii, the brachialis, and I have here the distal lateral triceps. And I always find the radial nerve, and I'm going to tell you why in a minute. And this is a beautiful view of the radial nerve. I have seen the radial nerve systematically in the last 15 years. I'm going to talk about that in a minute. So we have a very logical sequence to do this beautiful surgery. So I will do my both incisions, of course, and I have always to keep delicate and constant traction. I have one person in the surgery, an assistant, a resident, whose mission is to keep traction 100% of the time. You must be very delicate. This is a very delicate procedure, especially in the challenging distal cases that I'm going to show in a minute. you will connect both the incisions. How do I connect them? Always under traction with a delicate osteotome and even the plate. The 12-hole plate can be a very good instrument to connect the incision because it's very blunt. And people ask me from up to down or down to up. I prefer to do it from the proximal incision to the distal incision and always under traction. I repeat, one person is in the surgery to keep traction 100% of the time. So which is the hole with which I'm going to start? This is my magic. It took me 10 years to get to this point. So I always start with this distal hole. So this is my first perforation. I always put the distal two ones in the upper part, in the distal part, and I begin with the penultimate screw on the distal fragment because it gives me a lot of ease to achieve reduction. So what is the sequence? I will introduce the plate, always under traction, and I'm gonna put one screw in that penultimate distal screw, partially screwed. I will put the screw until the end, and I will come back in a way that the tip of the screw is gonna be in the middle of the intramedullary canal. Saying the same thing in a different way. The screw is going to be on the first cortical. This is a very important point. So after that, I will check reduction. I will reduce the fracture under C-arm control, always under traction. And then my assistants will drill the upper penultimate distal hole, which is this. I always start proximally and distally with the penultimate screw. And then I will put one screw there, partially screwed. So at that moment, both screws, they are only partially screwed. They are on the first cortical, because at that moment, I have length adjusted, and I will adjust varus and valgus, always under C-arm control. And then I will fix both the screws on the distal cortical, and then the surgery is going to be done. And I only have to put one more screw up and one more screw down. So it's been 15 years I do this, and 13 years my Indian friends have been asking me, what about the radial nerve? So the answer is, see, the idea is identify and demystify the nerves. I'm going to say it again. Identify and demystify the nerves. So when I'm doing the distal incision, I always put a Hohmann medially, a long and thin Hohmann, and I always try to see the radial nerve. I like to see it, it's very nice for me to see it from a psycho-emotional point of view. I am the surgeon. I know where it is, and I can put my instruments delicately. In the vast majority of the cases, I see it, and that's okay. But sometimes I don't see it, and that's also okay, because you cannot find it all of the times, but I find it in the vast majority of the times. I'm going to show many examples. So after that, you must try to avoid putting a Hohmann laterally in the distal incision. So I use these instruments. You can use a Farabeuf, you can use a Langenbeck, which is very, very useful to retract laterally the distal lateral part of the triceps. And this is one thing that I have invented, which is to put a long artery forceps as a lateral Hohmann to damage less. At least this is how I see the radial nerve. But sometimes you end up needing to put a lateral Hohmann. And many people say that this will cause a radial nerve palsy. This is a fallacy. This is not real, okay? So let's see a lot of radial nerves. So this is the radial nerve. This is again the radial nerve. Now we are seeing again the radial nerve. This is a right arm. This is a left arm, and we are seeing here the radial nerve. This is another case from the Amazon. Radial nerve, right humerus. This is another case in which we are seeing here a right arm radial nerve. This is another case from the Amazon too, left arm radial nerve. So you don't have to fear the radial nerve, okay? This is one message of this lecture. And the fact is, when you master this technique, you can go very distal, crazily distal. So let me show you how distal can we go. So this case is about a 23-year-old lady, very, very obese. Think with me, my friends, the size of the posterior incision and the soft tissue disturbance with a gigantic incision posteriorly. So the question is, can I put 2 screws down? So I can put 1 screw here, and I can put another screw here. And as I say, in distal cases, absolutely no place for mistakes. But I can put 2 screws. And this is another tip that I realized after so many years. As inconvenient as it may be, take personally you and the patient to the radiographic department. And then the surgeon will obtain an absolute left view in which I can guarantee that I can put 2 screws, no place for mistakes in the surgery. You cannot miss any drilling. But the answer is yes, I can put 2 screws. So this is the radial nerve on that surgery, very, very obese lady. And this is 1 week post-op. Many people say you cannot invade the olecranon fossa. This is another misconception. The olecranon fossa is posterior. I'm not invading anything anteriorly. And when I put the plate in a position distal as this, it will not bother elbow flexion. I'm going to show you very strong men doing everything in a worst case. So this is 1 week post-op, beautiful construction, minimal irritation of soft tissues. And this is 3 weeks post-op. As I have said, callus starts around 11, 10 weeks. But the mantra of the technique is, in anterior bridge plating, clinical healing precedes radiographical healing. As long as the patient is doing fine from a clinical point of view, I saw 3 patients this week because we do it a lot. And as long as the patient is doing fine, it's just a matter of waiting to see callus in the X-ray. So this is 7 weeks, absolutely nothing, but the kid was fine, no callus. And as long as the patient is doing fine, you just have to wait. I mean, fine from a clinical point of view. So pay attention in this. I see basically no callus, no signs of loosening of the plate. The lady was quite happy with her arm. And when you see 16 weeks, lovely callus, and we have to remember what Rockwood said, remodeling take months and years. So if I keep this lady for 1 year, 2 years, you will see a gigantic ball of bone. But I have said, as I have said, it's difficult to keep these patients more than 5-6 months with me because they are always asking me, Doc, I'm so good. Why do you want me to come back here? I have my job. I have my children. But anyway, this is 16 weeks. 16, some beautiful callus appearing. And then, as I am saying, just a matter of waiting. This is 20 weeks, a beautiful callus formation. And again, I have to repeat this. Callus remodeling takes months and years. If you keep on following this girl, the X-ray will appear better every time. And this is 20 weeks, the left view, everything going perfectly. And please think with me, my friends, see the size of the incisions and compare in this obese lady the gigantic incision you would do posteriorly. So I've been stating for 15 years, this is a revolution, and I'm quite sure that I am correct. So how was this girl 20 weeks post-op? So as I have said, we have some shrinkage phenomena in the skin. It's not a percutaneous technique. This is minimally invasive. We are seeing here a very good placement with the technique that I have showed you. And let's see the motion of this lady 20 weeks post-op. She is obese, as I have said. She's very satisfied. We are seeing here external rotation. Everything was okay. Now I'm going to ask her to put the hand behind, absolutely normal internal rotation. Forward elevation in scapular plane is absolutely okay. And she was very, very happy. This is what we want in the end of the day, a smile in the face of the patient. But can we go still more distal? So I'm going to show you the more distal case I have done in 15 years. So everybody would say, Dr. Sergio, it's impossible to do an anterior bridge plate here. You are crazy. Well, crazy I am. But I know that it's possible when you master the technique. So absolutely no place for mistakes. 26 very strong men, a car accident. I'm going to show you the final result. This is quite scary, but I trust the technique. So pay attention on the muscles. He's very bulky. He's a very strong man. I'm going to show you. And I have a personal way of conducting the post-op. We can discuss after. I'm not going to mention it, but because of time. But the thing is, it can be done as long as you can put 2 screws down. So this is the immediate post-op view. This is now 3 weeks, obviously no callus, but now I'm coming to a very important part of the lecture. 7 weeks, no callus, see the inferior part, the AP view, but I am saying all of the lecture. The mantra is clinical healing precedes radiographical healing, no callus. But how is this boy from a clinical point of view? Innumerable anterior bridge plate in clinical healing precedes and a lot radiographical healing. Let's listen to my voice.
São 7 semanas, 7 weeks, 7 semanas. Essa postura pode ser. Isso. Então vamos lá, cara. Dobra, flex. Isso. Estica. Não dói nada. Nada. No pain. No pain. Absolutely no pain. Tá bom? Dobra agora. Estica. Dobra. 7 weeks. Não, você está fazendo físico?
She was doing physical therapy.
Terapia? She's doing physical therapy. Ok, cara. Dobra tudo. Estica. Faz um joia.
So there is a message here. No callus in the X-ray, but clinical healing precedes radiographical healing. This is a mantra, okay? So this is 5 months post-op, the most distal case I have ever done in my life. Beautiful, beautiful radiographical healing. But many people say, what about the flexion? Does he has problems with the elbow? Let me give you the answer now. Please watch the video. 5 months post-op.
Vamos lá. 5 meses de pós-operatório, 5 months post-op. Frontman bridge plate. Sobe, levanta. Agora tudo, não dói nada. Põe as duas mãos atrás. Aí, volta. Vamos fazer uma pleque? Vamos lá. No chão. Isso. Isso. Aí. Não dói nada.
No pain.
Absolutamente nada. No pain. Absolutely no pain.
No pain.
Voltou. Beleza? Deixa eu só mostrar novamente. Tá. Faz um book aí. Ok.
Extremely strong man, and with all respect, I consider this a revolution. And this is my last case. I would like to have 2 hours to speak and show you all the cases, and but the thing is, I cannot talk 2 hours, so I want to talk a little bit about older patients. Many Indian guys tell me what is the limit in terms of age to do this technique, and then I'm going to come to my conclusions. So the thing is, in my opinion, as long as you have some biological response, you can go a little bit further. My limit is 70-year-old, and this lady is 68. So this is a 68-year-old lady with a short oblique fracture. This is the immediate post-op view. Another message here, a lot of people ask me, what is the minimal contact that we need to have in between the fragments? My answer is, I don't know. But in my 15-year-old practice, as long as I have minimal contact, we can do the job. And pay attention, everybody, in elders, everything go very slower from a radiographical point of view, and from a clinical point of view is the same. So this is the radial nerve of that lady, 68-year-old lady, absolutely nothing in the X-ray. This is 7 weeks in which I see nothing in the AP view and in the lateral view. She was good from a clinical point of view. This is 11 weeks. I still see basically nothing. And pay attention, everybody. Not much callus on the AP view, something on the lat view, but everything goes very slow. But from a clinical point of view, she was absolutely fine. Let me show you guys. 15 weeks, 68-year-old lady. So this is her external rotation, almost normal. She was having some pain in the shoulder and some difficulty to do internal rotation. This is internal rotation on the non-affected side. This is internal rotation on the affected side. Some pain in the shoulder, very good forward elevation, almost normal. And let's see the sizes of the incisions. This lady with some keloids, I cannot do nothing about it, but this is an extremely small incision. And about 3 centimeters up on the delta pec line, something like that. I'm measuring now with my pen. But she was very, very satisfied. She was very happy. And she was giving a thumbs up. And this is what we want in the end of the day, a happy and satisfied patient. But let's see this case radiographically. 19 weeks, callus only basically in the lat view. But when you come to 6 months, starting callus, she was absolutely fine doing everything at home. And as I have said in the beginning of the lecture, it's just a matter of waiting and everything will come from a radiographical point of view. So finally, 8 months, a beautiful callus in the lat view. And this is the last time I saw her. You can see here, callus, 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 medially, laterally in the AP view. It's just a matter of waiting. Everything goes slower from a radiographical point of view in the elders, but not from a clinical point of view. So this is the last day I saw her. Everything looks lovely in the lat view too. 68-year-old lady. Compare the size of the incisions with a posterior approach and think with me in the advantages of this technique. This is my last video. I'm coming to my conclusions. So this is the lady 9 months post-op. absolutely okay in forward elevation, elevation in scapular plane, external rotation. She was doing everything at home. She's a very good housewife, very decent lady. And still some difficulty in internal rotation. That was an issue in this case, and that's part of the game. But she, in spite of that, she was extremely satisfied. Again, I want to show you how we can manage very small incisions when you can master the technique. And no problems in flexion, no problems in extension. She was very, very satisfied. And this was the last day I saw her. And again, this is what we want in the end of the day, a smile in the patient's face. So having said that, these are my take-home messages. This technique that I have been helping to introduce in India since 2008 can be done in any pattern of humeral shaft fracture, what means diaphyseal cases, metaphysodiaphyseal proximal cases, and distal metaphysodiaphyseal cases. The magic is just one. As long as I can put 2 up and 2 down, I can do the job. Here, me and my friends, we use a very simple kit, extremely cheap, 12-hole long plates, narrow, 4.5 millimeters. 2 screws is enough. I have been debating this for 15 years all around the world. 2 screws, and many people are saying that they fear that and they want to put 3 screws, but I can guarantee to you 15 years of experience and my friends here in Brazil, 2 is enough. And as per our technique, we don't use locket screws. And this is my last one. What about musculocutaneous nerve? Don't worry, it's not there. It's not in front of you. You have to take care about the radial nerve. So this is my last message. The radial nerve, this is in Hindi, always respect, never fear. Identify and demystify the nerves, extremely delicate movements. Use my tip, a long curved artery forceps as a lateral Roman to give less, I would say, pressure on radial nerve. It's something that I think it's very usual, and be happy. So I just want to thanks a lot, Boscon, my good friends, Dr. Vansi, Dr. Rajiv Naik, Dr. Hemant, which is in the audience, and he is my brother. We have been working together for 10 years in our educational projects. This is my WhatsApp. I'm going to keep 10 seconds if people want to get it. And I kindly ask all of you who are interested in the shoulder and elbow universe, please subscribe to my channel. I'm regularly putting videos. I have 45 very pedagogical videos, all in English. And if you subscribe to my channel, I thank you a lot. Dhanyavad. And that's it. I'm going to stop sharing my screen. That's it.
Right. Dhanyavad, Dr. ROWINSKI. So before I ask the next speaker to share his slides, I would like to invite Dr. Hemant Reddy on the stage, please, as one of the panelists. Right. So the next speaker is Dr. Daniel MOYA. He is talking on treatment of acute acromioclavicular dislocations with coracoid cerclage. Dr. MOYA, are you online?
Yes, I am.
Yes,
Thank you very much.
Yes, you can start sharing your slide.
Okay. Ready. Thank you. I can begin whenever you want.
Yeah, you can start now, Dr. MOYA.
Thank you. Well, thank you for your invitation. It's really a pleasure and an honor to be with you. I will speak about a still very controversial topic, acute acromioclavicular trauma and acromioclavicular dislocations. We consider for surgery those patients with rupture of the acromioclavicular ligaments and the lateral coracoclavicular ligaments. I must state that we have been working in the role of the medial coracoclavicular ligament that we can see in the anatomical picture as participating in acromioclavicular stability. And I think it is a very interesting topic. But besides that, generally the cases that we need to treat are type 3 acromioclavicular separations, type 4, type 5, and are not very frequent to face the type 6. Treatment decision-making is still a matter of controversy. Rocco taught us that there are clinical criteria to consider. For instance, the age of the patient. We prefer to advise surgery to patients under 25 years old. And we also consider expectations and sport activity. Patients that have a job that is related to the use of the arm above the level of the shoulder, or for instance, overhead sport activity, make us also have a bigger tendency for surgery. But there are some other sports like rugby that in some way are almost a contraindication for surgery, because this kind of lesion is so common in rugby that the chance of recurrence would be very big. Basmania and Ben Kibler described another way to evaluate the decision, and they divided the acromioclavicular type 3, but we could also apply this to type 5 dislocations in two subtypes, A and B. A are stable and B are unstable. And it sounds a little bit weird to speak about a stable or unstable dislocation. But in fact, we can demonstrate that with some clinical tests like the cross-body adduction, in which we will see an overlap of the clavicle above the acromion. This can also be depicted in X-rays, as we see here on the right. So, in fact, and in summary, what we consider for surgery, especially in type 3 acromioclavicular dislocations, are young patients, overhead sports, jobs or using the arm over the shoulder, and when we can demonstrate a type 3B injury. What about the treatment timeline? Well, to speak, making a differentiation between acute and chronic is like speaking of choosing between reparation, repair, or reconstruction. And you can see here a reconstruction, a Weaver and Dunn procedure, where we have make an osteotomy of the distal clavicle and a transfer of the coracoacromial ligament. We prefer not to do this. We prefer repair and to recover the anatomy. But to do so, we need to perform surgery in the first 2 weeks after the trauma. Golke has shown that when we perform an early surgical treatment, we can get a higher constant score, a bigger chance of an anatomical reduction, less complications, and better patient satisfaction. What about resecting the distal end of the clavicle? Well, we prefer not to do so in acute trauma. If we can keep the integrity of the clavicle anatomy, it is better. We will have less complications. And what about repairing the coracoclavicular ligaments? Many authors don't even check or try to find the coracoclavicular ligaments, the lateral coracoclavicular ligaments, the conoid and trapezoid. Well, it has been demonstrated that if we repair them, the kinematics of the joint will be recovered in a better way. So we try to do so. But some people say it is not easy or it is not common to find the ligaments. I feel that if we perform the surgery acutely, the chance to find them is very high. Here we can see in one of our patients the trapezoid and the conoid ligaments, and we will find different tear patterns, but some remnant ligament will be there, and it is good to try to repair them. Some other authors have said that even if we repair them, they will not heal. But here you can see one of our cases, before and after surgery. You can see the result, and we ask for these patients a control MRI after 6 months, and we can see that the coracoclavicular ligaments are there. What about the decision of open or arthroscopic? Well, we know we can use both procedures, but still now the results are similar, and the open procedure has been demonstrated that it is less expensive and shorter, takes shorter time to be done. What about the containment method to use? Well, you all know there are many techniques. We think that the use of a non-absorbable suture is not a good idea, because with time we can see things, fractures like these ones, and the pins, even the threaded pins, have been quit from using because there were complications. And also the Bosworth or Rockwood screw. I trained with Dr. Rockwood, and I have seen screws implanted by Dr. Rockwood that also have a pull out and complications. I think that the hook plate is perhaps an indication for a reconstruction of a case in which we have a deficit of bone, but I don't think that this surgery is a good indication for a regular case of type 3 acromioclavicular dislocation. Now there are in fashion several techniques using buttons, especially for arthroscopic procedures, but we also see several complications with these cases and with these procedures, and there are many papers that have shown a high percentage of complications, like this paper, 50% of bad results, and many other papers that have shown that there are complications related with these kind of techniques. Even there are techniques, for instance, a graft rope that was reported to have near 100 complication, percentage failure. And I don't want to offer my patients these kind of techniques because I will get in problems. There are more recent papers, 22% complications, 44% complications. And I can tell you that after almost 30 years performing the same surgery, we have not had this experience with the cerclage around the coracoid. Some authors have said that the biomechanics of this procedure show that it does not give a sufficient vertical stability. But there are some other papers that have compared cerclage, tightrope, and clavicular plate, and the cerclage has demonstrated that gives more physiological stabilization. We use Rockwood's approach, centered on the coracoid process. Then we go through the fascia between the trapezius and deltoid, and we explore the acromioclavicular joint. We look for the coracoclavicular ligaments. We pass a suture through them, but not tight it. Then we pass 6 PDS sutures around the coracoid. This is an absorbable suture that takes around 180 days to disappear. We tied them, we reduced the acromioclavicular dislocation, tied the coracoid sutures, as you can see here, and finally tied the coracoclavicular ligament suture. Then we go to the acromioclavicular joint and we close the fascia, because the fascia is responsible for the dynamic stability of the acromioclavicular joint. This was my first case back in 1994. You can see above the dislocation of the left shoulder and in the inferior picture after surgery. This is the result. Another case before and after. You see the range of motion before and after. This is a doctor that I operated more than 20 years ago, and I am still in touch with him. And as you see, we do not leave any kind of hardware in the patients. You can see in this case the difference in the shape of the shoulder after surgery. This case was my youngest patient, an epiphysiolysis of the distal clavicle. The clavicle was displaced posteriorly, like in a type 4 acromioclavicular dislocation. Here you can see the distal epiphysis of the clavicle. So we performed the surgery. Here is the distal epiphysis of the clavicle. This is the distal shaft of the clavicle that you can see is displaced posteriorly. It was making a hole in the trapezius. Here we have the coracoclavicular ligaments, and this is after the reduction. This is the area of the epiphysiolysis. Here you can see the X-ray, postoperative X-ray. This in the center is the MRI before surgery, and on the right side you can see the MRI after surgery, where we can see the coracoclavicular ligaments. This is the range of motion. So as you see, it's a safe procedure, and it is not an expensive procedure. But it is also useful for sportmen. This patient was an Olympic wrestler, and he suffered a type 3B acromioclavicular dislocation, and we performed the same procedure, and after 4 months he was participating in international championship of his practice. So I think that this is a very useful, easy, cheap procedure, very reliable. I can tell you that after more than 30 years working on shoulder surgery, perhaps this is the most reliable procedure I can offer to my patients, and I feel very comfortable with it. Thank you very much.
Thank you, Dr. Moya. We'll go with your next talk, Diagnostic Error in Shoulder Pathology, Modern Paradox, and come back for the question and answers.
Okay. Well, thank you. We orthopedic surgeons have a tendency to speak always about treatment and always about techniques, but diagnosis is still a problem. And I say that it's a modern paradox because we have learned a lot in the last 20, 30 years about shoulder pathology. We have very powerful diagnosis tools, but still we face every week in our clinics diagnosis error. And that is really a problem that we do not measure. This is not only limited to shoulder pathology. This was paper that was a study that was done by a health agency of the United States, and one of their statements was that most Americans will get a wrong or late diagnosis at least once in their lives. We see on shoulder pathology that there is a loss of clinical examination. There is a loss of the art of clinical examination. Many diagnoses are based on complementary studies, and examination has a lot to give us as orthopedic surgeons and shoulder surgeons. Another reason is the system. This is a study on the left that was done in Japan, and they describe that an average medical consultation lasts 6 minutes. And on the right side, you can see a call to strike by doctors in Spain, in Catalonia. And one of the things they were asking was that the consultation should at least last 10 minutes. So this is an international problem. In the long chain of interaction between the patient and the doctor, there are many steps, and the treatment is just one step. You will see that we have many societies and congresses devoted to treatment, but we do not have societies devoted or dedicated to clinical diagnosis. The reasons for diagnostic error in shoulder pathology are related with many reasons. One of them is that shoulder pain is frequent, and many times there is not a correlation between the structural lesion and the symptoms. There are more than 90 differential diagnoses that have been described on shoulder surgery, on shoulder symptoms or shoulder pain. There is a high prevalence of pathological findings in imaging, and as I said, time devoted to clinical examination is becoming shorter and shorter, and of course, we must accept that there are some surgeons that are very aggressive with the surgical indication. What is making things even worse is that many other professionals are getting in touch with shoulder pathology and treating shoulder pathology. And there are many new procedures, treatments that are applied. For instance, we see things like this. This was a 40-year-old patient with 6 months trauma. You can see that he has displaced fracture of the acromion, a massive rotator cuff tear, and when he arrived to my office, he was treated with 6 PRP injections. So many other professionals are getting in touch with shoulder pathology, and they have a treatment, but they do not have a diagnosis. And this is a big problem for us. We must always consider that the shoulder is a place where pain coming from other areas is referred. We all know about the neck, but there are many, especially for young colleagues, visceral origins like gallbladder, heart, spleen, lung, and also ectopic pregnancy, for instance, that can refer pain to the shoulder. And we have seen many of these cases. I always remember a patient that came to my office at the hospital, to the shoulder orthopedic department, with his uncle that was a doctor, with an x-ray, a shoulder x-ray that was normal, and the story of having fall from the bicycle 2 days before. And he was just complaining of left shoulder pain. The examination of the shoulder was normal, but just pressing the left hypochondrium produced a very sharp pain on his shoulder. And at the next moment, we asked him an ultrasound in the hospital, and he had a tear of the spleen and was sent to the operating room to have a partial splenectomy. Imagine that if I send the patient back to his home with medication, pain medication. Perhaps he could have had a two-step rupture of the spleen and die. So we must be very alert with these things. But what is even more frequent are patients like this one, 73 years old and shoulder pain for 6 months, just an ultrasound diagnosis. And I am also very concerned about the massive use of ultrasound by people that has no experience on shoulder pathology. And we will find partial tears or other type of problems in a high percentage of patients, but those are not necessarily the reason for the symptoms. And in this case, the patient had a lung adenocarcinoma. Also, we must think about the Pankos-Tobias syndrome, and in this case, the reason for shoulder pain was a brain tumor metastasis in the apex of the lung. We must also think about myofascial pain syndrome. The trigger points can refer pain on the shoulder. We must consider also metastasis. This was a 72-year-old patient with shoulder pain. He was sent to rehab with not even an X-ray. He felt a crack and intense pain when exercising with the physiotherapist, and what he got was a fracture, a pathological fracture because of lung cancer metastasis. This is another patient, 55 years old, shoulder pain for 1 year. He underwent 2 arthroscopic subacromial decompression and continued with severe pain. And what in fact he had was a lung cancer metastasis that was located in the subacromial space, as you can see here, very clear in the last MRI on the right side. Another case, 67 years old, shoulder pain for 1 year, rotator cuff partial tear. He had the advice by 2 surgeons to get an arthroscopic surgery, and 1 patient advised him to have an open surgery, and he came to me to make the decision, arthroscopic or open. He came with this MRI, 3 surgeons indicating surgery, but of course, I was surprised by the shape of the proximal humerus. I asked an X-ray, and it was, of course, pathological and a scintigraphy. And as you can see, this is pathological not only at the shoulder. The patient had a prostate cancer metastasis. So what I'm showing you is what I see, and I have just 10 minutes, but I could stay for a long time showing you cases like these ones. And I want to alert young people about this tendency to make a surgical decision before, at least in the cases when it's possible, trying conservative treatment and get more time to better know the patient. This was an orthopedic surgeon, 82 years old, shoulder pain for 3 months. He was a very active person and confessed he has fallen, went to a private hospital, get an X-ray. This patient is European, was treated in Europe, did not get the X-ray, get the X-rays. They were in the hospital system, and they diagnosed a greater tuberosity fracture. But pain continues besides the treatment, and in a second X-ray 2 months later, they realized that that was not the problem. This patient had a lung cancer metastasis. So we must consider all these things. What about neurological diseases? Well, some of them are very common, like carpal tunnel medial nerve compression. 40% of carpal tunnel nerve compression, medial nerve compression, can produce pain referred to the shoulder. So if we get a patient like this, we ask an MRI or an ultrasound study, and we see a tear of the rotator cuff, we will think that the rotator cuff is responsible for pain, but things could be different. There are other neurological situations like the Parsonage-Turner syndrome that are not as common as the carpal tunnel, but we must also consider the brachial plexus pathology that could give a very big manifestation on the shoulder. Syngomyelia is another not common neurological problem, but develops an arthropathy, neurological arthropathy, very, very fast. In some weeks, the shoulder is destroyed. There are also some other situations, like this patient, 33 years old, congenital diabetes, pain and functional limited range of motion in his shoulder, subacromial bursitis. He received corticosteroid shots because of the subacromial bursitis, but in fact, what he had was a diabetic polyneuropathy that can affect also upper limb. Shoulder instability can be a very subtle pathology and make some complications for having a diagnosis. We must consider that under 40 years old, a patient with shoulder pain should be considered to have some type of instability before proving other pathologies. But the opposite can also happen. This was a 24 years old professional tennis player that had hyperlaxity, and he was treated considering that he had a multidirectional shoulder instability, but there were no changes after surgery. Severe shoulder pain continued, and what he had was a suprascapular nerve compression. So we can consider all those things. Shoulder trauma can be tricky. We all know that posterior shoulder glenohumeral dislocation can be not diagnosed in the beginning. You can see that the X-ray on the left looks very innocent, but in fact, this patient has a posterior shoulder dislocation. And sometimes we see things like this. This patient was in an intensive care unit because of polytrauma and was in coma, but when he recovered, he began to complain of shoulder pain. They took x-rays and they didn't see anything. The patient was sent home and come back to the hospital 1 week later with shoulder pain, and they took the x-ray and they saw this. The electrodes and wires were hiding the fracture. Finally, we must also think about infections. This was a 40-year-old lady complaining of shoulder pain. She went to his doctor, and in the same day, the doctor advised to have an arthroscopic decompression. The patient did not get well. After 2 years, the situation was this. And after 4 years, this was the situation. The patient always had a tuberculous osteoarthritis. So my advice is to take time and to make a decision for surgery, especially when we see that there is not any urgency to do so. This building looks Indian architecture. You can see an elephant there, but this picture was not taken in India. This picture was taken in Buenos Aires at the Buenos Aires Zoo. So sometimes things look very alike, but could be completely different. And in shoulder pathology, that's very common. Thank you.
Thank you, Dr. Sergio, for the wonderful technique of bridge plating. And thank you, Dr. Daniel, for a wonderful presentation of clinical scenarios and the AC joint. Would request a little bit of clarification regarding your AC joint pathologies. Do you fix all the type 2, type 3 AC joint disruptions?
No, I generally do not perform surgery in type 2 AC separations. In type 3, we consider clinical criteria. We consider the age of the patient, the type of sport, and we evaluate the case to try to define if it is a type 3A or a type 3B. I could say that many cases have very good results with conservative treatment. So we do not operate all type 3 acromioclavicular dislocation. Many of them, I could say more than 50, 60% get very well with conservative treatment.
Do you take any preoperative MRI to know the collateral injuries other than the AC joint, as the forces are transmitted through the humeral head and the clavicle?
Well, we not do that regularly. If possible, if it is possible, that's good. Always, as much information you get, it's better. But generally, we focus our decision making on the acromioclavicular joint, except that there is a very high trauma and the patient has a polytrauma. But generally, for instance, we have many rugby players here, and the mechanism of the lesion, it's very clear and it's very common. So we generally do not have surprises.
In India, when we have an AC joint disruption more than 50 years, we mostly see an associated cuff tears.
Well, if you perform an MRI in patients, in normal people over 50 years, you will see rotator cuff tears in many of them, perhaps including me.
Yeah, that's a fantastic thing. Then how do you want to address them when you are operating on them without an MRI?
If I see, first step is that generally, if I have more than 50 years old acromioclavicular dislocation, I do not operate the patient because of the acromioclavicular dislocation. I think that operating a patient over 50 with acromioclavicular dislocation is exceptional. So that gives me time to check if there is a rotator cuff tear. If a patient has an acute rotator cuff tear, of course, my indication is surgery. But with an acromioclavicular dislocation, over 50, I do not operate generally the patients.
Fantastic.
Dr. Sergio, if there is a pre-op wrist drop, would you still go ahead with the anterior bridge plating, or you would like to do an open procedure?
Well, the thing is, this question comes all of the time, and the answer is still the same. The only exception is when I have a nerve palsy associated, and then I would have to do an open procedure with identification, and ideally with a hand surgeon with me to do something on the nerve if needed. Hopefully, this is an exception from an epidemiological point of view. This question comes all of the times I am in India or discussing these things. But the thing is, no, when you have a nerve palsy, I think that you have no space for indication, in spite of the fact that 90% of the cases we are dealing with neuropraxias, which will recover over time. Only 10% of the cases we have real anatomical tears, but nevertheless, I think that open procedure and exploring the radial nerve is the way when you have a nerve radial palsy.
Thank you very much. Thank you, Dr. Sergio, for the kind sharing, and Dr. Daniel. And yeah, one question from the audience.
Professor Sergio.
Yeah.
You said in your talk that whether you see the radial nerve, it is okay. If you don't see the radial nerve, it is okay.
Yeah.
In which case, why at all see it?
I didn't understand the question.
No, you said in the distal incision, if you see the radial nerve, it is okay. If you don't see the radial nerve, then also it is okay. In which case, why take the trouble of isolating the nerve?
No. The idea is different, sir. First, I am not isolating the nerve. I am identifying. And the thing is that, see the practical philosophy. I always try to see, but sometimes it's so lateral that it becomes difficult. Okay? And I don't isolate. I just want to see that my instruments are not above it. Because a lot of people fear the nerve. The idea is you have to respect it. But you see, sir, when you know where the nerve is, you know where the nerve is not. So when I know where the nerve is, I'm putting it laterally and my instruments are not bothering it. But in a few cases, it's difficult to see. So stay close to the bone and be gentle and everything is going to be okay. Just one thing, sir, just one thing. Everybody asks me about radial nerve pulses after anterior bridge plating. I had one case in 15 years, sir. So I think that with proper care, this is not an issue.
Thank you, Sergio.
Okay.
Thank you for all the presenters. The panelists can kindly stay back because we have two case discussions. Professor Wagner will be the moderator online. So the first case, Dr. ROWINSKI, are you ready with it?
Yes.
Yeah, you can go ahead.
So I just want to say something before I start. I'm going to show you a very, very interesting case. One of the most difficult cases of my life with one of the best final results. But the thing is, I'm going to say just one thing. What Dr. Daniel has said is so important in his last lecture because clinics is everything. And MRIs and ultrasounds, they mean nothing without a very good clinical assessment. And the beauty of the case, in spite of the difficulty, is that all of the clinical decisions that we had to take were very important to achieve a nice result. So let me come now, just a second.
Yeah, I would request Dr. ROWINSKI and Dr. MOYA to kindly keep your presentations a little short because we are lagging back on time.
Okay, I'm going to be as fast as I can. Can I start now?
Yes, please.
Okay, so thank you very much. This is a very difficult case I had in my life. I wanted to show the rationale to get a beautiful result. So the thing is, this case was about a 38-year-old lady who lived in the Amazon, in which a place in which I've been working for 10 years, developing shoulder surgery. She had a proximal humerus fracture on the right shoulder, January 2018, which was fixed by a local surgeon, very far away place, who said that everything was okay in the surgery. The problem is that the 38-year-old, very decent lady evolved from day one with lots of pain in the shoulder, severe stiffness that was not getting better over time. 1 month, 2 months, 3 months, 4 months, 5 months, 6 months post-op. And she was with pain, stiffness, a lot of pain. And the surgeon was telling the family that everything was okay. So after a lot of time, in spite of all of the difficulties, because she lives 200 kilometers from the capital of the state, she came from a second opinion with a friend of mine who really understood what was going on and asked for my help because the problem was very big. So this is the AP view of the case taken 11 months post-op, in which we can see that we have a posterior dislocation of the shoulder. It's difficult to establish to say much more inferences when we see the left view. It's a very well positioned left view. There is a clear indication for a CT, but for the juniors to understand, this is the AP view taken 11 months post-op. This is the glenoid and this is the humerus. So it's very, very easy to see that we have a posterior dislocation. So this is the CT in which we can do these inferences. First, the humeral head was posteriorly dislocated, and we had some screws from the phyllos plate destroying and scratching glenoid. And besides that, when we see the same image, no drilling signs on the humeral head. And if we see this other image of the CT, no signs of drilling, of perforating the humeral head. So it took some time for us to discuss the case, but we could finally understand what was happening and why that lady was in such misery. For sure, she had a 3-part posterior fracture dislocation in the beginning, and unfortunately, the surgeon didn't realize that the head was posteriorly dislocated, and hence, unfortunately, he fixed something like the shaft, the metaphyseal part of the shaft, on the glenoid, which was obviously a tragedy in a 38-year-old lady 1 year post-op. So that was the rationale. What about the status of the rotator cuff 1 year post-op? For sure, it would be very bad. The humeral head status, for sure, it was very bad. It was into AVN, making reconstruction impossible. Big arthritis in the glenohumeral joint. The humeral head was gone, and she was only 38. So the best option for that case would be a reverse and maybe a total shoulder, depending on the intraoperative status of the cuff tear. But I was sure that the rotator cuff would be a mess, and I was absolutely correct. So I went to the Amazon, 2,000 kilometers from my home. We did a 5-hour surgery. It was very difficult. I did an extended Delta Pack, and see what weird, strange approach that was done by the index surgeon in a way that he didn't know what he was doing. So we did a reverse. It was a very difficult surgery, a lot of fibrotic tissue. We had to take the philos out and distorted anatomy. This is the screw perforations on the shaft from the philos plate. A very well done reverse prosthesis. And this is a beautiful image in 2 weeks post-op. And to make things easy for the juniors to understand, in this beautiful axillary view, I'm showing here the clavicle, here in yellow, the coracoid in this axillary view in green, and here in red, the spine of the scapula and the acromion. A very well done prosthesis, reverse prosthesis. This is the patient 2 months post-op. I was amazed with the final clinical results of this case since the beginning. The subscap was gone. We couldn't do nothing. When we know that the pec major can give us quite good internal rotation. Her external rotation was fine, 2 months post-op, and some difficulties in forward elevation in scapular plane because of adherences on the anterior inferior capsule, as we see in all proximal humerus fractures. This is the lady 4 months post-op. She was in misery, a stuck shoulder, and 4 months post-op, external rotation was fine. Internal rotation was not exactly fine, but still some stiffness due to adherences in the anterior inferior capsule, and she was doing a lot of physio. But let's see this lady 8 months post-op. A wonderful result, much better than I would ever, I would say, expect. Absolutely good elevation in scapular plane, external rotation was fine. She was very satisfied. For 1 year, she was in misery, stiff shoulder, absolutely a strong pain. And then we asked her to come 1 year after. So she came 1 year after, September last year, 2020. We can see that everything was okay in the AP view, a very good tilt of the glenoid component. In the axillary view, everything was fine. And how was this girl 1 year, 8 months post-operatively? This is COVID times. She's using a mask. This is 6 months ago. And a wonderful result. 15 years of shoulder practice, I would never expect such a fantastic result. Very good internal rotation, very good external rotation without the subscap. The subscap was gone, absolutely lovely forward elevation. And this is one of my best results in one of the worst cases. Very, very good final clinical result and final radiological result. So these are some take-home messages for the juniors on this very challenging case. We know that reverse restores the center of rotation of the shoulder, any tensions, the deltoid, of course. It allows quite reasonable range of motion, sometimes wonderful range of motion, and it's becoming a good solution for many complex trauma cases. We know that the index, the classical indication, is an irreparable tear on a pseudoparalytical shoulder on a patient 70 plus, which has few comorbidities and is quite deciding to be collaborative and quite active in rehabilitation. But, and this is the idea in this case, the indications, they are increasing. So it's quite a consensus that reverse should be done in complex proximal humerus fractures in the elders, especially above 75, whenever they cannot be managed conservatively because osteosynthesis has a high chance of failure after 75. But the thing is that in trauma complex sequelae, we really can have interesting indications, and especially this idea, even in younger patients. This lady is 38, she was in misery, and now she's very happy. And even if we have to do a revision in 10 or 15 years, there is a space for reverses in very complex case, as long as we are doing good indications and with proper technique and with reasonable experience. So thanks a lot, my friends, Dr. Rajiv Naik, Dr. Vansi, Dr. Hemant Bangalore. This is my YouTube channel of shoulder and elbow education. If someone wants to give me a WhatsApp, I am absolutely available. And it's lovely to see my brand of international education in shoulder and elbow medicine and surgery together with such wonderful faculty and audience. And that's it, Dhanyavad. I'm going to stop sharing for Dr. Daniel to show his case. That's it.
Congratulations to Brazil, an excellent case. I would also have suggested a reversed prosthesis, but I never did one in a patient younger than 50. So you are very brave. What other alternative could you suggest?
Dr. Wagner, are you listening to me?
Yes.
Sir, see, I am showing you a discussion that took more than a month, okay? But the thing is, we came to the in my opinion, there was absolutely no other options than a reverse. Reconstructing this shoulder was absolutely impossible, okay? The cuff was gone, and I was absolutely right. We had a big AVN, so without a cuff, and with glenohumeral arthritis and with a destroyed glenoid, sir, we had no option. I'm going to tell you that all of my patients, and I am a shoulder guy for 15 years, 16 years, they are above 60, 65, but this is an exception. So I think that we discussed this with the patient, and the patient said, okay, if I'm going to be 10 years free of pain or 15 years, and if I have to go under a revision, I am okay because I am in misery. So I think I was brave, but after, as you have said, sir, but beyond that, I think that was the only option, okay? And an arthroplasty resection, a Jones, like a Gilderstone in the hip, would be quite a bad option, and you know, so I think that was not the best option, the only option. And the only point, sir, is that I was not expecting such a beautiful final clinical result, okay? But I guess that we had only one option. And if you allow me, sir, Dr. Daniel, do you agree with me that in this case, no other option than a reverse?
Would you ever think about a fusion?
No, sir. Sir, the point is, I wouldn't do a fusion because, you know, what about if she had pain after the fusion? We would have nothing to do. And this is an exception case, but think with me, sir, we discussed this a lot before the surgery. If she goes under a revision after 50 And then if she has a failure after 65, at least she will be 27 years without pain.
I agree, yes.
So I think that my decision was quite wise, sir.
Yes. Questions to Dr. Rowinski? Okay, you can also do it in the chat. Now we are a little bit running out of time. Now,
okay.
Thank you very much for your presentation. I learned a lot. And
okay.
Let's stay in South America.
Dr. Daniel.
Dr. Moya, please, your case.
Yes. This is a very short case. In fact, it is a request of some of the delegates of this Congress from India. He received a patient that is 50 years old, a male, villager, and this patient suffered shoulder trauma 3 months ago, and now he has mild pain, full range of motion, and we must consider that this patient has low economic resources. This is the situation. As we can see, this patient has a distal clavicle displaced fracture. You can see the X-ray in February, X-ray in March. Of course, as we can expect, there were no differences. These fractures have a very big tendency to non-union. So we can open the discussion. First, which type of lesion, what we expect in this case. I just move ahead and show that for young people, these type of fractures have two subtypes, 2A and 2B. In 2A, we see that the lateral coracoclavicular ligaments are intact. It is very typical to see this shape, and the lower part of the clavicle, the distal clavicle fragment is longer and can give place for the ligaments to be inserted there. And this is the case that we are seeing on the right is the type 2B, where the conoid ligament is torn, and as we see, the shape of the distal fragment is very small. So we could discuss what we have done in the first days, and what can we do now, if you agree, Dr. Wagner.
Pardon?
If you agree, we can discuss what to do.
Yeah.
Sergio, what would you do?
Okay. Well, I'm not sure if people are seeing. Excuse me. I'm not sure if people are seeing me. I'm not seeing my face, but nevertheless,
we can see you.
Okay, lovely. Okay, lovely, sir. So see, the thing is, I've been dealing with complex shoulder and elbow trauma for 15 years. And I can tell you that 15 years ago, I would be quite lost. But now, to be very honest, I would feel quite comfortable to know what to do. The first idea is that in 2A and in 2B, these lesions behave like AC joint dislocations. This is the first idea. So you have to manage them as AC joint dislocations. I have two similar cases in my life. So this is one point. Point two, I have come to a point in my life in which I do absolutely hardware-less fixation of AC joint dislocation. Dr. Daniel knows that. We discussed this a lot of time last year, a lot of times. So I would do the technique that I have been doing for around 8 years now. Subchoroid sutures. I do 4 ethibond subcoracoid sutures, 2 tunnels. I would do that, and I would pull down the distal, the proximal fragment, which is basically the wall bone, the wall clavicle, and I would fix it as an AC joint dislocation. At the moment that I do that, I would have a very good contact between the proximal fragment and the distal one. I would just induce some bleeding in between bones. and only by contact they would heal. Maybe depending on an intraoperative perception, I would harvest some bone from the iliac crest to add some biology to the scenario. And one thing that I have done once, and I have the photos, besides the subcoracoid cerclage to manage the AC joint dislocation, because I manage these cases as AC joint dislocation, what I do in between the fragments is to do an osteosuture. I do a loop around. I pass one suture delicately to embrace both fragments. And I would keep this patient, as I do here in Brazil, quiet 4 weeks in a sling. And if he develops some stiffness in the shoulder, I can manage it non-operatively. I do it every day for 15 years, not a problem. And after 4 weeks, slow movements and full motion after 6 weeks. I had 2 similar cases. I managed that way. They were both chronic, and they ended up with a good result. One thing that I just want to mention, and I know that Dr. Daniel thinks relatively like me, many people in Europe would put a hook plate, maybe with some autologous or artificial graft in between the fragments. But here in Brazil, we have come to a consensus that we really don't like hook plates for a lot of reasons. In a way that I would not use a hook plate. I would manage this as an AC joint dislocation with some graft, depending on the chronicity. If it's 1 month, definitely not. If it's 6 months, it depends. But I have to do a macroscopic analysis of the focus of the fracture, and that would be what I would do.
Okay.
Okay, I also don't like the hook plate, but I would have used it. Any other suggestion?
I just want to show you what we do in acute trauma, what Sergio said. You can see preoperative x-ray, a fracture like this one, and this is the result, just with cerclage. So
it's the same that I have said, huh?
Yes.
Yeah, okay.
But wouldn't you consider in a patient that is dedicated to farm activities, poor situation, not big resources, after 3 months, full range of motion and mild pain, wouldn't you try rehab in this patient? Or you consider that after 3 months, you would just go directly to, in acute conditions? I agree, completely agree with surgery. What about this type of patient?
Daniel, I'm sorry, if the patient is doing nice from a clinical point of view, maybe you can do nothing. This is what Dr. Rockwood used it to say, skillful neglect. And I have very poor patients with limited resources too. So on an acute scenario, I would really feel bad not to fix it from a surgical point of view. But in a chronic scenario, if the patient is doing fine, I would do the famous wait and watch.
Good.
Okay. Now, any further suggestion to this case?
Dr. Daniel, in the last presentation of yours, you have shown the referred pain from lung cancers and cervical pain. But do you prefer to take an MRI before you fix that distal clavicular fracture to know that there are no injuries there? Because we cannot examine the shoulder in acute conditions. Do you still would like to go ahead with an X-ray, or do you take an MRI and decide?
Nowadays, generally, I ask for an MRI, but I can tell you that in most of the cases, there are no changes in my decision because related to the information I get in the MRI. So if you have money and you have the chance to ask MRI to all the patients, that's not a problem. It always will give you more information, but generally it doesn't change my decision.
See, when we can't examine the shoulder, is it right to do a surgical procedure without assessing the soft tissue there? Because patient has money or doesn't have money, the assessment has to be done from our side before we take a call.
You know that in these cases, as it is just to add more information, but you know, in a patient that has an acromioclavicular dislocation, generally the energy is dissipated in that place. And I had a teacher when I was at the medical school who told me, in Argentina you see an animal with 4 legs, big animal with a long tail, and it looks like a horse, do not think in a zebra, because if you think that perhaps it is a zebra, you have a high chance of making a bad decision, a wrong decision. So I think that if I get an acromioclavicular dislocation, in most of the cases, and the mechanism of lesion, the type of patient to whom I will perform surgery, generally there are not rotator cuff tears, because as I said, we perform surgery in patients under 25 years old.
Yes.
So we do not see rotator cuff tears in those patients.
Can I make a comment?
Doesn't change your indication, the MRI. Sorry? The MRI doesn't change your indication.
Yes, the slap tears are very common these days for the high-end athletes. These are mostly seen with the contact athletes. So the persistent pain after 3 months or stiffness, which comes most of the times with the hook plate or with the fixation of the coracoid joint, is because of under-assessment of the patient. Because when a patient is having an AC joint fracture or a dislocation, acute conditions, it's impossible to assess the soft tissue injury. And these slap tears present late, and when they come for acute pain after 6 months or 9 months of time, so there is no point in subjecting the patient for second surgery for a slap tear repair. So that's what we have been practicing in Bangalore here. So we get an MRI done, and then we see the slap tears in younger athletes and cuff tears in elderly people, so that we don't miss a diagnosis before we fix up and try to say that this frozen shoulder has come for the patient. So we avoid that sort of an embarrassing situation before we take the surgery.
So I imagine that you operate on all slab lesions that you see on MRI. And
no. My surgical rate is quite low because the patient comes with pain after the surgery second time. When I'm going in for a AC joint surgery, I don't mind putting 2 stitches for the slap tear, rather than doing a surgery later after 6 months or 9 months.
So if you see a slab lesion in the MRI in a patient with an acute acromioclavicular dislocation, you will fix the slab lesion.
Yes.
Just because you see this in the MRI. Do you know that there is a paper that was published by a Finnish group 4 years ago showing that real surgery and fake surgery in 2 groups with a slab lesion got the same results?
Yes.
Yes.
Hammond. Hammond.
Yes, sir, Sergio.
I need to be the devil's advocate, and I'm going to defend a little bit Dr. Daniel. This is very serious. We have to figure out very straight points. From an epidemiological point of view, we are talking about very young boys with AC joint dislocations. So the chances from an epidemiological and pathophysiological point of view of these boys having a cuff tear, traumatic, is very low. This is point 1. Second, the index of slap tears in AC joint dislocation is very small. And third, when you do an MRI after an AC joint dislocation and you see a slap tear, the chances of false positivity in this exam is extremely big, because the edema of the AC joint dislocation will show you an image in the labrum that much probably doesn't exist. So I'm sorry to say, but if you are operating all of these labs, you'll see in an MRI post just after an AC joint dislocation. In the vast majority of these cases, this slap doesn't exist. Do you agree with me, Dr. Daniel, considering epidemiology, radiology aspects, and pathophysiology? Do you agree with me, Daniel?
I completely agree. Dr. Rockwood used to tell us, if you want to operate on a patient, ask him an MRI because you will always find an excuse.
Thank you, Dr. Daniel, for a wonderful discussion. Thank you, Sergio, for a wonderful listening, and Dr. Wagner, thank you very much.
Thank you. Thank you for this session. Thank you, the panelists, Dr. Hemant Reddy and Dr. Mohan. Thanks, Dr. Wagner, for moderating this session. Thank you, Dr. ROWINSKI and Dr. MOYA. Going on to the next session, which is the elbow and wrist. I would like to welcome Dr. Rajiv Raman, who is online, Dr. Bharat Kadadi on stage, Dr. Prakashappa sir, and Dr. Vasudev Prabhu on stage. So we have the first talk by Professor Jesse Jupiter. His topic is elbow trauma and reconstruction. Professor, are you online?
Yes.
Yeah, please start sharing your slides.
Okay. Thank you very much for the kind invitation, and looking at many friends in your Congress. It's a pleasure to be able to share with you some thoughts about this ever increasingly complex problem. We are learning a lot about these problems, and fundamentally, we've come to realize that the elbow, from a structural point of view, is a ring, and there are anterior, posterior, lateral, and medial components to this that I will cover in this presentation. When we see a fracture dislocation, by definition, there's a soft tissue injury, but the complexity increases with the supporting structures involved, going from the lateral side to the anterior side, to the medial side, to the posterior side. And if there is a message there, it's that a simple dislocation, once reduced, is generally stable. You may see some calcifications and healing, but it's generally stable. Introduce a lateral column injury, and this becomes more unstable. Introduce a lateral column and an anterior buttress column. These are very unstable, and we've been terming them the terrible triad. So the more supporting structures involved is tantamount to the greater degree of instability. We can call these two different injuries dislocations or intra-articular fractures, but are they really the same as these injuries? Are they all part of the same process, or are we looking at different terms? For dislocation, really, there's the terrible triad and the lateral column injury with dislocation. We can have anterior and posterior olecranon fracture dislocations, which I'll show you are really not dislocations, but they're really distortions or subluxations. And you can have involvement of the anterior buttress involving the posterior medial component of the coronoid. Dislocation, by definition, is that the joint is no longer in contact. Disruption, rather, still has a contact of the joint, except the joint has been displaced. But the problem here is that these may or may not have lateral soft tissue injuries, which then take them into what might be more of a dislocation. We call these disruptions this anterior fracture dislocation of the olecranon, but one has to always be careful because some of these will have lateral collateral soft tissue injuries. Once you introduce the radial head, as I mentioned, the risk of instability increases. The loss of a radial head alone is not a problem for stability unless you've lost the medial soft tissues and unless you've had a dislocation as well. We learned this a long time ago from Sweden, where with fracture dislocations, what they call type 4, that is radial head and elbow dislocations, one should preserve or reconstruct the radial head as much as possible and always repair the torn ligaments per se. When these were not done, the patients did considerably worse. We know for many, many years, looking at these classifications of radial head fractures that are very arbitrary. But looking in a greater detail, it comes about that when you extend the fracture into the neck, or you extend your dissection along the neck, you do have a risk of introducing avascular necrosis. So while implants are improving, they're still too large and they require too much exposure and too great a risk of avascular changes. The blood supply to the radial head is analogous to the femoral head, that the bulk of the blood vessel supply comes in through the neck. The cartilage and the outer layer of cartilage is nourished by imbibition of the synovial fluid, but the rest, it comes from blood supply coming from the neck. And this is a nice study done out of the Mayo Clinic where they injected with latex the vessels around this area. And off the recurrent radial artery, we see the major vessel entering the neck of the radius and extending proximally. So just the outer layer of the cartilage of the head is nourished by the synovial fluid. The rest is dependent upon these vessels. And if you have a fracture that extends into this, or your dissection ends, goes down into this, there is a risk of injury to these vessels. And in the injection studies, in some cases, only one branch extends up into the fragments of the radial head. And so with a fracture extending more distally, or your dissection involves a more distal exposure, we do have a risk of avascular necrosis. And a number of years ago, we looked at a large series of fracture dislocations with fixation of the radial head or neck. And we found that a risk for non-union was about 25%. Now, it doesn't necessarily mean you should not try to fix these, because 75% will heal. And even if it doesn't heal acutely, it will serve as a biologic spacer while the ligaments that need to be repaired heal. So I think for these fractures, be prepared for ORIF or even prosthetic replacement. But these will serve as a biologic spacer, even if later we see that there's avascular changes. Now, once you introduce the coronoid, now we're dealing with an entirely different problem of instability. We know that even a small fleck seen on an X-ray would suggest that there's either been a subluxation or a dislocation that's reduced itself. So just like in the shoulder with the Bankart fracture, injury to the coronoid, even by itself, would be a marker for more soft tissue injury. And the terrible triad is really one that is an injury that until recently has had a very bad prognosis. Instability, malunion, non-union, and arthrosis, unless this is repaired very well, has been observed repeatedly. So I go back to that concept of stability, And we're looking at now the anterior buttress and the lateral buttress. And the Greeks understood this many centuries ago in their buildings. And so if we look at the anterior column, which involves the coronoid, brachialis, and the anterior capsule, and the posterior column that involves the olecranon process, notice where the articular hyaline cartilage is. It's very anterior and very posterior. And these are the two buttresses against the elbow subluxating or the forearm subluxating when you flex and extend. Now on the lateral side, we have, as mentioned, the radial head, capitellum, and the lateral soft tissue injuries. And on the medial side, we have the ligament and the coronoid as well. So if we look at the primary stabilizers, we have the soft tissue structures and importantly, the trochlea-coronoid relationship. The trochlea-coronoid relationship gives more than 50% of the stability. And that's why when you have a complete dislocation, but no fracture, and you reduce it, that contact pressure from the coronoid to the trochlea will enhance and maintain stability in most cases. These prevent varus and valgus stress, these ligaments. But if you look at the secondary stabilizers, particularly the radial side, the radial capitellar articulation is a little bit more important than has long been thought, meaning that you can't just lose your radial head, especially if you have ligament injury. The dynamic stabilizers are the muscles that stabilize in flexion extension. When you flex or extend, your forearm wants to move proximally. So you need those buttresses, as I mentioned, but you need these muscles. So if you go to the OR and the patient has complete brachial block and there are no muscles involved, you may see a sense of instability after you've reduced the fracture. But look at it the next day when the muscle power is back returned, and it won't be the case. And that's because the muscles are important to bring the contact pressure back into place. So the radial head works along with the medial collateral ligament to prevent valgus stability, but it also works with the lateral soft tissues to prevent injury or subluxation in the sagittal plane and in the axial plane as well. So I guess the message is stability comes from these structures, and the goal of treatment is to repair or replace the injured structures. When we have the terrible triad, we're looking at injury to all of these supporting structures and soft tissues. And we're looking at a column that's broken. And this is what happens. We always try to figure out the mechanisms per se, but it's very hard with these injuries. Suffice it to say, this is what it looks like clinically, where there's gross subluxation or dislocation and fracture of both the radial side and the anterior buttress. How to approach these is variable, depends upon your own setup, but you really need to have good ability to image, because the restoration of the component parts may take imaging to know where to put your implant or your fixation. There are a lot of approaches, medial, lateral, as many people have become familiar with, or the extensile approach, which allows you to get to the side of both sides of the elbow, because the approach to the front and the back of the elbow are through the sides. The downside of this approach is only that it creates a dead space postoperatively. So you need to have a drain. I like to keep a drain for a few days because there's a dead space that hematoma can accumulate. But doing this, you can get to both sides as necessary. You'll always find the lateral soft tissues have been disrupted. We call it the bald epicondyle. And a good repair of the lateral soft tissues is paramount to maintaining or restoring stability. The coronoid, as I mentioned, can be variable, but with the advance of imaging, especially 3D imaging, especially where you can remove the distal humerus, allows you a much better understanding of the morphology of the coronoid and the coronoid that you're dealing with in injury. And bear in mind that the anterior medial facet can be substantially larger than you think and not appreciated in standard x-rays from a sagittal view, but you need the imaging per se. And we can see these a lot better with 3D imaging, again, removing the radial head, removing the distal humerus. How you classify these varies per se, but let me just repeat that the injury may be, or the involvement of the coronoid may be greater than the image on the x-ray suggests. A lot of different ways to repair these. Some people would argue small fractures, excuse me, that excision, and bringing the brachialis back into that defect will help for stability. Others would argue that this is a greater risk of elbow stiffness. But you don't need very complex plates or screws. Even threaded Kirschner wires will suffice in many of these injuries, or headless screws per se, as I think the movement toward radial head fixation is now with headless screws, putting them obliquely or using small plates per se, mindful of the fact that the plates have to be in a position that does not cause blockage of the forearm rotation. And that was described by Hotchkiss in New York many years ago for the safe zone for putting the plate in. But remember that plates can be themselves a problem with motion or with blood supply. Here's a patient who came in with a terrible triad. The fracture and C-arm image is reduced, but you can see the instability once the reduction is let go. And my own purpose is trying to replace the radial head with its natural head. So even doing it on the table, I think for me is preferable than putting a prosthesis in. And here's the post-op at 2 months, 6 months. Notice the plate is broken, but the fracture is healed and the function is good. Another patient with severe instability. In this case, the radial head is fractured off the neck and coronoid fracture as well. You can see that in the sagittal CT scan below. Coronoid is replaced with small screws and the radial head with a plate, given the fact this one extended into the neck. And the patient is moving at the first week and then 3 months per se, and has done well. To summarize, this paper was by a study out of Toronto, and their approach to this is fix or replace the radial head, fix the coronoid, repair the lateral soft tissues, and then make sure you're stable. Try not to leave the operating room unless you're feeling good about the stability. If you're not feeling good, then go to the medial side and try to restore the medial soft tissues. And then if there's residual instability, perhaps a fixator, and it doesn't need to be a hinge fixator, is good. Their results were considerably better than previously published, but note, still not perfect. This is a very substantial injury and fraught with complications. I don't like braces per se, but many people do. But I think that a fixator, if it's in place, should be removed within 3 or 4 weeks. So let me summarize again. and these are the approaches that I think would follow. Simple dislocations are stable. Dislocations involving one of the columns become more problematic, and dislocations involving the lateral soft tissues and lateral column and anterior buttress are very unstable. If you have persistent instability, then a fixator is good. And sometimes when you can't repair the coronoid and there's a bad radial head fracture and you have available prostheses, you can take, like in this patient seen somewhat late, and take the radial head and shape it to make a coronoid and then put a prosthesis in. And this patient had that done with a fixator. Here's the post-op, and at 6 weeks, and now at 3 months, 3-year follow-up, he was very stable. The final group is involving the olecranon, and these are the olecranon fracture dislocations. As I mentioned, they're more disruptive injuries. The radial head relationship to the ulna is intact, but some of these may have lateral soft tissue injuries. But here's a patient with this type of injury. This black material is all hematoma. And one way to do this was described by Jeff Mast in his fracture book by putting a smooth pin, bringing the proximal fragment under the humeral shaft and putting it back in place, and then putting a threaded pin distal to the injury, putting on your pre-bent plate, and then using a distractor to help bring these fragments together, as this patient had done. And this patient was in high school then. He's now an orthopedic surgeon. So finally, you can determine the injury sometimes based upon the fracture pattern. And looking at these fracture patterns, I think you can tell what's been involved or what you have to suspect is involved and facilitate operative planning and execution. But remember, stability is the rule, not mobility, but stability. We don't want to leave the operating room with an unstable situation. So thank you very much. I think I'll stop sharing now. Okay.
Jesse?
Yes.
Thank you. Thank you. That was a great talk. So I have one question to you. When you do the olecranon fracture dislocations,
yes.
What is the position of the patient? Would you prefer a lateral decubitus, or would you do it in a supine position? Because I often felt the
lateral decubitus. Yeah. I think you can get better x-rays, and also in these cases, sometimes you have to go to the medial side of the proximal ulna if the fracture is very displaced.
Okay, and the weight of the forearm can help you to reduce the fracture in the lateral decubitus position.
Well, you need an assistant or pins.
Yeah. So when you're not able to fix the radial head, so what process do you use?
Whatever is in our
Which is the best available. Okay. The best available. Okay.
The answer is, for me, is don't put in too large a prosthesis.
Yeah. Okay.
Take the radial pieces, put them together, and then take the diameter of the inner rim, not the outer rim, the inner rim of the articular surface.
Thank you. Thank you so much.
Okay.
Next, we'll go to Professor Diego Fernandez. He'll be speaking on avoiding complications in distal radius fractures. Professor, please share your screen.
Hey, thank you very much for the invitation, Dr. Balal, Dr. Naik, and Dr. Samsi, who wrote to me for inviting me to participate in this trauma meeting. In this first talk, I will show you how to avoid most of the complications associated with distal radius fractures. First of all, with conservative treatment, we should recognize the unstable fracture patterns. We have to use adequate anesthesia for close reductions. Sorry, you hear me? You have to master both reductions and casting techniques, and you have to follow up very closely the patients in the early phase after reduction. If we have a secondary displacement, then the decision making is very important, whether to put a cast on, do percutaneous spinning, or open the fractures, or use an external fixation. The problem with the unstable fractures is usually they displace very rapidly after an initial adequate reduction. And usually this is because we fail to recognize the parameters of instability in initial x-rays. And you all know that these are classic radiographic criteria: more than 20 degrees of angulation, displacement, important more than 2/3 of the width of the shaft, metaphyseal comminution, intra-articular component, or associated distal ulnar fracture. If you use finger trap traction to reduce, usually you get the length and the ulnar inclination very easily, but to restore the volar tilt, it's important that you get palmar displacement of the back of the hand towards palmar. This rotates the first carpal row, lunate, and it brings the distal fragment down. Then we put them usually in a 3-point contact cast, as described by John Charley, in 15 degrees of flexion, 15 degrees of ulnar deviation, and slight pronation. This is for a Colles fracture. And very important is that the volar cortex shouldn't overlap the proximal fragment, as you can see there. If you have a good reduction of the palmar cortex with good contact, then most of the time this will remain stable and you will have a good result. We put a sugar tongue splint in for the first 2 weeks that controls pronation and supination, and then we keep it for 2 weeks. And the follow-up x-rays at 3-7 days is very important. And as I said before, if you detect loss of reduction, then it's very important you can remanipulate only the stable fracture types. Otherwise, consider this an unstable situation and you have to put pins, external fixator, or internal fixation. When you put a cast on, remove tight casts with finger swelling and constant pain. If you see that, that's the patient that's going to end up with a dystrophy or chronic reflex sympathetic pain. So this is the result. In that case, as you can see, for conservative treatment, it's a very good radiographic result. Here you can see the opposite case. The Colles fracture has been over-reduced towards the palmar side. And you can see here that volar cortex overlap. And that is synonymous of instability. No matter what you do, this thing is going to settle down and shorten, as you can see there, after 3-5 weeks. And this is an established malunion very early on that you have to treat surgically. What about complications associated with percutaneous spinning? This is the ideal minimal invasive method, but just for young patients with good bone quality. And for those fractures that are reducible, closed, also intra-articular fractures, but minimal amount of metaphyseal comminution, as you can see in that case in the bottom part of the slide. This one, as you see here, it's an elderly patient with comminution at the metaphyseal area, and you see that early on you have pin loosening and settling of the fractures because the indication was not the correct one. What about complications with external fixation? Most of the times you can have accidental nerve injury, loss of reduction, median nerve irritation, pin tract infection, pseudodystrophy, and non-union or malunion. These are all the classic complications. How to avoid them? Accidental nerve injury, the most common thing is the superficial radial nerve, because that's the entry point of the pins used on the radial side of the forearm. So use blunt dissection until you get down to bone, until you hit the bone, and then do not forget to use the drill gap to avoid contact of these threaded pins with a superficial radial nerve. Other authors have shown that they used bigger incisions down to bone, also protect the sleeves, sides, and Putman described that. But if you can do it with stab wounds and use the trick of blunt dissection, you're okay. Insufficient reduction, in this case, you see exactly what happens. You get the length back, you get the ulnar inclination back, but you don't get the volar tilt back. And this is because you forget to do this palmar displacement that John Agee told us a long time ago to get the volar tilt back. So you might end up with the malunited distal radius. Pin tract infection is mostly, the problem is bad technique, but mostly because the patients are not instructed on pin care. That disinfect and maintain a clean dressing around the pins in the period of fixation of the radius fracture. So we have to instruct the patient on that. Also apply physiotherapy measures. Usually the patients on an X-fix, they have the tendency to hold the arm in pronation. They have a problem to restore supination. And if you started with slight flexion of the wrist, then try and get them back to a neutral position after 3 to 4 weeks. The other problem is if you do excessive distraction with external fixation, you might get not only joint stiffness and MP joints, but reflex sympathetic dystrophy. And the other thing, if you're distracting a fracture with a lot of metaphyseal comminution, you might end up with a metaphyseal bone defect and a iatrogenic non-union of the distal radius. So what about how to avoid complications with open reduction and internal fixation of these fractures? First of all, you have to have the correct indication for internal fixation. Bone quality, occupation, comorbidities, etc. Then you have to have a very good diagnosis of a fracture pattern. For these, I think you need to use CT scans, especially if the fractures are intra-articular or complex. I don't think you need CT scans for extra-articular fractures. Then whether it's a closed or an open injury, associated lesions, and then think about the optimal timing. This depends on the soft tissue condition, edema, vascular impairment, or nerve compression. And most important for the surgeon is to be familiar with the surgical approaches about the wrist. So then it comes whether or not do we have the necessary implants for each fracture type. This is a little bit of a problem now. Most of the companies have now almost a plate for each fracture type. It's incredible, but things can be done more not so sophisticated with simple implants. Remember to plan treatment of the associated lesions at the same time, whether you're going to do primary or delayed repair of carpal ligaments or triangular fibrocartilage, tendons, nerves, and soft tissue coverage. So how about the complications regarding the choice of the surgical approach and implants? Here you have a case. This is an intra-articular fracture, the distal radius, and these are the CT scans. If we look at them for a moment, then my question is, do you do a volar, a dorsal, or a combined approach? This one needs what we call fragment-specific fixation through a dorsal approach, because that dorsal fragment, if you see it, it's completely rotated towards the proximal part of the forearm, and it's irreducible through volar approach. How about this one? This one is, for me, it's a stable fracture. There's no shortening. It's very easy to reduce closed. And look what they did. They put this plate on, and what do you think this is? For me, it's the wrong indication, poor implant choice, but most of the thing is a lousy surgery. So this had to be revised to a normal plating at the early date after the first operation. Do you think that volar locking plates solve every problem in the fixation of complex distal radius fractures? The answer is no. And this I show you because of you have to avoid the problem of the indication of the right choice of surgical approach and implant. So the dorsal marginal shearing fractures, radiocarpal dislocations, radiostylic fractures, centrally impacted fragments, or irreducible dorsal fragments, as you can see here, or impacted fractures with non-displaced volar cortex or massive articular and diaphyseal comminution. These are all not candidates for volar plate fixation. Here's another case, a 60-year-old farmer. You see that has a complex intra-articular distal fractures and an open wound. This is intraoperative. The patient the surgeon used a temporary external fixator to get the length back, put a volar plate on, and look at the x-rays 2 days after the operation. This hasn't been reduced. The dorsal component of the fracture has not been reduced, and the CTs at 4 weeks show this. Actually, this is a mess on the dorsal side. We have comminution. We have even intra-articular heart. So the patient had to be reoperated from the dorsal side and got quite an acceptable reduction. Loss of reduction or insufficient reduction. This shows this case that you see that the volar tilt has not been restored. And what happens? The plate is prominent on the volar side, and here you have a potential problem with the flexor tendons. So if you see this, the best thing is if we restore the volar tilt, as shown in this other case on the side, you see that now the plate is separated from the volar rim is lower, more anterior than the end of the plate, and therefore most of these in these situations you don't have a problem with the flexor tendons. Plate positioning: if you put a plate too proximal in osteoporotic bone, it means that this fracture can settle down because you don't have the subchondral support that you have with the locked pins or screws, and then you may end up with a settling and an incongruity. The loss of reduction comminuted volar shearing fractures, usually there's failure to capture and fix the volar ulnar fragment. And this is shown in this X-ray. You see that because the fragment it's controlled, it's in contact or it's attached to the lunate through the short radial lunate ligament, the whole carpus falls into a volar subluxation. In this patient, the fracture remodeled quite well. The plate was removed, but you see that the wrist stays deformed. Dr. Harness used to be a fellow of Dr. Jesse, described in this paper three factors that can give you a risk that you can predict in these fractures, which are the AOB33 fractures, that they might end up with a volar subluxation if you see that there's carpal translation more, there's a lunate subsidence in that ulnar part more than 5 millimeters, and the volar cortex length of that volar ulnar fragment is greater than 15 millimeters. And here's an example showing this. You see the carpal translation, the subsidence more than 5 millimeters, and that's the cortical length of the volar fragment. This was plated in this way, and look at 10 days already. You see the volar subluxation of the wrist with that volar fragment hasn't been captured with a plate years after reconstruction. So this is very important too. This is where the CT scans and the 3D reconstruction comes very handy, because you will see that key fragments on the volar side. And here again, a case that hasn't been treated correctly, and there are a lot of implants now that has been devised to solve this problem. The volar rim plate, adding hooks to conventional plates or plate extensions. This one was treated with the volar rim plate. And the very important thing is, when you put the plate on, you have to check if the wrist still is unstable, trying to fall down into volar subluxation. When in those cases, you better put a pin across the radius into the lunate and keep it there for 6 weeks. You can see another example of the use of these plates that have hooks or extensions to solve these problems. And all of these are now trying to get this volar fragment or volar rim fragment stable. See this case in the bottom part of the slide. Again, the radiocarpal joint was transfixed for 6 weeks, because despite the fixation of the volar fragment, there was residual subluxation. And finally, how to avoid flexor tendon problems. Remember, you have to place the plate proximal to the watershed line. And you see that reconstructing, reducing well the volar tilt, you will be okay with flexion tendon contacts with prominent plates on the volar side. The problem tendon is the flexor pollicis longus, and here you can see a whole bunch of publications of this. So this has been already shown in the laboratory and also clinically, that distal to the watershed lines, there is the potential to impinge on the traversing flexor pollicis longus tendon, even when a radius heals anatomically. But I think this also depends if the plates are thick or thin or streamlined. So there are a lot of volar plates, and you better watch out when you have their thicker plates and much thinner plates, and I think that makes a difference. However, plates directly or beyond the volar rim should increase pressure and wear of the FPL tendon. So all these plates that over the rim, as the volar rim plate, what they recommend to remove them after the fracture is healed. See here, there's the typical case of a plate that it's a little bit thicker. The volar tilt has not been restored, and here you have a problem with attrition tendinitis of the hip. If the fracture redisplaces, as in this case, you end up with ruptures, and you have to reconstruct the fracture again early on and do something about restoring the continuity of the flexor pollicis longus. On the extensor side, most of the time, these are self-tapping screws that pass across the dorsal cortex, and then they produce attrition tendinitis and rupture of the extensor tendons. And here you see another example. So the thing is to stay short of the dorsal cortex when you measure the length of the screws, 2 millimeters short of what you're measuring, as showing that in that slide underneath. And that's the way to avoid that complication. These are special skyline views and dorsal horizon views that you can use intraoperatively if you want to be sure that your screws are not trespassing the limit of the dorsal cortex. And the last thing I'll show you is an intra-articular hardware. A lot has been said that these plates, especially in osteoporotic bone, should be placed very distally to provide subchondral support. and sometimes you may end up with screws inside the joint. So you can use this intraoperative X-ray elevating the wrist about 22 degrees so that the X-ray is parallel to radiocarpal joint in the frontal plane, and you can end up discovering that some screws are inside. Sometimes they can go over and block the radio honor joint. Everything, it's okay. As soon as you remove the implants motion, it's going to come back very easy. So in conclusion, remember that all these complications, the most common, can be avoided if the surgeon has the correct diagnosis, master reduction and casting techniques, is familiar with the anatomy and surgical approaches of the wrist, chooses the appropriate implant for each fracture type, and most important, can hopefully handle non-compliant patients when something goes wrong. Thank you very much. I can't hear you. Hello.
Professor, when will you indicate a surgery or when you wanted to treat conservatively?
Sorry?
When you will decide to treat conservatively, when you wanted to decide surgically?
Well, that was in the first slide of the talk. Basically, in stable fractures, extra-articular fractures or intra-articular fractures that you do a close reduction and remain stable, these are stable type of fractures. Most of the time you can treat them conservatively. More complex fractures in the elderly patient that even with not very good close reductions, there are papers that have shown that the functional results, despite not very good final X-rays, that the results are acceptable for that age group. So in elderly patients, it's the same as the proximal shoulder. If you can get them with conservative treatment, it's okay. For the more active patients or irreducible intra-articular fractures, most of the time we will decide for surgical treatment.
Professor Digo?
Yeah.
Can you hear me?
Yes.
Yeah, thank you. Thank you so much for highlighting the important salient features and the tips and tricks of avoiding the complications in treatment of the distal radius fracture. I just have two questions to you. One is, so how often do you think wrist arthroscopy is useful in avoiding malreduction in articular fractures? Number one. Number two, when you have a distal radius fracture with a DRJ disruption, with obvious DRJ disruption, so when you decide this particular patient needs a TFCC repair or a ligament repair, so he doesn't come back later for a unlacerated wrist pain. The question number one is how often do you think arthroscopy is useful in preventing articular malreduction? Question number two is, when you have an obvious DRJ disruption with a distal radius fracture, so what patient do you select for a ligament repair?
Okay, arthroscopy. If you're going to use arthroscopy, first you have to know how to do arthroscopy. I mean, not every surgeon has arthroscopy skills in the wrist. If you have that, then it's most of the times are the fracture patterns that you might suspect associated carpal ligament injury. Just by putting the arthroscope in, it's not going to help you to get better reductions as with open techniques, because all of the tricks we know with pushing up the fracture fragments against the carpus and all that, you can do it with mini open or assisted or putting the scope in. It will help you just to control the reduction, but not how to do the reduction. All the tricks with the K-wires and pushing with elevators is done the scope just help you see that you're getting a good result. And then the DRUJ disruption, I think Dr. JÚPITER is going to talk a lot about that. But I think the most important thing is after fixing the radius fracture is to check the stability, the clinical instability that you may have in the distal radial joint. And first of all, remember, when you put the patient to sleep, go and see how lax is the patient on the other side. You might have a young girl with very lax joints, and you think that it has a rupture. It's just lax. So most of the times I will decide by seeing if I have important anterior-posterior displacement, then you can treat them accordingly, putting a pin across to the radius, keep them a few weeks in a sugar tone splint, or repairing the TFCC primarily.
Thank you.
Do you recommend ulnar styloid fixation regularly? If there is ulnar styloid fracture with the intra-articular fractures of the distal end of radius?
Yes. Yes, I think that if you look at the literature, the results with external fixation and the early comparative series between open reduction and internal fixation and external fixation.
The question is on ulnar styloid, fracture ulnar styloid, fixation of fracture ulnar styloid. How often do you do that along with the distal radius?
Ulnar styloid. Well, it depends again what I said before. Usually it was thought that the foveal insertion of the TFCC, if it goes all the way down to the foveal, and you have that kind of fracture that shows that the fovea is inside that fragment, there are very basal ones. Then those are the ones that you might need to fix because they're associated with a foveal disinsertion of the TFCC.
Thank you.
Thank you, Professor. We'll go back to Professor J.C. JÚPITER. He'll be talking on DRUJ problems, diagnosis and management. Professor, you can share your screen.
Okay, let me move ahead a little bit. Just add a little bit about reconstruction, but no time. Here we go. Okay. Well, the interesting thing about the distal radioulnar joint, it's really part of the forearm, which is part of an articulation. So the proximal and radioulnar joints are really part of this essentially important joint for function. If you look at this schematic from Marco Garcia-Elias, you see that the radius rotates around the ulna. It's not the ulna rotating around the radius. And as a result, it's a contact joint and a contact pressure. And the question about styloid comes about if you fix the radius with a volar plate and restore the alignment of the sigmoid notch, and then compress the radius to the ulna, you're restoring the contact pressure, and then rotate the forearm. Even in the presence of an ulnar styloid fracture, you rarely will sense instability. And that's because, as I mentioned with the trochlea olecranon sulcus contact pressure, the same goes here. And so the stability of this joint it's a weight-bearing joint in a way, and it's important for the contact pressure. And we see that in the shape of the ulna head compared to the sigmoid notch. It allows motion and still contact of the articular surfaces. This was demonstrated by Lees and Schecker very nicely. When you see a patient who's had resection of part or the complete ulnar head, and if you ask them to hold a weight of 5 pounds or more and then get a sagittal X-ray, you will see in a frontal plane that the radius and ulna are converging. And that's because you've lost that contact pressure. So this joint allows motion and it carries load. And when it's injured, stiffness is a result. And if it lost its articulation, then instability and articular dysfunction occurs. We can see fibrosis as a result of trauma. We can see intercondylar fractures, articular injuries, and ligament incompetence. Once we're dealing with chronic instability, as Adams in the US defined, there are a number of problems that may be important to address, and we'll take these individually. As Dr. Fernandez mentioned, where the fovea attaches at the base really may depend upon instability if you have a large ulnar styloid fracture. But what we've learned in distal radius fractures with ulnar styloid fractures, I repeat, is the volar plate has restored the rotation of the radius fracture. As a result, it's restored the orientation of the sigmoid notch, and therefore the contact pressure on the ulnar head has been restored. So we don't see instability much anymore like we used to see when we treated these other methods. Acute injuries, as you know, can be from trauma, but more often than not, we're seeing it from chronic sport-related injuries or workers doing forearm rotational injuries per se. As you know, the hallmark clinical exam is tenderness at the fovea, and again, pushing the radius and ulna together. If you have pain, then there could be a problem with the TFCC as well. It's been well described by Palmer and many others, different degrees of injury. Suffice it to say, if you looked at MRIs of distal radius fractures where the end of the radius has been widely displaced, you will find always soft tissue injury to the dorsal volar radio-ulnar ligaments. That's the only way that displacement would occur. And here's an MRI, if you look, of a normal TFCC where it's surrounded by these arrows, and where you've lost the TFCC as a result of chronic wear. Arthroscopy is important here, but as was mentioned, you really have to understand that there's a lot of distortion and magnification in arthroscopy. What looks like a big hole may not be a big hole at all. So one has to be a little bit humble when defining the extent of injuries of the TFCC. But it is a very good way to understand if the TFCC has been torn off of its attachment from the foveal insertion here in the blue arrow, as opposed to central impaction, as you see here. The idea of taking this hole and making it bigger with a shaver pleases the doctor and pleases the patient conceptually, but I don't think it really addresses the problem. And so it's what you're looking at here is the head of the ulna through the hole. So we have to keep this in mind for ulnar-sided wrist pain, including lateral sided injuries, the LT ligament tear, ECU and FCU injuries, and even ganglion cysts. The so-called tilt is triquetral impingement ligament tear, and we'll have pain directly over the triquetrum with a history of a hyperflexion injury. And while the x-rays are normal, you may see swelling and a limited range of motion. And what you'll see is increased signal in this area, and there'll be a injury to the TFCC and the lunotriquetral injury. Sometimes these are appreciated, but often they're missed. And more often, they can heal with conservative treatment, but a recognition of this particularly ulnar-sided injury is important. Arthroscopic debridement in this case may remove some of the reactive synovitis per se, but may not repair the LT injury per se. And so here we're debriding this more thoroughly. ECU, as you know, can come about from a direct trauma such as hitting the side of a board or and with a torsional injury and the subluxation of the ECU, which sometimes clinically may be difficult, but it may be picked up more clearly on the MR in the coronal section. What we often see in ulnar-sided pain is tearing or at least synovitis below the ECU in the so-called subsheath. And this may show up more clearly on an MRI, and it's something to consider when you're doing the arthroscopy, is to turn your scope to get a good view of the subsheath. But subluxation, when you see it in this patient, is quite visible. It may not be as obvious per se. And treatment should be conservative to start out, with at least 6 weeks of preventing forearm rotation. Once you start getting into deformity from trauma, now we're looking at chronic problems. And as I mentioned, you may have contracture or impaction leading to loss of forearm rotation. And, you know, sometimes people talk about with pronation, you have contracture of the dorsal components, and with the loss of supination, you have contracture of the volar components. But you may see problems as a result of ischemia of the pronator quadratus. And, you know, when your pronator is contracting, it pulls your forearm into pronation. And so here, where you see in supination how the pronator is out, quadratus is out to length, and here in pronation, it's contracted. And these pictures from George Orbe show this very nicely, because this patient has a pronation contracture, meaning she can't supinate very well. The X-ray is really unremarkable. She had a distal radius fracture, but may have had ischemia of her pronator per se. And years ago, it was described by Kleiman in Indianapolis about the contracture. And what you may find is the pronator is contracted, ischemic, but more important, the volar and even dorsal capsular ligament is contracted, and there may be fibrosis in the joint. So lifting up the pronator quadratus, freeing that, and then looking at the joint itself, opening that up and debriding the fibrosis, debriding the capsule, and then making sure that you can have passive supination. And it's a step-by-step debridement, extending all the way up to the dorsal radioulnar capsule. But here's the case of Orbe showing a nice result per se. Abutment, we know, and sometimes I recently saw someone who was diagnosed as Kienbach's, and it's not uncommon to see that diagnosis, but findings like this are pretty common. When you do an ulnar shortening osteotomy, one has to keep in mind this very important study by Tolat and Stanley, who pointed out that the orientation, especially if you're dealing with a malunion of the radius, is important in that it may be abnormal. And so a well-oriented sigmoid notch is important per se. Now here's a patient who had that. Case of Diego Fernandez with a malunion that with an orientation of the distal radioulnar joint, that you see the sigmoid notch and correction. Here's the initial function with limited extension flexion and limited pronation, an osteotomy done, and that improved just by restoring the orientation of the sigmoid notch. Once we're dealing with pathology, either from trauma, arthrosis, loose bodies, or disruption of the sigmoid notch, then we have a few choices. The resection arthroplasty is important, and a low demand patient, for the most part, unless there's instability, has worked well. So the so-called Darroch resection in many patients has worked well, and it's certainly a first line of approach. Bowers described shaving down the end of the ulna better in rheumatoid and then into position of a soft tissue per se. This is useful, I think, better in rheumatoid arthritis. Kapanji has described arthrodesis of this joint and then resection proximally. In a young person, you're preserving the ulnar-sided ligaments and the ulnar-sided joint. The problem can be instability of the proximal ulnar stump or failure to fuse per se. And now you're directing all of the forces more to the radius and ulnar side of the wrist. So this can work particularly in younger laborers. The ablative procedure, as I started out with, is a problem because you're losing this contact pressure and you may get impingement, and that's where prosthetic implant comes in. And there's a number of options for this, either isolated ulnar head, partial or total, or even a whole total joint arthroplasty, non-constrained or constrained. And there are several options available for either partial or complete ulnar head replacement. And the idea is to produce pain relief, but also provide stability. And that's one of the problems with the ulnar head implant, is that if you have inadequate soft tissue, instability may persist. And so a careful and meticulous reconstruction of the soft tissue is important. So it's important for these particular problems, but you need to have ideally soft tissue competence to do these. Some people have looked at total joint arthroplasty, and the one I'm most familiar with is in the right side, my right side, that's the Schecker prosthesis. All of these will have certain complications, and they're not so always predictable. With the ulnar head replacement, we can see erosion and we can see loosening. And a good revision is this Schecker prosthesis. Here's a man who had actually a fusion of the radial ulnar joint post-trauma and a resection of the radial head, but arthritis in that area as well. So he actually had no forearm rotation for quite a long time. I put in this implant arthroplasty, and he improved quite a bit, both in objective and subjective outcomes. So this prosthesis may not be available to everyone, and it's quite expensive, but it's a interesting prosthesis, and it, in my hands, has worked exceptionally well for some very difficult reconstruction. There's the ulnar implant and the radial side implant, and I think it's best done with someone who's mature. Here's a woman who had multiple procedures. She has a form fruits of deformity of the radius for many years, and I was able to bend the radial shaft component but she really regained motion, stability, excuse me, and pain relief. Another one with arthritis, having had a wrist fusion. Here's the end of the ulnar head removed and had implant put in. And remember that without that ulnar head, you may have instability, pain, and problems. We've tried to do tenodesis of the stump. We've tried to lengthen, but I think this prosthesis is the best. And here's a man who had 14 operations after a salve Kapanji, and I put this in because he was grossly unstable, and he didn't have full pronation, but nearly full. I looked at this between 3 medical centers, and early on in Checker's experience, this prosthesis, and with an adequate follow-up. And you see most of being done in middle-aged patients for a variety of reasons, per se. And also, most of these are not done as the primary procedure. And the long-term outcomes for 5 years over in almost 100 patients in this review was relatively good. Pre and post-op pain, pre and post-op motion, pre and post-op subjective patient evaluation. But there will be complications. Anytime you're doing revision surgery in an area that has modest soft tissue coverage, this could be a problem, but very, very little loosening and very little implant problems, per se. Here's a rheumatoid patient who had a DARA fusion and a lot of instability. Her hand was not very functional and had this implant put in and a good function. So if we look at this point of view, most of the people with these implants for arthritis and for salvage have done very well. And so I think for me right now, this is the primary option for symptomatic DJD.
Yes.
And I thank you very much again for inviting
Best-looking
myself and having the opportunity to share this experience.
Jesse?
Yes, sir.
Yeah, thanks so much for simplifying the ulnar-sided wrist pain. Yeah, I have just one question to you. A patient with a DRJ instability. So how do you decide which patient needs conservative treatment, which patient needs TFCC repair, and which patient needs Adam Burgess procedure? I mean, the joint is normal, the cartilage is normal.
Well, if they really truly have it post in a younger patient, I think perhaps the first approach is try to restore the soft tissue stability, as Adams and others have described. Not want to go to implant or even Darrick or whatever. That's with a normal articulation.
Thank you.
We're going back to Professor Diego Fernandez to speak his experience on scaphoid fractures. Fracture and non-enough scaphoid. Professor, you can share your screen.
Yeah, I'm trying. Okay, thank you very much again for the invitation. I will show you my experience with scaphoid fractures and non-unions. The indications for conservative treatment and scaphoid fractures for us is the non-displaced waist fracture, non-displaced waist fractures, and distal pole fractures. So those that they show intra-scaphoid norm within normal or a fracture gap less than 1 millimeter. In this conservative treatment with a short navicular cast for 8 to 12 weeks, it's okay, and the results are quite good. The single most important factor, however, to predict union is not the time since injury, and it's not the fracture location, but actually the fracture displacement. Not only the gap formation, as I said before, but also a translation more than 1 millimeter and an angulation of the fracture for more than 15 degrees. So therefore, the indications for operative treatment is the displaced unstable fracture, the comminuted fracture, scaphoid associated with perilunar dislocation or distal radius fractures, but also the patient's individual needs. What about percutaneous fixation? We think that it avoids additional damage to the vascular supply. It does not disrupt the volar ligament as we do with open reduction. The dorsal palmar or anterior grade dorsal fixation allows, I think, for more stable fixation of proximal pole fractures. Their overall soft tissue trauma accounts for faster rehab and fracture healing. And probably the most important thing with percutaneous fixation is to have the screw exactly in the central axis of the scaphoid, because this is the most stable fixation and will give you undisturbed mobility. Do we use a dorsal or a volar approach? The volar approach, the advantages is that it's minimally invasive. Hello, everyone. To function in most of the patients, and also the rate is close to 100%. Advantages of a volar approach is technically demanding procedure, and we have increased X-ray exposure. If you have this kind of relatively stable fracture with slight displacement, these are very well amenable for percutaneous fixation. What about the distal screw entry? Now, traditionally, you can do a small capsulotomy of the scaphotrapezial joint and lever the trapezium towards the dorsal side to have a better exposure of the entry point with a conventional approach. Some other authors prefer to resect the so we want to give them one single procedure and hence the amyotroplasty. The approach, this was the gold standard which has largely been supplanted by a version part of the sculpture. You drill it, and you will see that this technique gives you the best placement of the screw. So here we see that central screw placement for both transverse and oblique fractures distributes equally the compression load across the whole fracture plane, therefore increases stability. Here you can see on the left side, you see that the screw is slightly oblique with a standard volar approach, and that it's very central in the middle of the scaphoid. If less than 8 millimeters. It's an easy approach. It doesn't need any manipulation or traction. It doesn't resect any part of the trapezium, and it gives you a central placement of the screw. The possible disadvantage would be some cartilage changes or cartilage damage of the S joint, but this has not been proven up to now. The dorsal approach was described by Joe Slade, and he also had 100% rate at an average of 12 weeks, fresh fractures. And this is a way to do it if you're going to use arthroscopically assisted fixation. So the point of entry is pre-injury status. You have to flex the largely intact. They have a better. It's usually 1 to 2 millimeters radial to the scaphoid insertion.
gives a better chance for the tuberosity.
The K-wire or the central guide wire, you go exactly on the axis of the slight abductive thumb, as you can see there. This wire is to find the ring sign. You see the scaphoid as a circle, and that's where you're going to target the guide wire. Here's a case that has been treated in this way, from dorsal to palmar or anterograde fixation with arthroscopic control using an Acrotrack screw. But the same thing you can do with a mini open technique, knowing if you don't do arthroscopic, you know that eventually where it is, and you can use fluoroscopy to get the guide wire in the right place. You see that in this case, the screws placement has been very good. What about open reduction? We will use it for comminuted fractures, bone grafting if needed, irreducible displaced fractures, transcaphal perilunar dislocations, and associated distal-radius fractures. Here you see a case
See what's going on in the
fracture, treated through a dorsal approach and an anterior.
It's not my job to start singing praises of a hemiarthroplasty.
This is an absolute.
I think I'll leave that to Dr.
Scaphoid fixation.
Dr. Williams for his next talk. I have to, however, caution you that a reverse arthroplasty is not a benign procedure. It has its own set of problems.
And with anterograde fixation. Now we go to the treatment scaphoid non-union. We follow this. Union is stable. There's no deformity, no collapse.
You can get scapular notching and
prognosis, and we will repair all. You don't need to put a graft in, and you can do percutaneous or assisted arthroscopic assisted fixation. The mobile non-union is very, very unstable. You have early collapse. They all have a DC deformity, but they have a good prognosis. But here you have to correct the deformity. You may use anterior wedge grafting or compressed cancellous bone grafting, open or arthroscopic. Sclerotic non-union, these are non-unions. They have moderate to marked collapse and osteoarthritic changes. You can say that this is already a slack wrist type 1, and they have fair prognosis. So we have the choice of reconstructing and revascularizing the proximal pole. The vascular non-union, here you have a fragmented necrotic proximal pole. They're non-salvageable, and then we will use, most of the times, the authors are using now free osteochondral grafts from the knee or prosthetic replacement. Here's a classic case of a late union or fibrous union, but with a DC deformity and a humpback deformity of the scaphoid. First, you correct the lunate rotation, you transfix it through the radius as described by Lynchite, and then you put the screw in with the technique we showed before. This is this example. The mobile non-union is now deformity scan. If you restore the anatomy, will prevent malunion. It'll improve functional results. We stop the progression of carpal collapse, and therefore reduces the incidence of late arthritic changes. Amadio described the intrascaphoid angles, and Bob Belso was the first author to use computerized imaging of scaphoid non-unions to calculate the size of the graft to be interposed. And Bain described the height to length ratio of the most let's say, convincing way of measuring the humpback deformity. Nowadays, the non-union can be also preoperative planned with a computer, try to reconstruct the original shape.
Top 5
In gray, you
tips.
see the contralateral side,
Number 1,
normal side. Those images are superimposed,
selection.
and then
We
you
have
get a
moved
final result.
from the times
You can
of
calculate with the computer the amount of graft needed.
bone
In the
grafts.
beginning, in this publication in '84, we used
The success, as we have
the length
seen,
of the scaphoid just by interposing the iliac graft in this way and fixing it with K-wires. We used the comparative x-ray with the wrist and maximal ulnar deviation to pay for it and therefore have an idea of how much bone you need to put in between those two fragments. We use the extended Rousset approach, resect the non-union, and also use
with the hemiarthroplasty depends on
to correct the flexion deformity and the slight pronation deformity of the distal fragment. And then the trapezoidal, usually trapezoidal iliac bone graft comes in and is fixed with screws and here an extra K-wire. What happens if you have an irreducible DC malalignment associated with these? Again, first correct the dorsally rotated lunate, then fix it with a K-wire.
Get the stem would cause significant bone destruction. Fortunately, in the United Kingdom, we can get information from the operating surgeon of the type of the prosthesis used, and fortunately, this was a platform prosthesis.
So here, the rotation of the dorsally
and it wasn't too difficult.
Transfixed to the radius, and then the reconstruction done as described before. In our series of 14 non-unions, we had in 7 years, our healing rate was 89%. Patient satisfaction was 92%, and the overall ratings were 70%, 15 excellent and good, and 5 and were fair results, 30% of the case. What happens if you have a non-union following a failed internal fixation? The problem is you have a central defect in the stay foot because of the loose screw that you have bone loss. So what we do is to put a iliac peg graft in intramedullary and the old screw channel, and then we put on top of that, we call it Arc de Triomphe graft, not that is coming from Paris.
About 5 to 8 millimeters from the
so you don't fracture
footprint
the little peg you have
attachment
as shown here in the
and
back.
of the rotating
So this is a case
to the dome of the head.
intramedullary in the proximal pole, some bleeding points there, so you don't need a vascularized bone graft. And then
Measuring the metaphyseal length
graft comes in place. You don't have any place for screw fixation, so here again we will use K-wires and a cast for about 8 to 10 weeks. And here's the 1.5 year result with this technique. What about a vascular proximal pulse? We decide the indication based on imaging with gadolinium enhanced MRI. If you have fragmentation, subchondral collapse, and also you can diagnose degenerative changes. But most important, perhaps, is the analysis of the bleeding points in the proximal fragment and the bone sclerosis. So here we have the indications for vascularized bone grafts. We will do that in smaller vascular proximal pole non-unions, large fragments with absent bleeding points, or recurrent non-unions after conventional graft.
Is one of the techniques.
This is
So
a
if
case
you
of 10 weeks after conservatively treated proximal
the
fracture.
tendency to pull the tuberosity
3-year-old girl, and you
to the
see
lateral
that
fin,
there is
and
a vascular necrosis.
this resulted in overtensioning the anterior cuff and having a lax
Two intercompartmental supraretinacular
posterior cuff, which almost always resulted in loss of external.
And which is elevated with that pedicle, and then that vascularized pedicle graft is put in at the level of the non-union. You can see 7-year-old result. This vascular fragment is non-reconstructible. As I said before, some authors prefer to resect everything there and put a free microvascular graft taken from the medial condyle in the knee. What we have done here is to put a pyrocarbon prosthesis by Aldo and Pecchino in 2000, and this is actually a spacer that maintains the carpal height. You don't have to fix it, and the long-term results, a lot of series here in Europe, and been very promising. So in conclusion, in my experience, 90% of the cases of non-union arthroscapes for even those with scant bleeding.
Heavy arthroplasty where that you
I have treated them with internal fixation,
which
conventional bone grafting, and only just 10% of the problem cases we needed to revascularize or put a prosthesis in. Thank you very much for your attention.
Thank you, Professor, for describing the scaphoid treatment overall in a nutshell. Thank you. So it's not uncommon to see the scaphoid non-unions, patient with scaphoid non-union coming back 5 years later, 10 years later down the line, maybe 15 years later down the line. So what's your criteria to decide you want to do a reosteosynthesis of this particular patient who comes 5 years down the line, 10 years down the line, or when you want to brand him as a snack wrist? What criteria do you take to decide whether you want to do a reosteosynthesis or you want to brand him as a snack wrist and do a salvage of the wrist rather than a salvage of the scaphoid? What criteria do you to take a decision on that? Because it's not uncommon for them to come back 5 years, 10 years, 15 years down the line.
Exactly. I think it depends on how much degenerative changes you have in the joint. If it's a snack one, sometimes you just do a styloidectomy, but that's where the pain comes from. And if it's a proximal non-union, which is long-standing, usually you don't have deformity. You don't have carpal collapse. They're still there. It's an extra little piece of bone, which might be ischemic, but it's still with cartilage and no degenerative changes.
the poorer outcomes.
Scaphoid facet. So you just do a styloidectomy on those and they do fine. And if you want to reconstruct, then again, it depends whether or not in those long-standing non-unions, if you have good vascularity of the proximal pole. So you might have in mind probably need to revascularize with a pedicle.
So take home message.
If you have more than that,
many arthroplasty is a difficult
carpal
procedure with many variables.
You have to treat them as
and to get an optimal outcome
for corner fusion. And
you need to get the length version.
In a snack 2 or a snack 3, a snack 2 or a snack 3, would you prefer a proximal rapectomy or a partial wrist fusion?
Well,
and if you prefer would you prefer a capital unit fusion alone, or would you prefer a 4-corner fusion to a capital unit fusion alone?
Capital unit alone. Yes, I haven't done. I don't have experience. I've done proximal. I've done 4-corner fusions, but I also have done scaphoid or capital lunate fusions. We published that, a couple of papers, but
the tuberosities
about that. They don't move very well, but they do find that combined with styloidectomy. But the proximal row corpectomy is a very good option. The X-rays, long-term follow-up show a little bit of degenerative changes in the long run, but you can gain about 15 to 20 years with a proximal row corpectomy. No problem, and it's not diffuse.
Absolutely. Thank you. Thank you so much. Thanks for the wonderful session on the wrist. Thank you.
Thank you. Thank you to the speakers, Professor Jesse Jupiter, Professor Diego Fernandez, and our panelists, Dr. Prakash Apasar and Dr. Bharat Kadadi. So moving on, we have our ankle and foot session. Moderators, Dr. Ajoy SM is online. I'd like to invite Dr. Narendra and Dr. Manjunath Kumar on stage. So the first talk is by Professor Paul Tornetta. Professor, are you online?
I am, yeah. Can you guys hear me okay?
Yes, we can see you. If you can start sharing your slides and go ahead with the presentation, Professor.
Okay. Can everybody see the slides okay?
Yes, we can.
Great. So what I'm going to talk about is sort of how to stay out of trouble with ankle fractures. It's a place I work in Boston. And I have some disclosures, some of the implants that you'll see but this is a principle-based talk. I don't think it has any role. So I'm going to talk about the top through and then one problem. So one is fibular length. You have to confirm that this is correct, even if you're high. Syndesmotic translation and rotation, and over-reduction indicate relatively free flow. You push the medial malleolus too far over, and you can close down the syndesmosis to its tightest position. So here you can see an example of the malleolus being over-reduced. So this is a pretty common problem when you have that obliquity from high and lateral to low and medial, where people put the screws in at this angle and push the medial malleolus over. You can really pretty clearly see that on that X-ray. And you can see that's pushed over. You've lost the normal contour, and the talus is being pushed towards the syndesmosis. So you can see in this case that required an osteotomy medially in order to get length and to correct the lateral side. So here you can see that once that's corrected, you can get the talus back under where it has to be. And that correction then comes from the top lateral side as well. So here's just an example. You can see pretty nice relationship of the medial side here. And then once the syndesmosis was fixed, again, these are not my cases or ones that I've revised, but you can see that the syndesmosis was pushed to its most medial portion, right? So there's a little bit of play in the syndesmosis that is over-reduced. So here you see a nice relationship to the superficial joint before the reduction, but then afterwards you can see that the talus is shifted too far medially, and that can be in your way as well. So here's just another example. This is someone who fixed, you can see a fairly large incision, an aggressive approach, but you've lost the syndesmotic space, and you can very clearly see that the talus is shifted too far. As discussed earlier. That's that translation that you don't want to have. Have to think about the fibula. You always have to be out to length. This is something that people from my institution years and years ago have talked about. But you have to think about the fibular reduction not just when it's low, but also when it's above the syndesmosis, because that can affect your outcome. So here's a pretty clear case of a ligamentous SE4 treated non-operatively. That's going to require some planning and revision. This is probably a 25-year-old case. These principles are not new. Fibular length has to do with syndesmotic reduction. This is a relationship everyone needs to understand. A lot of times when the syndesmosis looks off, it's actually because the fibula is short. As you lengthen the fibula, you tend to gain the correct amount of tension and get a much better reduction of the syndesmosis. Lateral tilt, wide or even narrow medial clear space, showing that syndesmosis is off, and a loss of the lateral corner. So sort of here you can see, once you bring it out to length, how it looks. So just going back, you can see that the medial clear space is a little wide. There's a lateral tilt. You've lost the lateral corner. And with lengthening, you get a reduction of the syndesmosis. And how was that done? That was done with lengthening up high. So here you can see the fibula was short, brought it out to length at a higher level, and got the syndesmosis. Here's just an example of Weber C to say that you have to look all the way up here, even though the mortise may look good. So here's a very young patient. I think she was about 18. And you can see that this reduction looks pretty good. This is my case. This is in the OR. Said, how do you think it looks? The residents thought, wow, this looks great. And actually, the ankle mortise looks pretty good. But you can't forget to look up higher because this is still very short. Now, this was actually a difficult reduction. I ended up having to put the compression distraction device to get this out to length. And the ankle mortise looked on the side. So that's what she had to look like. But if you looked only at the mortise, you may be off here. So you cannot forget to pay attention to the fibula, even when it's high up. This is an example of that same patient and in follow-up. We talk about reduction techniques of the syndesmosis. There's fluoroscopic and open methods. I'm going to go over a few of these briefly. This is just an example. Here's a syndesmotic injury. And you can see the medial side is fixed first. I frequently will do that. Most of the time now I use bicortical screws. And what I do is I get true laterals to look at the fibular location. So this is a true lateral of the affected and the non-affected side prior to fixation of the syndesmosis. If you look at where the back of the fibula lies, it's in exactly the same position on what I would consider to be a perfect lateral of the plafond. This is how I do that. I have them both up on the fluoro screen at one time. And then this one was reduced. You can see a towel that's not under the ankle, but not under the calcaneus, but under the ankle. I rarely use clamps anymore. I usually will use just a push reduction and a K-wire, which I'll show you. But this is just an old example to show how you can get that reduction and that reduction looks very good as long as it's lined. Where we looked at cadaverics, the lateral view regularly, one of whom was correct 100% of the time. So it's a very good view to use. The lateral, the AP is far less helpful. Here's just an example of a case. This is someone who did a mini open of the through a large incision of the fibula just to get it out to length and get the rotation and then fix the syndesmosis. This was actually done in my hospital by one of my partners. And they called me into the room and say, hey, it looks a little funny on my post-op x-rays. What do you think? And you can see it does look a little funny because that fibula is pretty far behind that line, which is typically where it lines up. Usually the back of the fibula is right at the back of the articular surface. So I got a view of the normal side. So well, let's just look at against the normal side. We got fluoroscopic views. And here you can see that back line. And you can see that the affected side is now posteriorly translated. So there's definitely an error here. So this was reopened. This is what it looked like. Now, I'd call you why, but this is the area you want to look gapped open. So the syndesmotic screws were removed, and it actually reduced all by itself. It just popped back in place. You can see that reduction looks much better. And then it was fixed. Remember, the capsule is disrupted, so the talus can sit in a lot of places. But if you look at the view now of the perfect lateral, the more of the plafond, the back of the fibula is sitting at the exact same level. And a CAT scan confirmed that that's a good reduction. Now, when you're thinking about doing an open reduction, where do you look? And I see a lot of things about looking at the incisura, and I think that's not the best place to look because that area can be very differently shaped. It can be flat or very constrained. When it's flat in particular, it's hard to understand the relationship, and I think it's better to look at the joint. So this is where I like to look, right at the anterolateral corner of the joint itself, rather than looking at the incisura. And we tried to look at this. This is the incisura. This is a cadaveric study that we did. And basically, we asked the question and covered up the other area. We had a bunch of surgeons come in and look at reductions which were on, and they tried to get a perfect reduction and drive a K-wire across, and then we referenced that using other K-wires. Look at the study if you want. We had 10 cadaveric ankles, and of those pairs, we did reductions. And then we had someone else, an independent observer, just measure the difference in distance, right? So if you look at the AP difference at the level of the joint of the cartilage of the tibia and fibula, and then we went one versus the width of the incisura to understand why people are malaligned, to see if there was a difference. And the answer was very clear. Every surgeon that did this study with us had a better reduction at the level of the syndesmosis by looking at the articular surface, not at the incisura. The average amount off was only a millimeter plus or minus 0.7. So that puts you pretty comfortably in 95% of the cases, probably more, well within that 2 millimeter margin that we think is acceptable. The other thing we found was that if you look at the articular surface, the difference between the width of the articular surface at the level of the joint is only 2 millimeters, meaning that if you're perfect at that level, you're not going to be more than 2 millimeters off. Whereas though if you just look 1 centimeter above, this is just an example of a case and how I do it. So this is a high fibula. It looks to me to be out to length. I wasn't too worried about it, but I'll show you a reconstruction later.
One horrible case of female 63-year-old after the fall with four-fragmented fracture.
You can look at the articular surface of the anterolateral plafond against the anteromedial fibula.
Young anti-chestic surgeon decided to use
sort of showing that this is being held reduced by me, and now I'm going to unreduce it to show you the difference. So it's just a little anterolateral incision. Now here's a finger reduction, and that's the reduction you're looking at. And it's very easy to understand that relationship. This is just a little bit of a close-up, and you're looking a little bit of tissue off the capsule to see action that all of my residents are quite capable of doing with me standing next to them. And this is just that same patient with a push reduction, a K-wire, as we have with tight ropes. And, I would say we can get into a discussion later about whether it's worth using those. But one of the things a tight rope won't do, because it allows for instability, right? There's planned instability, is it's not going to hold length. So you can't use these in a length unstable patient. So this is an example of a patient sent in to me for revision, and you can see that it's off. And you can also see that the fibula is very short. And what was the problem? The problem was that there was a high fibula, and like I said, they didn't pay attention to fibular length, even though it's a Weber C. So that's a problem. And that's where that error is. And this is what the CAT scan
62 years old.
So not only is it off in length, it's off in
infection on the right side.
This is just to show that when you take the tightrope out, if you just close this down, you don't get a reduction.
25.
This is just an example. In the operating showing the clamp being placed, you can see that we're still short.
And as you see here,
so this, rather than going up top to do an osteotomy, I came down distal and did a sliding osteotomy, and then just used a length technique with lock screws distally to gain my length. And then what you do with these is as you tension this out, so you can look on the right-hand portion of the slide, that's the anterolateral articular surface of the plafond against the fibula. It's right here. It's very obvious when it's perfect. And then that was fixed. And you can see that patient had a little bit of an anterior osteophyte already, but overall, a very good-looking mortise at the end of that procedure. So in summary, you want to gain fibular length and make sure you pay attention to that, even if it's a high fracture. You can do that by going down to the level of the mortise and looking directly at the articular surface. Be careful not to get in your own way, because when the capsule is disrupted and both sides of the ankle are unstable, you can push the talus in a lot of different directions. You can over-reduce things in either direction, medially or laterally. And then when you're reducing the syndesmosis, you can see this slide. This was an example of another patient sent in to me. That plate that you see directly anterior on the fibula is actually on the lateral surface of the fibula, and I never changed that plate, but had to reorient the syndesmosis and fix the wagstaff fragment. You see that's the reduction after we were done. You have to pay attention to perfect open reduction of the syndesmosis if you're unsure of your radiographic or fluoroscopic reduction. Thanks very much. I didn't know if you guys want to take questions.
Thank you, Jack, for that presentation. We have some questions coming up.
Questions? Hello, good evening. Should be okay?
Yeah.
Maybe just a couple of them. Okay, so to the reduction of the syndesmosis itself, is there any, very often do you feel that the reduction is more anterior when you're looking at the CT scan? Do you feel that the fibula is reduced more anteriorly in the syndesmosis, or it is anytime also reduced more posteriorly?
You mean the ones that I do that I've revised? Like, how do they come into me, or are they all off front or back? I've probably equally, and I've actually seen rotation in both internal and external rotation. And my belief about that is that for the most part, and there's a lot of data, that a lot of publications that I think are all errant in the same way.
I'm not going to put a reverse to you.
That, if you're going to use a clamp to reduce syndesmosis, you have to understand the orientation.
On the uptake on the reverse, just because
and my pen is.
I know it can create so much mischief.
The clamp has to be in a direction that pushes it together in the right way. So
as well, it goes so well when it goes.
That's posterior. Your clamp will have to be in this axis to push it up, right? If you push it over, it'll be here. Similarly, if you put the bolster under the calcaneus, sometimes the fibula will sit anteriorly, and you'll push it across too far in the front. So there's a bunch of, in my mind, sort of nonsense, because what has to happen is the clamp has to go in the place that it's just a point-to-a-point in translation. So you have to identify which way you want to translate, which is why oftentimes I do a finger reduction and then K-wire and then confirm it under fluoroscopy. But the internal rotation deformities that I've seen have primarily been from people who take a clamp from the anterior tibia to the anterior fibula and clamp it that way. And then what happens is it internally rotates like that. So, you see all of these deformities, and you can almost understand what the surgeon did wrong when you're revising them.
Wrong, it goes so wrong.
Good. And any word regarding posterior-medial combination in case of medial malleolar fractures?
The osteoarthritis one.
So
it's a lot better than the post-trauma.
The medial malleolus it doesn't concern me unless it's a fracture that extends around to actually take part of the posterior lip that I think is articular.
But the other.
So if you have a sort of a transverse, a Haraguchi type type 1 or transverse fracture that extends around to the medial side. I'll say more posterior incision. And I just typically go behind, in front of posterior tib tendon and lift everything up and then put a little anti-glide 2.4 plate or something back there. But you have to stay out of the posterior tibial tendon groove. And I think that approach, works pretty well for me. It's uncommon that I go there, but there are occasionally fractures of the medial malleolus that sort of wrap around to the back. And those are the ones I think you need to address posteriorly.
Right. Okay. So a 2.4 plate would be the.
Dr. Paul, there is one case. Our senior delegate, Dr. Rajanak, want to discuss about the ankle. So can you go there?
Are you there? There is a case sent by a delegate.
So basically,
for your opinion.
sorry, the question. What is the question? Can you repeat that again?
Okay. Yeah.
Hello.
How do you go about with tensioning to prevent instability?
I can. Yes. Can you hear me?
Dr. Paul, can you hear
How do you
us?
tension your prosthesis?
Yeah. This is a
You
case.
have to repair the tuberosities first. That is very important. And you don't want to sink the prosthesis too much.
Trimalleolar fracture dislocation. He has come
Dr. As
after 4
Jab
days
showed that
with this X-ray.
you don't want to sink the
How would you
prosthesis.
approach?
So this is sort of an SPF variant. It's really a posterior plafond injury. It's a shearing injury. We just had a very nice session on distal radius, and this is the same thing, right? So I would CAT scan these, but it could just be the way that it appears on my screen. But I would approach this assuming that there was not a lot of impaction, and I don't know if you can see. I can't annotate, can I? So if you want to look for marginal impaction, it's just like a posterior wall fracture, the acetabulum, or any other shearing injury, you can get marginal impaction. So if there's marginal impaction, you need to be able to reduce that marginal impaction, which you would do through the fracture site and graft it. But to me, I do these patients prone with them at the bottom of the table, so the foot is just at the very edge, so I can pull straight down. And I do a posterolateral approach through which you can address the fibula and the posterior malleolus.
There'll be a gap happening.
I've done quite a lot of these now. And
some people say this slope
and then I use a posterior plate, which I place underbent. So first thing you do is reduce the talus under the anterior part of the
is also important.
Assuming that there's no complete crack that puts that off. I think there's a bit that's intact. I'll sometimes K-wire that in place, but typically just anterior translation will hold it. You don't want to dorsiflex because dorsiflexion will actually pop it out the back. So it's a plantar flexion and translation that gets you to reduction. Then I use a ball spike pusher or a clamp percutaneously to get that reduced. I put K-wires across so that it doesn't over-reduce, because you can actually over-reduce these with an underbent plate. Then I'll typically lag the joint with a 4.7 partially threaded cancellous screw for really good purchase, and then use an underbent posterior plate to fix that and hold it down. That functions as an and then compress distal to that to make it into a buttress plate in the end. And then usually add through the same incision. I usually reflect the peroneal tendons laterally instead of going to the lateral side through that same incision and fix the fibula. And in these, I think the medial malleolus is, enough of that is intact that I probably wouldn't have to do anything for them.
Okay, what happened was this patient had severe soft tissue swelling and blebs and so on. So he was sent on a plaster cast. And then he came with this picture. This is after about 20 days or so. Now, how would you proceed?
Yeah, I think it's the same problem. So I would 20 days. I think I would still go for trying to reconstruct it, but I would get a CAT scan to understand what the talus
and
looks
don't forget
like, if
for the
there's
reverse
erosion
patrol
on it, and whether or not there's more loss of that anterior bone that started. Probably the anterior portion of the plafond is going to be preserved here because it's just riding a little bit on the talar neck. But the talar articular surface may be damaged, and you have to sort of make an assessment as to whether you believe that's going to be salvageable or whether you're going to have to move to an acute fusion. In general, I don't do MRIs with cartilage sequencing. I generally just make the assessment based on the CAT scan, and then in the operating room, the patients know that if the joint is completely destroyed, then
on tablets, and she lives alone.
So you don't.
And this is the X-ray that she came in with.
And then
Lee, could I please ask you what would your approach be for this kind of situation?
And it was unsuccessful.
Okay, so I see a series of X-rays, an AP, possibly lateral scapular, possibly apial limbic fracture of the proximal humerus, showing some comminution of the shaft as it joins onto the head.
How to help with the open reduction. I think that the tool that's most helpful here is a plate that you place under universal distractor was attempted. But what you can do is plantar flex and put the universal distractor on and then force that posterior piece. Once you get it distracted, you can force it in with the plate and use the plate as a reduction tool. I don't know if that was attempted or not. But at this point, I think that if you place the patient in traction or put a spanning frame on and gently crank it out to length, once you regain length, you can go back and try again.
Yeah, I think that was done, what you suggested. And
exercises, probably avoid active abduction until we see signs of union, and show her how if she stands and leans forward, she
on the screen. It certainly looks like the right idea.
clean and dry in her armpit. A little, give her the speech, a little bit of movement stimulates healing. Too much movement slows
piece down. But the principles look. I can't tell if the alignment.
Yeah, thank you. Thanks.
Yes, sir. I think maybe we can proceed with regard to the calcaneus now between this. Should that be okay? I think
yeah,
can we proceed with between the sinus tarsi and the extended lateral?
Yeah, I gotta. Let me just.
Go to the next session, sir.
Yep. Hang on one second. I just gotta close the other one. All right.
Professor, can share your next talk.
Yeah, it's there. Okay. So this talk is really about, when to use the sinus tarsi, when is it good, when is it bad in comparison with the extensile lateral approach. Again, the implants that you see, I've out of them, but it doesn't really have anything to do with the talk. So I think, in general, we all think that less aggressive approaches are good. We've all been trained now to try to use minimally invasive techniques. So it's very attractive to say that the STA, the sinus tarsi approach, is a good idea in many cases. Complications, as if you look at all of the very large series of the extensile lateral, there's no series over 300 patients without one amputation. So it's something to consider. This is one of the papers Weber showed. Now here's a comparison between the standard was the extensile lateral, the ELA, and the sinus tarsi approach.
So I would prefer to fix
fewer numbers of subtalar
either with a nail or a plate, but plate is more commonly used and more comfortable using it. So I would prefer
approach. There's some evidence that sort of
thank you, Mr. Modi. Yes.
Yes, my inclination would be to fix.
You can see the. Shorter operative times and basically an advantage across the board in soft tissue things, less wound complications, shorter hospital stay. What does concern me a little bit is the fact that there's a smaller amount of step off of the posterior facet tarsi compared to the extensile lateral. To me, that means someone's probably not doing the extensile lateral particularly well, because that gives you full and complete exposure, and you really should not be having a step off if you're using that approach. This is a comparison out of China, and you can see here that operative time favors the sinus tarsi approach, as does wound complications. This is a meta-analysis of a bunch of different papers, and I think this is probably true. However, you have to balance that with some really quality high-level surgeons who have not had 15 and 20% complications. So Roy Sanders in his career, 0.9% deep infection rate.
The 72-year-old gentleman who fell at home. He's a very fit gentleman. He does everything himself.
My own experience, and I'm
known diabetes is very well controlled.
I don't think I've done as many as
That's
Roy or
the X-ray
Steve, but I
there.
do a
So,
fair amount.
Mr. Pandey will start
I've
off
had
with
only
you.
one infection in an
What would
extended
you
lateral
consider,
approach.
sir?
I would say though that I'm probably far less aggressive
It's a
on patients who have
72-year-old
diabetes than
gentleman.
others are, so my rate is probably a little lower. This is my one case.
The
He's a heavy
fracture
smoker,
looks
but a really bad
a bit
injury,
impacted.
and I had to debride part of that posterior part of the
So
tuberosity.
obviously
He
I'll
ended
get
up
a
doing okay after that, but a true deep infection, my case. So I take this into account based on the fracture pattern, and I think this is like anything else. If you look, you don't just stick to one approach for anything because it doesn't make any sense anatomically or by time from injury. So the longer it is from injury, the more that's going to favor the extensile lateral approach over the sinus tarsi. I look at the joint comminution and in specific, the location of that comminution. Posterior and medial is very difficult to get through the sinus tarsi approach. Now I look at whether the lateral posterior facet is attached to the tuberosity.
CT to see
again, that makes it challenging through the sinus tarsi. So remember, the
purely
sinus tarsi
because the
approach, it's
fracture
really just a full circle back
looks
to
a
the
bit
palmar.
impacted
So it's a
to
short
me. So if
version of
everything
the
is
palmar approach that
impacted, just
paralleled the
we
perineal
could
tendons,
try non-optimal.
and I used early in my career, which is the same basic approach as the Coker approach, but it's more distal. So
And
when you
we
want to look
could always
anteriorly
do
at the
a
sinus tarsi region in the front of the joint, you pull the tendons posteriorly. There are occasions, and I'll show you an example, where you want to see the back, and when you have to see back here, you've got to pull the tendons anteriorly. So you have to do a little bit more of a dissection to get to that point. Now this is sort of a standard simple calcaneus fracture. And here you see the CAT scan. It's a Sanders 2B. And it's sort of a tongue type, but it isn't a full tongue, right? It ends just at the back of the apex of the tuberosity. So my positioning is the same for both approaches. The only difference being when I do the sinus tarsi, I don't elevate the tourniquet. I'm a non-tourniquet user. I don't use it for plateaus or plafons. The only case I still use a tourniquet for is an extended lateral approach to the calcaneus. Otherwise, I use no tourniquets in my OR. But I place it for this case in case I need it. But with more experience, I think I haven't. So here you can see both incisions drawn out. So you can see the sinus tarsi small approach and the extensile
working
lateral.
the maths.
So this is what it looks like for me.
This one, in my mind, never got into
You can see that extension
proper
at the
because
back.
this one
I would
is,
take that if I need to get to the back of the tendon.
I don't think ever going to do well. They don't like it.
Tarsi, this 2 centimeter, 3 centimeter incision is enough. Here's the perineal tendons. So you find the tendons, point. And here's the view that you get, which is quite good for the front of the joint. So this is the intact medial part of the posterior facet of the calcaneus. This is the anterolateral fragment of Langdon. And this is our impacted lateral portion of the facet. But you can see you don't have a lot of control over the tuberosity here, right? You can see the joint well, but your ability to reduce is definitely more difficult through this approach. So this is what we're seeing through the sinus tarsi approach.
When they roll round into various, they don't like.
Besides that. And this is what it looks like. So I say, okay, this looks pretty good. The one thing I'll say is that reducing the tuberosity is much easier through this approach because when you do the extended approach, you're pulling up on the flap, which is causing a lateral displacement of the tuberosity that you have to fight. With this approach, you're usually using a laminar spreader and pushing down and out, and that gets the tuberosity out of the way. So I don't do
I'm doing a hemiarthroplasty on this person, but I'm using a modular stem. So I'm using a stem that gives me the exit option of a reverse 5 or 10 years from now if I need it.
But to me, that
so I'm offering him, well,
so
always non-operative, you know, but I'm offering him surgery.
It looks reasonably good, but you have to be very cautious because if you go back to that view, you don't see the back half of the joint. It's very hard to lift that tissue up and see in there. So what I do is I get a Broden's view in the OR. And here you can see an example of one that this was well reduced in the front, but I was not anatomic in the back. And here you can see it. So that's just a Broden's view shooting to the back half of the facet. And I think it's very important to do this because if you don't, you're actually going to think you're reduced when you're not. So based on that, I did that little extension. I pulled the perineal tendons anteriorly so I could get a view of the back. And then this is what it was. And then this is where I ended up. So you can see a much different reduction on that view because now I've gotten around to the back to see the back corner. And then this is the fixation. So you see I fixed the joint first. And then we slide a pre-contoured plate in. There's a number of these on the market.
Have enough space for bone grafting at the proximal part. Do you not think it is too bulky in the metaphyseal area?
It's very important when you use these kinds of plates, you have to bend
It's a bulky one. This was the non-trauma one before the trauma stem came out in evolutus.
So you've got to bend that
this was a HA-coated top. So the HA-coat actually helps holding the tuberosity. You don't need to trim the tuberosity a bit to accommodate it there. The stem is slightly proud.
Cover up those tendons nicely, and then a multiple level closure of the incision. You can see this is sort of what it looks like, and it comes out pretty good. This is the finals on that particular patient, and this is his motion at 3.5 months. And I would say that this is atypical, but it's really not. They tend to get pretty good motion. Doesn't mean they're pain-free. Now, that doesn't mean I use it all the time. This was my last case. My last case was an extensile lateral, because that's what that patient needs approach. And this is a very old slide, so I've been using this approach for 25 years, but here's our peroneal tendons. There's the front of the Achilles. You want to be very posterior to avoid the blood supply. I also think it's important not to disrupt the abductor fascia. So stay on top of the fascia, keep that intact, because
just
it's a really protective layer over the area of skin that usually
you know what I mean? Bring it forward to me a little. But you can't sink this stem much more with the geometry of the fatness there.
One big flap. There's the lateral
yes, I agree. And that point about tuberosity pulling down, that's very, very commonly seen, because
pulling up on the flap,
we always have the tendency to pull it down rather than we don't pull it forward. We tend to pull it down. And that is one mistake I make when we do especially the infraspinatus fragment and the teres fragment. You need to get it wrapping around rather than pulling down.
I'm not sure why in that one article there were worse reductions to this approach. I have a hard time understanding that one thing. You want to make sure you look right at your rotation is correct. Now, as I said, this is an older case where we didn't have perimeter plates, so I used to buttress these laterally and superiorly to prevent the two displacements that occur. And then that's closed in a very careful way with multiple layer closure, always sewing from the edge to the middle. And this is what that particular patient looked like. Now, I'm going to show you just two cases. The one on the left is Roy Sanders' case. I showed these at the OTA a couple of years ago. The one on the right is mine. These were done within the same week. He did his in Tampa, and the patient happened to follow up with me.
This would require surgical intervention firstly.
What these look like at
if the patient is fit and
almost the exact same fracture pattern as you can see. So not a lot of difference in the pattern.
I'm looking at some
that Roy had in the OR. You can see mine through the sinus tarsi on the right. Both are well reduced, but this is what it looks like at 2.5 weeks. So you get a little darkness in the skin, and anyone that tells you that they don't get darkness in the skin at these incisions is lying to you, because it just, no matter what approach you do, you're stretching the skin and it gets a bit annoyed, right? But you can see that that's considered a wound complication on the left side.
Replacement. Now I need a bit
death. It's just a little bit of irritation. You need to leave the sutures in longer, but that patient will come out doing a little bit of scabbing occurring in that anterior area, which doesn't concern me because it's not infected. It's just a little bit of superficial irritation and a little bit of sort of superficial skin death. But at 2.5 weeks, Roy's patient was on narcotics Q6. My patient was on Tylenol and only took it for a week. So there's definitely a difference.
Nicely on your CTs, we always visualize the valgus
impact of 2.5 weeks of the extended approach.
Part that the head has come down, but the head has come down and tilted backwards. You can see that on your second image. So when you elevate that head, I'm not fixing this one, by the way, but if you are going to fix this one, when you elevate the head, it's not just pushing it up, but you also need to push it round from the back to allow that tuberosity to fit back into it. Can you go back one click?
And they have different benefits. So to me, I try to look at it and say the sinus tarsi has become my workhorse, but there are indications to do an extensile lateral. And what are those indications? Well, one is if the fracture doesn't have a good aspect of approach through the lateral wall. So when it's a tongue type or something that looks like this, or there's a lot of comminution edge, I find those fractures are better done through an extended lateral. And why is that? Well, it's because you can't really see, right? So if you look at this area, there is a tilt, and I'm going to rotate this image in a second, but if you're picturing that you're looking from the lateral side across, the medial side of that posterior facet is lower. It's not very visible. So if you look at it, this is a slope. You see that slope, and now you have to tilt the talus towards
on
it.
the reverse I do later, rather than sort of try and fix it or something like that. The reverse I do later will be more difficult, yes, maybe not as reproducible, but you might actually get reasonable function and pain relief. So it really depends on how medically unwell this patient is.
See how you have to tilt it to look at that back.
Patient is quite well, actually.
And it's
quite functional. Just a long
I think it's a lot easier to see that through the extensile lateral.
And I think the thoughts in my head was when he came that the head fragment is displaced. And as you say,
here's an example just of one that absolutely requires an extensile lateral approach. There's a 59-year-old woman who was referred in to me from an ankle sprain 8 weeks out. And you can very clearly see that there's overlap of the posterior facet of the calcaneus with the talus. Seems so this is actually a major calcaneal fracture dislocation that was missed by a referring emergency room. So here's the CAT scan, and you can see what that looks like. So there's a number of factors here that tell me this is clearly an extensile lateral approach. One, it's a late case. If I'm going to have to take stuff down all the way to the medial side and across in a late case, the extensile lateral is far advantageous to the sinus tarsi. Two, there's no break in the lateral wall. So when I look at this and say, how would I visualize this or get down to that fracture through the sinus tarsi, I don't see a pathway for that. So to me, this was an extensile lateral because this is what I would see through very helpful. So this went extensile, and here you can see that extensile approach, and here's the reduction, which I think is perfect, with a perimeter plate and lag fixation. I don't think I'd have been able to do that through the sinus.
A 72-year-old, it will be difficult, as Lee rightly said, quite a significant displacement.
A bit easier.
For all practical purposes, avascular. So in a 72-year-old, you probably want to do one surgery.
The posterior part of the joint, particularly if it's posteromedial, is fairly difficult.
It always sounds attractive, but in this one, the likelihood of that failing is very high.
Or a Coker than it does like an STA.
That's great. I would have gone for reverse itself, but just a question.
Yeah.
Posterior medial comminution. And if there's an
okay, last one, 4-year-old who's quite independent.
I'm happy to take any questions. Thanks very much.
Well, thank you so much. So that was extremely informative. So you actually laid out what can be done through the sinus tarsi and what should be done through the extended lateral. I think it's quite very clear to most of us who have been listening. Just that if there are any associated injuries along with the calcaneus, we're dealing only with the calcaneus now. Any associated injuries, like supposing there's also a pylon fracture to add on to it, or maybe a talus which is dislocated with the calcaneus.
Calca is reasonable.
I think those would probably be indications for an extended lateral.
Yes, so that would depend on what approach was going to be required for the rest of the fixation.
Because
I've had one case, it's rare.
tuberosity is a nice large
and for that reason, I actually did the sinus tarsi and extended
given the fashion these days, I will probably go for reverse because that'll be one operation in an 84-year-old. Mind you, reverse.
And did it through that approach. I've had very few combination calcaneuses and pylons in my career, but I've done them based on for the plafond injury, and then deciding whether I'm going to use separate or extended incisions to get to the calcaneus. So I think that those are fairly difficult problems that are, and I don't think the rule would be use one approach over the other. I think it would be to just carefully, as Dr. SCHATZKER has told us for years, carefully plan out what you're going to do before you do it.
Okay.
Versus do have significant complications.
Have to be doing it's an anterolateral comminution in the pylon, so I probably need an anterolateral plate there and also a calcaneus. So I think I don't know if the skin window between the two would be
sharp.
I don't make the anterolateral. I make my plafond incisions if I'm using an anteromedial direct.
This is not really a biology thing in terms of
so whether it's
blood supply to the head. This is a little bit of a biology thing with bone quality. If you have a look at the outlines of her shaft of her humerus, she's got
have,
little
I don't use tourniquets. I
pencils.
don't like to have
There's
one
not.
incision to bone. I like
She's
to have a
osteopenic,
layer.
isn't she? There's going to be a bone holding problem.
That there's intact tissue
So this is about
underneath it.
her really. If she
If I
wants,
had an
how she feels about one operation
I
or
would
two
probably
operations.
do almost
So
a
if she
direct
sits there and she says, "Yes, Lee, I want a good shoulder. I want my independence back as quickly as I can.
for the plafond.
I want one operation, and I like taking a little bit more risk."
For the calcaneus, because they wouldn't be connected.
Okay, great. Thanks. Thank you so much. Any other questions from the floor?
Thank you, sir. Can we go for
Nothing
Yeah,
from the
we will go for the next session, Dr.
She'll get a revert.
SCHATZKER.
Okay, thank you all
Thank
for
you,
having
thank
me.
you.
It's very nice to see everyone.
It's a pleasure.
Thank you,
Professor
alternator.
Okay.
Yeah. Next, we have the most awaited talk for the day by Professor Joseph SCHATZKER. He'll be speaking on history of
Amit discussed with the patient, and patient decided non-operative management. This is her x-rays at 10 weeks. And this is how she is post-op. I think she has done really well.
You can see
Amit, do you have any comments? How did you find it?
Well, I think some of this just results of the proper trials of use, right from non-operative to fixation to all the way to reverse arthroplasty, and they do just as well. I don't know what others' experience have been, but
which began with the AO, and this evening I have the opportunity to speak to you on the history of tibial plateau fractures and its treatment. I must take you back, and to some of you, this will be like a fairy tale, back to the days of smoke-filled lecture theaters, to the days of diazo blue text slides.
Brendan, if you were with us last week, you'd have seen me kind of quickly run through the Polaris 3 nailing system. This week, I want to take you through the kind of other side of that same system, which is the plates. Now, just one thing kind of before going with it is to remember that this system essentially uses the same instruments and screws as the nailing system. So the Polaris 3 isn't just plates or nails, it's a proper fixation system. So let me just switch to my demo camera, so hopefully we can see.
And what did we have available? We're now going back to 1970. Clinically, yes, we had ears and eyes and hands.
The Polaris 3 proximal humeral flap
on the history of the trauma and on the physical examination. And I was thrilled today to hear the physical examination emphasized, because it is so terribly important. Our imaging was extremely primitive. We had plain x-rays, AP, lateral, and obliques. We had examinations under anesthesia and stress views, arteriography, and the mini laparotomy. And
is the posterior tabs that are optional. Obviously, we do have the plates without as well, but these optional tabs are kind of a unique little feature. And they can either be used alongside the screws, so the blunt 4.3mm screws, which kind of lock into the plate. But if you don't want to use screws,
there was Charnley's book, and Campbell's Operative Orthopedics. And the 1960
sutures as well, just to kind of
given, had 1.5 pages on the principles of internal fixation. That tells you where internal and how rarely it was used. Well, we had the beginnings of the AO. We had the Techniques of Internal Fixation, a book published in 1965. It had few principles. Then came the first And then we had fracture classifications.
A lot of the same instrumentation that is there that you use for the nailing system. It's on kind of the same trays. So as I said last week, you've got the option of either a sharp drill or a blunt drill for these posterior screws, just to obviously try and protect the articulating surface on the kind of far side of the humeral head. You've got the radiolucent carbon fibre retractors on the set as well, which obviously, you know, trying to reduce the fracture and get the plate in the correct
collection of implants and screws of different manufacturers, different metals, and most did not fit nor have any specific indications. In North America in 1970, there was only the AO beginner set. We had no distractors. We had no specialized tools. For instance, became available when the life was very primitive. We have no bone substitute.
And
there were no bone banks. There were no allografts. Fracture tables were used mostly for fractured hips, as illustrated here. We had no translucent tables. It sounds like I'm painting a very primitive picture, but that was reality. We had only 2 plane X-rays and 2 plane tomography. What else did we have? Well, arteriography,
posterior tabs on
or in the angiography suite. We had no Doppler ultrasound.
Thank you very much, Brendan. So I think with this, we'll conclude this webinar. Thank you for attending, and apologies again for the sound issues and the streaming issues we've had. Have a good weekend. Bye.
Thanks, Lee.
No surface 3D reconstruction, no MRI. We had no intraoperative fluoroscopy. There was no CT. And if you wanted an intraoperative guidance, well, you had to take portable X-rays, which took a minimum of 5 minutes to arrive dripping wet in the operating room to be hung in the view box. What about surgical education? In North America, education was university-based, but students had to arrange their own curriculum. Few centers had courses in surgery, but none taught orthopedics. In Europe, there was no organized education, and every institution taught its concepts. Surgical education was based on mentor principle. What does that mean? You worked with a surgeon and you were taught my way of doing things. There were no principles. You were taught this is the way to do it. There was no standardized body of knowledge or agreed curriculum, and qualifications varied widely. What did we have to support? There was no fax, there was no iPhone, there was no iPad, and there was no Professor Googles. Our cameras, 35 millimeter, took days to be developed and printed. Making slides was unbelievably primitive. First, you had to get it typed, then it had to go to a photographer, and you didn't get it till days later. What about the transfer of images? It didn't exist. What about research? Well, we didn't have databases. All of us made primitive attempts at databases, which consisted of large sheets of paper glued together, which we would spread out on the floor of a room, and we would gradually cover that with columns. There were no agreed classification systems to make studies possible. Authors, concepts. There was no evidence-based medicine. the decision making had not yet been retrospective. And when you came to study, there was invariably a large loss of cases from study for review. And in those days, there was no such thing. That was my reality. Those were the days where I began my training in traumatology. In 1974, today, on a history of its treatment. This classification was based on a retrospective analysis of cases which were treated in the Toronto teaching hospitals between the years of 1968 and 1972. It was based on a chart review and an X-ray review, and my attempts to form a database, because as I told you, that didn't exist. So what did we do? What did I do? I lumped like with like. I examined carefully what I had, what was clinically valid, and what were clinically valid conclusions. And in those days, there was no such thing as a concept of interpersonal or intrapersonal agreement. There were really no guiding principles to any classification, and most classifications available represented the author's concept. And so is my classification, which I'm proud to say has survived since its publication in 1974. What did I base it on? Well, I noted organized based on the age, similarly based on the morphology of the fracture, based on bone quality, and based on the amount of energy involved. And I had the insight to state that the indication for surgery was instability and not just the degree of joint depression. Every 1 millimeters of joint depression indicated surgery. The early AO principles, you all know them, but I would like to bring to your attention the first, namely, it was immediate surgery before swelling developed. It was based on the concept that the swelling was the result of hematoma, and if you would let out the hematoma, the soft tissues would now be slack and everything would be fine. Well, this immediate surgery had its What did we? Everything was planned in 2 dimensions. We did not have any 3-dimensional imaging. And the patient positioning, it was almost always supine on the operating table. You looked at things from in front. Intubation didn't exist, and you couldn't get a patient in the prone position because the anesthetist would not be able to ventilate the patient. And when it came to X-ray, we didn't have such a thing as a translucent table. So here we see the 4 views that we had to work with. This, as you can see, 1978. We had stress under anesthesia. And I can tell you that it provided a great deal of information, because here you see in the middle, stress was applied, and to your right, you now see the displacement, and you can see the amount of information that this simple examination and X-ray provided. Remember, we had nothing else. So we are faced with two-dimensional images, and now how do we arrive at a three-dimensional concept? Well, we all spoke of three-dimensional thinking. And really, to become an orthopedic surgeon, you had to have the ability to project things in the third dimension because it didn't exist. Only at the time of surgery could the surgeon, for the first time, gain a three-dimensional appreciation of the injury. And at that point, it was far too late to correct mistakes in surgical approach. The surgical approaches, here I am illustrating for you the three approaches in the manual in 1970. The lateral curved oblique approach, the L-shaped approach, and the horrible Mercedes three flaps elevated, again an anterior approach, the most comprehensive approach to the proximal tibia. We had no other approach. This is what you gained from an anterior approach, and this was an approach which I actually published and used for a period of time. Which I didn't like because oftentimes the back wall of the tibia was broken and you wouldn't be able to fix it. But if the anterior tibial tubercle was attached to the tibia, dividing the infrapatellar tendon in a Z fashion allowed you, as depicted on the schematic diagram, a full overview of what you were dealing with, all from in front. There was no posteromedial or posterolateral approach, and never posterior. That was called the tiger country. Well, how did we do? Well, we didn't do that badly. And on the imaging of what we were dealing with, it was the first time that we had an axial cut, a transverse cut through the fracture. Because the sagittal and a coronal view is the AP and the lateral. But a transverse was unthinkable. It didn't exist. And many fractures in the frontal coronal plane were missed because we did not have the axial cut. We didn't have the surface anatomy reconstruction, which is possible to view the surface anatomy. And the CT allowed us for the first time to establish certain things. It allowed us to establish the direction of the principal fracture plane. Articular fractures are the results of shear and compression, and the principal fracture plane is the plane of the shearing force. I'll come to that because this is very important. It also allowed us for the first time to determine where we need to position the buttress plate, because the buttress plate is positioned parallel to the fracture, to the principal fracture plane. These two are parallel. So for the first time, we could determine accurately where we wanted to position the buttress plate. And that, as you will see in a moment, has its importance. The axial cut was also of tremendous importance because it was for the first time that we could graphically see in front of our eyes what was anterior and what was posterior. And this tibial plateau fracture, a type 2 lateral, is posterior. And if you approached it through the standard anterior approach, you would have approached an intact tibia and you would not be able to do anything. So this is for the first time where we can accurately localize the injury, and from this, unbelievably important for preoperative planning. I have had the honor and pleasure to work the last few years with a colleague of mine who originally comes from Brazil, Mauricio Furi. And Mauricio asked me one day, Joe, how can we tell people exactly where the lesion is? In your classification, you have 6 principal types. You have just illustrated how important it is to be able to localize where the injury is. But how do we tell people that this is now a type 2 posterior? And this rather simple question was a major stimulus and led to a great deal of research activity, and I believe a number of discoveries which we made, which I would like to share with you. We looked at over 100 CT studies of tibial plateau fractures, first to validate my classification, the 6 principal types. We noted the immense value of the CT in making the diagnosis, proximal tibia. Mauricio is the first to provide bony landmarks to the division of what is in front and what is behind, with the concept of the virtual equator, which I will demonstrate in a moment. And for the first time, based on anatomical landmarks, we have been able to divide into 4 quadrants with defined limits of exposure. What do I mean by all of these things? Mauricio defined the virtual equator. It begins on the lateral side, the anterior tubercle, the attachment, fibular attachment of the lateral collateral ligament, and it goes over to the medial side and the posterior edge of the superficial medial collateral ligament. These are points that you can identify on every axial cut, whether it is a CT or an MRI, and this equator divides the tibia into a large anterior and a much smaller posterior, not half, but part. But it allows us, if we now take the equator, and if we take the medial edge of the tibial tubercle and the foot plate of the posterior cruciate, and if we draw a line, we now have perfect definition of the 4 quadrants limited in the surgical approach by the collateral ligaments. And this is terribly important to keep in mind if you are planning a surgical approach and the procedure. There has also been a major progress in our concept. We noted in the survey of over 100 of these tibial plateau fractures that what was most important was to achieve articular congruity and a straight leg in that order. Keep in mind the AO dictum of anatomic reduction. It emphasized articular congruity. It did not emphasize stability. We next asked what I believe to be really the most fundamental question in traumatology. What defines joint stability? Well, yes, we know that we have collateral ligaments, we have soft tissue envelope, which provides stability. The collateral ligaments static, the anterior and posterior dynamic. Clearly, stability depends on the alignment of the restoring the normal joint axis. If you allow a deformity persist, this leads to joint overload. In a sense, this defines instability in a frontal plane, but it doesn't answer the question. The question is, in an articular fracture, what determines joint stability? Yes, ligamentous and capsular attachment. But what about the fracture itself? Is there a difference between articular surface impaction and a split wedge rim lesion? What am I suggesting to you? We're seeing here three principal types of articular injuries. You have a pure joint impaction. The peripheral rim remains intact. At the bottom, you have the typical split wedge fragment, which is sheared off, and you may also have impaction of the joint rim, which is really a split wedge, and I will illustrate for you in a moment. And it is our belief that the key fragment that governs joint stability is the split wedge fragment. It is made up of the rim of the fragment and its metaphysis to the point it exits. So you have a three-dimensional structure, the split wedge, which is sheared from the tibial plateau, and split wedge fragment, whether it is anteriorly, anterolateral, posterolateral, anteromedial, or posteromedial. This is really the key fragment to identify in preoperative planning, because this is the key. All of you have experienced this. The split wedge fragment has a sweet point. If you press there with your thumb or finger, this split wedge, as long as there is no impacted bone in a fracture, will reduce. And as that reduces, so does the stability of the joint. And please note that the split wedge is the principal fracture plane, is the shearing plane that splits the split wedge. And so is the key to joint stability. We now have an answer to the question which Maurizio posed. How do we tell the surgeon where the lesion is, the key lesion important for joint stability? If we now look at this fracture of the lateral tibial plateau, a typical type 2, if it is comminuted, it has another split wedge, and that split wedge is posterior. And that posterior split wedge has to be addressed surgically in order to restore the joint stability and not only the anterior anterolateral component of the fracture. So we now have a type 2 anterior and posterior. Just to remind you of what we mean by a split wedge. Here we have a type 5, a bicondylar fracture. There is a fragment posteromedially, but on the lateral side, there is an anterolateral fragment and a posterolateral fragment. So we now have a type 2 medial posterior, lateral, anterior, and posterior. We are now beginning to isolate with great precision of where the fragment is that is responsible for joint stability. And if you think for a moment on the superb lecture that we listened to on the distal radius, if you apply this split wedge to the distal radius, if there is a dorsal split wedge, that is the key to the joint instability, not the volar fragment. And if you just reduce the volar fragment, the carpus remains unstable and subluxes dorsally. So you have to look at the key of where the key is to joint instability. So what have we contributed? Well, we have provided new anatomical landmarks for the proximal tibia. We have provided the concept of the virtual equator and the 4 quadrants defining exposure. And I will repeat, the wedge fracture, the split wedge, is a rim lesion, and that is the key to joint instability. As long as it remains displaced, the joint remains unstable. Our new contribution has allowed us to extend the original classification into 3-dimension, because we now can provide with new notations the fracture morphology in 3 dimensions. And where is the emphasis? Well, the emphasis is identifying where the split wedge fragments are, because they are the key to joint stability. The extended classification allows us now to speak with one language, and it allow and facilitate multi-center studies and research. It will facilitate the planning and the execution of what must be done in order to achieve a stable joint. First and foremost, in doing articular fracture reconstruction, we must restore joint stability. I don't mean to knock articular congruity. That is unquestionably important, but for the late survival of the joint, if you leave the joint unstable, it will, for us, are a stable joint, a congruous articulation if possible, and a straight limb. And these, if you achieve, you will greatly facilitate and achieve a far better outcome for the patient. And so, in conclusion, I would remind you that I gave you a glimpse of the dark ages when I began my career as a trauma surgeon. I spoke to you about the history of the tibial plateau surgery and its struggles, where we began. I hope you were able to follow the steps we took in order to achieve today's level of expertise. And in some way, I have been able to give you a preview of what is to come in the future. If you remember that the most important element in planning an articular reconstruction is to ask the question, what is the essence, what is the key to joint instability? Where is the split wedge fragment? And begin to plan your reconstruction with that in mind. And with this, I thank you for the opportunity to speak to you today. It's evening where you are. It is just mid-morning. And I thank you very much for the opportunity of speaking to you, as well as to seeing some of my old friends and be able to say hello to them. Thank you very much. Yeah, go.
Thank you, Professor SCHATZKER. It was an amazing lecture. One of the best we have heard in the recent past. We really, this lecture, right from womb to tomb, it looks like that. It's been one of the most wonderful lectures we've all heard. And on behalf of the Bangalore Orthopedic Society, we deeply appreciate this and we thank you immensely for having joined us with all these things. We thank you very much, sir. We keep in touch with you again. Thank you, sir.
Thank you all. Thank you.
Now would Dr. Uday Kumar will do the vote of thanks. Thank you, Professor SCHATZKER.
Thank you very much.
Have you shut it off? Have you shut off? Thank you very much for the excellent program we have had, the Bangalore Orthopedic Society Annual Conference 2021. We thank all the speakers who have taken part. And just to make a few announcements, the best e-poster award goes to Surgical Management of Occipito-Atlanto-Axial Complex Injury in a 9-month-old infant by Dr. Balamurugan T. And the best paper award goes to Dr. Vikas Kuntwad, who has presented arthroscopic lateral J with re-implicage as an effective procedure in converting off-track lesions to on-track lesions. Vikas from Manipal Hospital. So this is the final part. And coming to the vote of thanks, we thank all the sponsors right from Alembic, Mr. Vishnu, Off-Trit, Mr. Nitin. We thank Arthrex, Mr. Santosh, and the other Microsoft Micro Labs for the audio-visual. We thank the BYGT Brewery for arranging a beautiful venue where we could take part both in a physical as well as in a virtual meeting. We thank the audio-visual, all the people who have helped us to make this program a grand success. If I have missed out anyone, please excuse me. Thank you very much. Very kind of you.
Thank you, everybody. We are going to end the meet now. Good night.